And welcome everybody. I hope you had a good rest. Okay, so we are about to start. So, and I will just make few announcements. And one is that today we are having lunch here at the first floor. So there is a hall here. The hall is called Iris. So that's where we are going to have lunch today, not the 18th floor. So we'll have lunch at the first floor. So for today and tomorrow. So, and our team has prepared a card with pickup information. So those traveling back to the airport, so please, during coffee break and lunchtime, you can approach the team there. So, and they will share the information with you, the time they will pick you and where they will be picking you on that. Okay, so yeah, so now we'll go to the sessions and we'll continue with the session of yesterday. So, and the group work on nutrition and planning. So, and Annabelle will share information about it. Okay, thank you.
There we go. Okay, good morning, everybody. So yesterday you heard about the recommendations. Now, if you all of you have the printed recommendations on your table. Now, what we would like to do is for you to discuss what are the key steps needed to adopt these new recommendations on TB and undernutrition. Some of the recommendations you're already doing, but just if you could look at those recommendations and think, what are the key steps? And we've just listed suggested areas of focus to discuss. So, you know, stakeholder coordination, how are you going to work out who does what, planning and resource mobilization, who's paying for it, policies and norms and standards, what you'll need to put in place, and implementation, the HR, again, who does what? Is it an outside organization? Is it the department in charge of nutrition in the ministry? And equipment, facilities, what needs to be, what equipment is missing, food supplies, money, what are you going to be, which models are you going to be looking at? Infrastructure, maybe, you know, you need to think about infrastructure for storage if you're going to be going that way, logistics and delivery, etc. And monitoring and evaluation, of course, recording and reporting. So it would be great if you could discuss that. And I think that's all. And these are the distribution of the different CSOs according to the countries. Okay, has anybody got any questions? Good. So shall I leave that up? Yep, so that you can look through the list and then you can discuss amongst yourselves. Thank you very much.
So, good morning. Just like yesterday, kindly go to your group's respective teams, and we'll have 40 minutes for that before we go back to plenary. Country.
Oh, anybody from online?
Hello. Yeah, I can't hear anything from the meeting either.
Okay, we are doing the group work now.
Okay.
Hello?
Hello.
not this one, but the confidence is good. But that's the thing, that's a good thing because
Hello, online team. Can anybody speak from the online team?
Yes, good morning. Can you hear us? Can you hear?
Yeah, I can hear you.
Okay, good. Thank you.
Yeah, so now we have solved it. So we are doing the group work.
Okay,
Yeah, so and I already explained it in the chat. So
okay,
we are going to join the Myanmar team. So anybody
okay,
from Myanmar to lead the group work?
okay. Thank you.
Yeah, so you can, anybody from the Myanmar team?
Yes, only WHO staff are joined from the Myanmar team, and I will contact the colleagues from the NDP to lead the crew and we're applying you in the chapel. Yes.
Yes, you can lead the group work and have a discussion, and you will have the opportunity to has about 2 minutes to report about all the activities. So,
Yeah.
and the information is based on the slide that we have shared for the group work.
Well, where's the slide you share by email?
No, the slides are shared on the screen. Did you see the slide on the screen or not yet?
No, we can see the screen on.
You can see the screen, so I will just tell them to share the slide on the screen now. So I will just maybe see if I can share the slide.
Yeah, they will, but they have to do it. It's not us.
So are you seeing the slides?
Yes.
Yeah, so this is the information for the group work. Hmm. Okay, so maybe you can start, so and we'll let you know when to come back.
But I will, it's good to have you.
Okay, maybe we can start now the country discussions. So we will keep this projected as all of you speak respectively for your own countries. But in the interest of time, can we ask you to focus only on 3 major areas? And if you choose implementation, just choose 1 or 2. Is that clear? So you don't have to go through everything. So what you think you can share among the major bullets, then you just choose 3. Okay? Who would like to volunteer to go first? I don't see any hand, so may I call on who is ready? I think Lao. Sorry, are you volunteering? Okay, Vietnam is volunteering first, and then Lao PDR.
Yes, thank you. This also the new areas for Vietnam TV programs, and now we try to provide something to do about this. So in our group discussions, the first thing we want to do about the new tourism for TV patients, that we have to develop a strategic plans. We integrate the new tourism for TV patient into our NSP. Then maybe we because Vietnam is a limited resource country, so in our planning we divide in 3 states. We cannot provide the nutrition for all the TBK. So the first stage we focus on the MDR TBK and severe undernutrition TB patients. And then we gradually to extend to the other TBs and the household contact later. Then of course, the resources is very important. We now mostly based on the international donor funding. So in the coming time, we will try to mobilize the resources from the national and the local authorizations, authorities in Vietnam. And to do this, to provide the additional nutrition for TBKs, we need to mobilize the civil societies, the other organizations, local organizations who support TB to assess all the TB, MDR, TBK to provide them the additional nutrition. And so far, for Vietnam, we from the Ministry of Health, we already have the policy to assess the nutrition condition of the case, but only the case who get treatment in the hospital. So for the NTP, we will extend this activity to the case to get the treatment in the community. That means the outpatients. We will provide them the additional nutrition. So we need to advocate with the government and the ministries of health to do the assessment, not only to do the assessment for the nutrition, not only for the case in the hospital, but outpatient case, we also need that policy. So when we have the policy from the government and the MOS to allow us to do this area, so after that we will implement the nutrition provide for all the TBK in the hospital and also in the community. So that's all from our group. Thank you.
Thank you, Vietnam team. Can we call Dr. Sakon or Nepal and Lao PDR together? Okay.
Thank you. Today I'm going to present for Nepal and Lao together because we sit on the same table. So definitely this food program is very important for treatment of the tuberculosis patient because they are thin, lean, and nutritional deficient. So definitely we need some coordinations before starting anything. And we need multi-sectoral approach, like the approach from the Ministry of Finance, Ministry of Health, and then World Food Program, UNICEF, and WHO, and we should also involve some civil societies, and we should have coordinations or committee formations for the coordinations, like we can have a regular meeting and policy planning about how the food program will be mobilized and given to the patients, policy norms and standards. And for implementations, we need the manpower definitely, but manpower should be capacity builded, like they need the training, how they can provide the food to the patients, and equipment for nutrition assessment, like we need some weight measure machines, like height measuring tapes or something, maybe that needed. And food supplies versus money, like Lao supports food supplies, and in my concept, I think better is to give the bank transfer of the money, because if you supply the food, we need the infrastructure actually to store it, maybe temperature control needed, maybe electricity needed at every place, which is not possible. So my opinion, we can just give to the bank transfer of the money. And also logistic, if you supply the food, like Lao thinking that they can supply the food, so you need the logistic management team how to supply the procure food to the periphery at the treatment center level. And monitoring definitely is very important, like if you give them money, whether they have used it for a nutrition, to buy the nutrition, or to buy the alcohol or something. So definitely it's needed. Also, even you supply the food baskets, you have to take good care that the food basket goes to the patient, not to the other person. So monitoring has a very important role. And evaluations and research, definitely we have to do what is the changes after food supply to the treatment success rate or something like that. So that's all from Nepal and Lao.
Thank you. Thank you very much, Nepal and Lao. We learned a lot. So he focused on stakeholder coordination, the importance of planning and sitting together and talking about the how to get the food to the patients. And also you talked about implementation, the need for human resource, the need for storage in case it's food supplies, but you prefer bank transfer to do away with all the logistic and the infrastructure. And also agree with you on the monitoring, how to make sure that the support really goes to the patients. Thank you. So, Annabelle, you have any? Okay. Next, Cambodia.
Good morning, everyone. On behalf of the Cambodia team, especially the NDP, I'd like to share about our step, to be taken as an. So the first step that we will do is about conducting a stakeholder mapping. This is very, very important, So that's why we will include Ministry of Planning, Ministry of Economic and Finance, Ministry of Social Affairs, Ministry of Health itself, Ministry of Interior or Home Affairs, and development partner, WHO, World Food Program, private sector, especially the CSO and community affected by TB, including their family. I think this is very, very important to ensure that who should be involved in this particular, step. After that, Cambodia, especially the NDP, we have international interconnecting committee for TB control, and this working group is really focused on technical aspect. And then we will revisit the the scope, how to expand or how to include other sectors as well, like I said earlier. So, and after that, right now Cambodia is also implementing or running the MAF-TB, multi-sectoral accountability framework for TB response. So we use that platform to ensure that the nutrition, will be covered. After that, for the immediate action, this is very, very important as well. The NDP, when this come back, we will discuss internally to consider, the formulation of the national TB nutrient guideline or SOP, and this is very, very important to ensure that the TB and nutrition, will be existed after the meeting. And Cambodia right now, we just conducted the national TB legal environment scorecard. And then one recommendation is about to develop or to produce a national TB law. I think this is on the radar as well, how the nutrition, would be included in the national TB law. So this is very important to move in the future. In terms of the implementation, the NTP itself will provide training, specific training, or how to say, the training really focus on nutrition to TB's provider. And then in terms of equipment, the NTP will ensure the availability of the scale and the head measurement at point of TB disease, meaning that TB provider, can use those equipment to measure their client. For the food support, right now the Cambodia is running the social protection services, for example, like equity card or ID card, have palliative funds. So we will ensure the implementation will be included TB people affected by TB or expand the implementation. If the TB patient or people affected by TB already had the ID card or ID pool, we will ensure, for example, like producing the IEC material to ensure that they understand and they use, or utilize those card. And then in terms of M&E, right now we are running TBMIS nationwide. So we will include or we will add new module on nutrition, and then by adding a specific, indicator on nutrition. So I think these are the key steps that Cambodia will take forward. Thanks.
Thank you. Thank you. I think you have addressed all the basic requirement to start with. First is the stakeholders meeting. That's very important, and you have to multiple of them. And then what really was very clear in your planning scheme of things is that you are saying that you will keep the community also at the planning stages, because that's very important. Because if you are going to give food basket, it has to be acceptable to the community, right? You can't tailor-made or geographic specific. And what you said, there's an existing mechanism there for vulnerable populations, so that you just have to advocate, document, and present it to the ministry. I mean, both the ministry have to agree to it, Ministry of Finance plus Ministry of Health. So that coordination meeting, that advocacy, you have to, that policy document, the evidence that I think is there in the recommendation also, that has to be advocated well, that how it can improve the treatment outcomes, and it has a bearing on the TB mortality as well, if we do that. And good thing is that you already have a system of, as I understand, that you have some mechanism of giving nutrition to some vulnerable population, if I understood correctly. Okay, so if that can be, just modify and given it to the TB patients, yeah, and again, it has to be very clearly articulated in your strategy document of the implementation part. That component has to be very well articulated. How it will how it will improve in long runs, the impact on the incidence also, if we take care of the malnutrition part of the whole country. Thank you. Thank you.
Can we hear from the next country? Indonesia, Thailand. Thailand first.
Thank you for Thailand. As you may know, that our National Health Security Office that provide insurance for Thai people, they have the principle that they will not pay directly to the patient. They have to pay to the hospital only. So until now, if the TB patient is very malnutrition and has been admitted, there's no problem for them, because the hospital will take care of it, and we have the nutritionist in our hospital already. So the nutritionist in the hospital will be taking care of the IPD TB patient already. But now if we have to do more to the others TB, if they are not IPD, the coordination between stakeholders should be important. I'm thinking about the local administrative office since Thailand now is in the process of decentralized healthcare to the local administrative office. Until now, we decentralize the primary care from the MOPH to the local for more than 30 or 40% already. So they will be the stakeholder and the main stakeholder to take care of the primary care, especially for the nutrition of the patient. We also have in the provincial level, we have the Red Cross in the provincial level. We have the Social Development and Human Security Office of the provincial level. We also have a lot of CSO in the provincial level. But one of the challenging is the stigma. When we give the TB into outside of the MOPH, then the stigma problem will become. This is one of challenging that China is going to challenge that. And for the planning and resource mobilization, I have to share some of the pilot area in Thailand that some local administrative office already do some for the TB patient, not only TB patient, but malnutrition patient. Example, some elderly, they have the land and then they're raising the laying hens by the local administrative office, and then they give the eggs and crops and many things to the poor in their area with their budget. So just put TB patient into their hands, and then they can give them the food directly by the local, not by the hospital. And also some hospital, because we have the meals for all IPD patients in the hospital already, we provide them for free. Some hospital provide free food for the TB patient. Just OPD patient, OPD case, but they can come for food. So some hospital already provide this, and this is only in some pilot area because it's quite sensitive and maybe some transport system from the house of the patient to the hospital as well. For the implementation, I think it's not the major problem in Thailand because we can assess the nutrition by the hospital because all TB patients come to hospital for treatment. And the food supply is okay in Thailand, but money, we try to do the conditional cash transfer like Indonesia. Yesterday, we talked about that. But we discontinue that project because we have problem with how to monitor and evaluation, like you said yesterday. So we're not sure that if we push money directly to the patient, they will go for food or not. So we don't use the conditional cash transfer. And so now for the M&EO research, we will do the cost effectiveness analysis to make sure that some pilot area, which many way to do, especially for the local office, should be one of the most effective way in Thailand. Thank you.
Thank you. So as I understand, currently it is for the inpatients that's there, and you are working towards all the TB patient outside, who was on domiciliary treatment. You also have that there is an existing social development department which you can work with. One important thing what you talked about was the stigma. How we dealt with it, that basically there's a positive spin-off when you do it at a scale where the stakeholders, communities, you have to take them in the confidence, and when they do it, then there is a dent on stigma as well, because it has to be mainstream. And again, the TB survivor networks or TB affected communities, if they are also part of the whole planning, that's how we did it. Then I think the ownership or the uptake from the government also will help, because if program only pushes it, yes, because every government has to see that they have enough resources for this. So there are two models in India. You can also, and again, what you said, that how to monitor it. Again, involving the communities, TB affected communities play a big role in advocacy for the policymakers, plus the implementation and monitoring part. So that can be that can be deliberated by the NTP program. Yes, for this, what we have done that we took when we started our DBT program, that benefit transfer in 2018, there was a lot of advocacy to the finance ministry that this is required, so the resource was allocated, so we are able to give that money to all TB patients, irrespective of IPD or domiciliary treatment. So that's again, so the corporates or volunteers or civil society organization can help, but it is the NTPs who have to push for it, because it's really proven that when you, in addition to the treatment, the nutritional support definitely increases the treatment outcomes, and the mortality also goes down with this. So those are the suggestions, but I think you have to work in your your system. So every country would have to do it in their own way, but the basic thing what we agreed, that it has to be done, that nutritional support will definitely help. In fact, what we are doing is we are adding energy dense nutrition supplement also. So that is also one of the recommendations. And now, since somebody has got TB, I mean, the people around or the family members definitely need that support. So that advocacy every country has to do with their Ministry of Health, plus the line ministries like Department of Finance, plus Social Security Department. So it has to be a multi-ministry debate. First, I mean, the case has to be presented in a way that Ministry of Health approves it, then then the intersectoral meetings and agreement or MOUs with different line ministries. It will take whole of government's approach. Only the NTP program just can't do it. I mean, you have to follow the whole of government's approach. I think every country has done it when COVID happened. All the departments came together for one cause, and TB is a national emergency. So we have to advocate in the same way, that all the possible resources which are there which can be leveraged, should be leveraged. So if that comes in the policy document, the proposal, then I think there'll be ownership from the government as well. Thank you.
Thank you. Good morning, everyone. I will be presenting for Indonesia. So we will be highlighting three important points from Indonesia. The first one is the stakeholders. Before that, in our presidential decree on TB, we already have policy. Oh, louder, sorry. In our presidential decree on TB, we already have, it's already stated about the nutritional fulfillment and also collaboration for the multisectoral. So based on that, we try to identify which stakeholders that might be related to the nutritional plan in Indonesia. So we have this mechanism called pentahelix. So it consists of 5 core in the community. The first one is government, and then academics, private sector, community, and media. So our team tried to identify for the government, it will be involving Ministry of National and for Human Development and Culture, Ministry of Finance, Ministry of Health, Ministry of Village and Development of Disadvantaged Region and Transmigration, Ministry of Internal Affairs, National Development and Planning Bureau, State Secretariat, and National Nutrition Agency. And for academics, we think to involve all professional organizations and private sectors. We involve private and government corporates along with the philanthropists. And for the community and development partners, we will involve all NGOs, UN agency, and also patient organizations. We have 26 patient organizations in Indonesia, and also media to amp up the collaboration in the stakeholders. And in subnational level, all the provincial and district government. The second point is for the planning and resource mobilization on also the policy and standards. Actually, in Indonesia, we already have initial coordination meeting with the related stakeholders. And right now we are on the developing policy brief for the nutritional plans. And the next step will be developing guidelines on this. And our team thinking there might be the next step probably to have resource mobilization from related stakeholder, but it's on the district level, and utilize the multi-sector forum and the TB elimination acceleration team that already existed at the all district level. The last one is for the implementation. In Indonesia, we currently have this free meals program for students that's provided by the central government. And our team think that we can piggyback or some kind of adopting this mechanism for TB patients. So we think probably there's a potential to give food coupon for patients, regardless of the nutritional level or the financial status. So all can claim these meals, and propose to have a collaboration with selected local SME, a small micro enterprise like small restaurants. So this can be a potential to empowering locals community, and the coupon can be then claimed to the district governments. I think that's all from Indonesia. Thank you.
Thank you. Thank you. I think you have ticked all the boxes, and I think as I'm aware that it has been you're very close to policy making policy brief, and it all is possible because I think the top leadership has taken the ownership of fighting TB. That really helps countries. I mean, if we have political high political commitment, definitely that helps in coordinating those meetings with the line ministries, because the commitment is from the top. So that really helps. And I think what the group which you have made for the stakeholders is I think very very comprehensive. Very important thing what you have kept media as one of your stakeholders. They are, we have to use that in getting the nuances, getting the science of nutrition in TB control, elimination, TB ending TB epidemic. The role of nutrition is very important. So proactively, if we keep media on our side, so that also really helps. And you have already made, and you are ready, what you said, that you have made a policy brief. Our 2 points, my 2 cents would be that it should very clearly articulate the resources, how they implement it. That's where the longest discussion happens, how we are going. So there are two mechanisms, either a food basket or through cash incentive direct to the bank. Both have their own advantages and disadvantages, so you have to just think over that. And the policy brief, as I've been saying since morning, it should be the advocacy should be so strong that this is one intervention in addition to treatment is very critical to ending TB in every geography. And last thing, what you said, to piggy bank on existing system, keep it as a addendum. I mean, if we articulate in the policy existing system and getting TB connected with this has its own issue. Yes, if it is there, it has a positive spin-off. Yes, but just keep it at that. Suggestion would be that, because if you try to expand the existing food distribution system, that may dilute your advocacy for special food package, special food nutrition support to TB patients and their families. So existing system will have their positive spin-off. Let them be. If you include this, I mean, it may complicate things. So this is what our experience is, that we also have a national nutrition mission. So that is already doing their bit. They are identified the vulnerable population, not for TB, all the vulnerable population, and giving the kits. So that will have its positive spin-off. But as NTP, I think we should be very, very articulate in pointing out the critical role of nutritional support in the whole effort of ending TB. Thank you.
Thank you. This is the group work on steps for uptake of recommendation by Bangladesh, adopt new recommendation on TB and undernutrition. Already we discussed about the stakeholder by others, and here the Minister of Health and Family Welfare, coordination with the Minister of Social Welfare, Minister of Finance, Minister of Women and Children, Minister of Labor, Minister of Home, and others ministry. We can make a coordination meeting and to involve our donor NGO and civil society and others that like WHO, the Global Fund, UNICEF, the World Food Program, civil society, our FBCCI and BEGMA. All are involved in as a stakeholder and make a good decisions. And our planning and resources based on the four pillar of food security, food utilization, food stability, food availability, and food access. So our planning and resource are on priority based. First, we make emphasis on MDR, then children, pregnant women, and then drug sensitive tuberculosis, and on the household basis program. And this our planning and resource is agreeing on malnutrition causes leads to design joint actions. The determinants of malnutrition and multi-sectoral approach. Here, food intake, access to food, health, care, water and sanitation, and gender are the main topics. And our implementation at the national level, our NTP program manager, deputy program manager, and national nutritional services are involved to make decision. And at the district level, our civil surgeon and superintendent of district hospital are involved. And below the district level or sub-district level, our Upajala, there are Upajala Health and Family Planning Officer. And at the community level, we have health inspector and community healthcare provider. So at the up to the community, we can make a good infrastructure to make it possible. Equipments for nutritional assessment, we assess the BMI, assess the comorbidity, and make a plan for it. And food supply versus money, we give it to the local authority, and the local authority decided whether they give the money or the food coupon. It can be distributed by civil surgeon office or the superintendent of district hospital or community healthcare provider. And this is the our total infrastructure. We may make a national policy and national nutritional policy that and jointly we makes all together. Thank you. Thank you all.
Thank you. I think you are very clear in your plan how to implement it. The only suggestion, if resources, we understand that, but since we give recommendation, if resources allow, I mean, ideal would be to not stagger it from MDR children to all TB patients, because if resources allow, that's the only suggestion, if resources allow. And as per the food basket, great that, I mean, that's what I said. I think you are very clear in your plan of things. And at some point, if possible, include the families of the TB patients. What you said, that's very, very important, that option is given to the local level implementers if food basket is the choice, because our experience in India, it's a huge country, and you can't have one kind of food basket for, say, North Indian states or Southern states. So that has to be that you have already factored in. So I think congratulations to you that you have understood and you are very, very clear, and you have all the relevant stakeholders in your committee, whoever decides, and the NTP is very clear that who all needs to be on board to finally implementing it on the ground. So congratulations to Bangladesh.
Thank you. PNG, The nutrition coverage is mainly main activities happening around the children, for the children. PNG studies have shown that the children have high malnutrition. So the government more like committed under the World Bank to support the children in the nutrition. But for TB program, from the government side, we have no support. Under the Global Fund grant, we try to support the TB patients with the nutrition, and I think we're focusing at the moment for the MDR cases, where we give them food vouchers, so they take it to the shop and then get what they need. And it's just for MDR patients, but otherwise, well, for the other patients, we don't support them. And for the Hemini now, we have done reviewed our tools, and we've included risk factors for TB, and the nutrition is one of them. So from there, we will see how much of our patients are affected by nutrition, and maybe we may go from there. But at the moment, we are just concentrating on the MDR patients only. Thank you.
Thank you. We understand that the concept is very, very clear, but then the advocacy from the NTP side to government would need some work there. But I think we have learned from all the other countries what stage they are in. So you can start advocating these recommendations which has come out, and again form a multi-sectoral committee, those meetings, and with this as you know, referring to the current workshop, how the evidence is, and then go back and you can work with the Ministry of Health. First of all, they have to own the idea, and then the multi-sectoral engagements with the necessary line ministries and all the stakeholders. Since you're starting it, I think the request would be to have the TB affected communities also on the stakeholders meeting. That makes a very, very when the policymakers hear 2-3 stories, they definitely survivor stories, how they have dealt with it, and what is the science behind nutrition being supplement nutrition being the only vaccine which we have today. We don't have any vaccine. It's a complicated disease, but we understand the science has the recommendation is very much there that nutrition work as long as there's no medicine. If we actually implement the recommendation of giving the nutrition to the household contacts of the TB patients also. So good luck to you. Thank you so much. Thank you.
Good morning. In Mongolian case, National Public Health Center did step survey and nutrition survey every 5 years, and nutrition survey reported last year. Mongolian situation, 3% of undernutrition for undernutrition prevalence, 3% of population, and overweight, more than 20% of population. Then in Mongolia, undernutrition issues are not too much, and in the Mongolia, approximately 3,000 new cases reported. TB cases reported yearly, annually, and we implemented a nutrition support project, enrolled 450 TB patients. It means almost 15% of TB patients enrolled food support program. Mongolian Anti-TB Association. This is a non-government organization. This NGO implementing food support program. They also trained more than 400 volunteers and volunteers implementing this food support program. And this program supplied the 30 around approximately $30 per month to give TB patients. And 10 years ago, we implemented Lunch Dot program. That time, we evaluated this program, and this research result showed us more than 10% compared the this is a case control study. Then TB patients who enrolled food support, this result TB treatment outcome more than 10% of who not enrolled TB support. Then we implemented more than 20 years for this food support and Lunch Dot program. And this year, our government also implementing food support program and social protection for in the nationwide. Then now national TB program trying to integrate for government food support program, because currently just supported by Global Fund financial support. Then we need to integrate for a government program. Also monitoring and evaluation process not enough for this program. In the future, we need to focus on this. Also, Mongolian, one problem is we are very small population, but our landscape is very huge. Then supply and logistics process difficult for us. Then we are prefer just send the money or food voucher. It's sometimes quite difficult to monitor. Thank you.
Thank you very much. Big hand to Mongolia. So we have seen different approaches to the undernutrition problem. So some countries have really advanced in their multi-sectoral approaches towards nutrition. And some countries start with project-based approaches and then now starting to integrate into the government implementation. So it's also good to hear from Mongolia that you know the magnitude of the nutrition problem in your country. And if there are project approaches, it's also good to know what the impact is of all these projects so that you know whether it's worth pursuing for integration. So I'd like to give the floor to our colleague in India who has a lot of experience in nutrition. So I think we're running out of time, so just 3 minutes.
Yeah, I've been told that we are running out of time. So I'll take just a couple of minutes in our experience, India's experience, and implementing the recommendation, which was that at diagnosis, all individuals should get the nutrition support. So when we wrote the National Strategic Plan in 2017, it was very well articulated. And in 2018, the Parliament allocated separate budget for the nutritional support through direct bank transfer. So since April 2018 till date, roughly, I mean, we have given 424 million US dollars to about 10 million TB patients. And so that was direct benefit transfer. Initial teething process issues were there, that reaching it to people who makes the list, who checks the lists, and how the money is dispersed. And in India, we give the annual budget to the states to implement the scheme. So now all those teething problems are involved, but now we are monitoring which are the states which are doing better, which are the states which are giving all the benefits to the TB patients. And we have increased after seeing the initial analysis that people receiving support, TB patients receiving support, their treatment adherence has improved and the outcomes have improved. And this year, the new government recently doubled that amount to about $11 per month to all TB patients, irrespective they are taking treatment from the government or from the private. The moment they are notified, everybody get $11 per month as nutritional support. Getting good experience out of this direct benefit transfer. We also involve the corporates and other individuals in civil society, elected representatives, to adopt the TB patients and give them food basket. One of the country also, I think Thailand, is linking with the livelihood schemes. So we also initiated one where one can volunteer in one's own district and adopt TB patient and take care of the whole nutritional support cost, which again comes down to about $11. The nutritional basket has been made after due deliberation with the National Institute of Nutrition, the component across geographies, what should be that. So this is how we are doing. Government is doing the direct benefit cash transfer, and through the stakeholders, corporates, institutes, individuals even, they can do the nutritional support there. So, and also recently this year, we have also got approval, as is the new recommendation that nutritional supplement should also be given. So energy dense nutritional support for the IP period for 2 months is to given to all TB patients. So that specification we are working so that ADNS support includes micronutrients, vitamins, etc. So this has been our experience. I'll just to close the session, I would say document well in your policy about the plan which you have to articulate it very, very clearly, and the budget required for that, plus the HR required for that. That should be very, very clearly mentioned. And now the newer recommendation that not only TB patient but their household contacts should also, because they are also vulnerable, after they should be also offered nutritional assessment and counseling as part of contact tracing, which is already being done. And it should be in settings with the food insecurity, food basket in combination with multiple micronutrients can also be factored in. And vitamin D supplementation may be provided to people with TB in the context of, I mean, these are the newer recommendations. Yeah, so that's all from my side. Thank you.
Thank you, Dr. Kumar. I was told by Mansa that we have colleagues from Myanmar who would also like to share.
Yes. Hello, can you hear me?
Yes, loud and clear.
Yes. Good morning, everybody. Greeting from the WHO Country Office, Myanmar. Unluckily, NDB College from Myanmar can join this workshop because they are busy with the response for the earthquake. And first of all, I would like to present concerning with the stakeholder coordination. As most of the country mentioned, that is the most important. We need to coordinate with the ministerial head and also with the nutritional program, existing nutritional program, and our ministerial head and WFP, WHO nutrition program, and the donor agency, social welfare service, NGO, and the implementing partner who are working for the TB. And for the planning and resource mobilization, it is also important, and we need to coordinate with the funding management organization and the WFP and the Ministry of Social Welfare. And for the most important thing is that we were trying to include the nutrition portion in our new NSP for the TB. And for the policy norms and the standard, we will follow the WHO nutrition guideline and will prioritize depending on the resource availability. And that also depend on the approval of the administration council. And for the implementation and HR portion, we can use the existing HR resources in the existing TV service delivery pathway and the volunteer from the partners. And for the equipment and the nutrition assessment, we can adopt the nutrition assessment tool from the WHO, WFP, and UNICEF. In kind or suppose we have to choose the food supply of the many. If we choose that may depend on the area and the situation. And because some area are difficult to transport, and if we choose to support many, we can save the HR costs and transportation costs and the other operational costs. And we can also provide through the digital payment platform. If we choose to support the many, we may also need to provide the knowledge for the patient and in nutrition also. And we may also need to provide the training for the nutrition also. And for some area like the disaster affected area, food supply may be more affected, and but because in this area people are very difficult to get that food supply in current situation. And for the infrastructure, we can use the current existing previous service delivery pathway and for logistic also. Now for the MME and research portion, we will include the discussion portion in the national technical working group meeting for the TV and the MME and the research meeting. And that's all from Myanmar. Thank you, everybody.
Thank you very much, colleagues from Myanmar. So we heard from our colleague from Myanmar that they are also into stakeholder coordination, and they give importance to planning and resource mobilization in the efforts towards undernutrition, and importance of following the WHO guidelines that have recently been updated and tailoring it to whatever is possible in their country, especially in terms of the availability of resources. And also the use of assessment tools are also available. They also take into consideration the logistics that are needed to choose between digital cash transfers or giving food itself. So with that, we'd like to thank everyone for all your inputs, sharing your experiences in your efforts against undernutrition. Let's give a big hand to Dr. Annabelle Badule for sharing with us the updated WHO recommendations. And we also thank our colleague yesterday from World Food Program and presentations from Bangladesh and Lao PDR. Thank you.
Yeah, and we thank also Dr. Mamel and Dr. Nishan for chairing this session. So, and we are moving to the next session, which is on WHO policy on TB treatment. So, and this session will be chaired by Dr. Krishan from Thailand and Dr. Naveen from Nepal. So we are a little bit late, and we will have the coffee break a little bit later.
So. Okay. Okay, and then conclude it. Yes, sir. So thank you. So now our treatment sections is started in the TB. Treatments first class will be taken by Dr. Ford, and then the second class will be Dr. Lin, and then there will be the question answer, and then will be the coffee break. So I think we should start from, as we are time constant, we should start the first session by Dr. Ford.
My name is Fuat Mirzaev. I am a team lead of the TB treatment team in the Global Tuberculosis Program in WHO headquarters in Geneva. Today, I am not there with you, unfortunately, but in this virtual presentation, I will provide you an overview of WHO consolidated guidelines on TB treatment and care, and my colleagues who will be there in person during this workshop will provide more details. Over the past 60 years or so, TB treatment has undergone significant advancements, evolving from no medication to combination therapies that may or may not include injections. Treatments have progressed from being minimally effective, toxic, lengthy, and burdensome for patients and the healthcare system to safer, shorter, and more effective options, including for drug-resistant TB. With the shortest regimen now being a 4-month course of treatment for drug-susceptible TB. The medications used in TB treatment include both those specifically developed for TB and other antibiotics that have been found effective and repurposed for TB management. While we have made great strides, the journey continues. Challenges like high medication costs, treatment duration, and safety remain, opening the door for exciting future innovations to create more accessible, efficient, and safer solutions. On this slide, you can see a snapshot of all the updates and publications released by the WHO Global Tuberculosis Program in the last 3.5 years. Drug-susceptible TB consolidated guidelines presented several new treatment recommendations. The new TB care guidelines and the handbook were released in 2022. Childhood TB guidelines incorporated all recommendations relevant to younger patients in the release back in 2021. And finally, drug-resistant TB guidelines that were released in December 2022 with a major update have been again updated in early 2025. So this year, WHO is releasing a new edition of the consolidated guidelines on TB treatment that combines all 3 current modules, the module on drug-susceptible TB, the one on TB care and support, and drug-resistant TB into one consolidated online resource. The part on the drug-resistant TB has also been updated. So let me run through each chapter of the consolidated guidelines. Chapter 1 is dedicated to the treatment of drug-susceptible TB. This part of the consolidated document will not present any significant updates compared to the previous version from 2022. The drug-susceptible TB guidelines were already rehauled and updated, also consolidating recommendations from 2010 and 2017 guidelines. Since the establishment of the current global standard of care for TB, the 6-month HRZE regimen, widely used for most TB patients, treatment guidelines for drug-susceptible TB have remained largely unchanged. A significant update came in 2022 with the introduction of 2 new 4-month-long regimen recommendations tailored for adults, but also for children and adolescents. Beyond this, the guidelines primarily reflected consolidation of the previous recommendations, also setting the stage for the future advancement. Back in 2022, WHO also released the TB care and support guidelines and the updated handbook. There are no changes in this chapter for this release of consolidated guidelines. The chapter on TB care and support prioritizes patient-centered care by incorporating recommendations that focus on care and support interventions tailored for all individuals with TB, ensuring their unique needs are met. There is also a part on specialized models of care designed specifically for people with drug-resistant TB, also addressing their distinct challenges. And finally, the models of care for children and adolescents, providing age-appropriate support to improve outcomes. The Chapter 2 on treatment of drug-resistant TB is the one that will see a major update. It was already announced in August last year in the rapid communication document. The updated guidelines with all the details and the handbook are being included in the release of the consolidated guidelines this year. This chapter introduces several key updates while retaining many previous recommendations. The updates are highlighted in red on these slides. A major policy addition back in 2022 was the 6-month BPAL-M regimen for patients with multi-drug resistant and rifampicin-resistant tuberculosis, including those with potential additional resistance to fluoroquinolones. This year, the chapter also introduces an alternative 6-month regimen and several modified and optimized 9-month regimens. Furthermore, it provides new recommendations on the potential co-administration of treatments for drug-resistant TB alongside modern therapies for hepatitis C. So let me just run through the main recommendations in this chapter. The game-changing new regimen reviewed and recommended back in 2022 is the so-called BPAL-M regimen, which combines several novel and repurposed medicaments and can be used in patients suffering from both multi-drug resistant and rifampicin-resistant TB and those with additional resistance to quinolones. Unknown safety of using the new agent, bretomanid, in patients below 14 years of age prevented recommendation to expand to all patients, leaving this unfortunate limitation until ongoing safety studies are complete. With the BPAL-M recommendation following the guidelines released in 2022, the framework of drug-resistant TB treatment has evolved as follows. The BPAL-M regimen became the regimen of choice, followed by 9-month regimens when specific limitations arise, with longer 18-month regimens reserved as a last resort for individualized treatment plans. Last year, the new evidence was kindly shared with WHO and used for the review and guidelines development originated from two clinical trials. BTB trial that studied a new 6-month regimen against standard of care 9-month regimen in South Africa, and the multi-country NTB trial that studied 5 new modified 9-month regimens, comparing them to the longer 18-month regimens. The research question that was used for the guidelines development was very much aligned with the BTB trial. And it is, as on this slide, it was whether this regimen, a 6-month regimen with bedaquiline, delamanid, and linezolid, with or without addition of levofloxacin or clofazimine, be used in patients with pulmonary rifampicin-resistant TB with or without quinolone resistance, when compared to the currently recommended 9-month regimen. The review of this new evidence from the Beat Tuberculosis trial resulted in this new recommendation for the so-called BDLLC regimen, and opened up an opportunity for younger patients to benefit from the shorter 6-month regimens as well. In the same manner, the second research question that was put forward for the review by the guideline development group was very much aligned with the research question of the NTB trial. And it was whether the 9-month NTB trial regimens, there were 5 of them, can be used in patients with pulmonary rifampicin-resistant TB, but those without quinolone resistance, over the currently recommended longer regimens. The outcomes of this review of the second question were 2 recommendations. Why 2? Because the first one is a positive recommendation that supports the use of 3 out of 5, 3 of the researched 9-month modified regimens, and as a more lighter and more streamlined alternative to the currently recommended 9-month regimen, consisting of 7 drugs. 2 of the regimens researched under the NTB trial are recommended against the use based on the evidence provided by the trial. That's why there is a second negative recommendation. These several new recommendations and a number of the new regimens, the paradigm of drug-resistant TB treatment is changing, with new regimens included in the 6-month and 9-month groups. An important highlight is that the 6-month regimens are now available for most of the patients of all ages. Well, now the new recommendations are in place, but there are still several implementation barriers to make them available to all patients needing treatment in all affected countries. Of course, that includes the diagnostic barriers, the high price of some medicines like delamanid. The medicines availability and procurement is still an issue in some places, but there are quite a number of programmatic barriers, like programs having the doubts about these new innovative regimens. There are still previous regimens in use. The regulatory in countries are not totally catching up with this change, and policy updates or repeated local research. Now, can we say that we are in a best place possible with the treatments for drugs susceptible and drug-resistant TB? No. The journey of TB treatment is far from over, and the future looks promising. While current TB treatments are not yet perfect, the field is vibrant with ongoing research into better regimens. We are optimistic that both current and upcoming trials will pave the way for even safer, more effective, and shorter regimen options, transforming the landscape of TB care. To provide a bit of summary of what I said, the shorter 6-month BPAL-M regimen is the regimen of choice for patients with multi-drug resistant TB, TB with rifampicin resistance, and also with additional resistance to quinolones, but can be used in those of 14 years of age or older. The 6-month regimen research under the Beat tuberculosis trial is a 6-month alternative for those not eligible for BPAL-M, and it can be used in all patients, including children and pregnant women. Several modified 9-month regimens can also be used for patients with multi-drug resistant TB, but without quinolone resistance, adding a choice of regimens with fewer component medicines to the group of 9-month regimens, including those currently recommended. The longer 18 or 20-month regimens remain the last resort individualized regimens. And obviously, the duration of drug-resistant TB treatment can be the same as the treatment for drug-susceptible TB, now for most of the patients, including children and during pregnancy. And finally, before we have a discussion and answer questions, let me say that in 2025, there is a consolidation of several guidelines and handbooks in Module 4 treatment. For drug-susceptible TB, we have 3 regimens, 2 shorter 4-month regimens and 1 6-month regimen that remains recommended. For drug-resistant TB, there are 7 shorter treatment regimens. 2 of them are 6-month, the BPAL-M and BDLLC. There are 3 new modified 9-month regimens and 2 previously recommended. The longer 18 to 20-month regimens remain the last resort option and the only individualized regimen that is possible.
Okay, thank you, Dr. Ford from British Oden. We will proceed to the new modified 9-month regimens by Dr. Lin. Dr. Lin, please.
Good morning, everyone. I will continue from what my colleague Fuad presented about recommendation for the use of the modified 9-month regimens. And in the presentation, I will, the first 2 points, I will recap what already mentioned, but mainly focus on eligibility, selection of regimen, composition and duration, dosage, drug dosage and frequency, subgroup and other implementation consideration, treatment monitoring and outcome assignment. So I think that Fuad already mentioned that the evidence come from the NTB trial. That's a multi-country trial testing 5 modified 9-month regimens. As you can see in the slide, the first 3 regimen, including containing bedaquiline, and the last 2 without bedaquiline, and 4 patients with MDR-TB or RTB without quinolone resistance. And these regimens were compared to the WHO recommended longer regimen. And again, the recommendation already presented. And in this presentation, I only focus on the first recommendation. That's a positive recommendation. I will not discuss further about the second recommendation, that's against using the two regimen without bedaquiline. So the three modified 9-month regimens are eligible for patients with MDR or rifampicin resistant TB without resistance to quinolone. And the regimens can be used for patients of all age, including children and adolescents, and can be used for people living with HIV, pregnant women, or breastfeeding women, and for patients with pulmonary TB, including extensive form of the disease. And the regimens can be used for extrapulmonary TB, except some severe forms of extrapulmonary TB. And the regimen can be used for patients with exposure to the component drugs less than 2 months, less than 1 month. And in case the patient have a history of exposure and drug resistance excluded. And for children and adolescents without confirmation of bacteriological confirmation of TB or drug resistance, but with a very high likelihood of MDR or RTB. And some factors for selection of the modified 9-month regimens, including the most important of the drug resistant pattern. And the 9-month regimen can be used for MDR or RTB with confirmed quinolone susceptibility. And for patients with unknown or unconfirmed quinolone resistance is not eligible, and not for pre-XR or XR-TB, and they can be used for other forms of TB, extrapulmonary TB, pulmonary TB, children less than, and adolescents less than 14 years old, and pregnant and breastfeeding women. And among three modified 9-month regimens, the first regimen containing 4 medicines, bedaquiline, linezolid, moxifloxacin, and pyrazinamide is the first preferable option, because due to the efficacy of the regimen, lowest cost of the drugs, and also lowest pill burden. And the last regimen with 5 medicines and using delamanid instead of clofazimine compared to the second option is the lowest priority or less preferable option among the three, because of the significantly high cost of the medicines, and also higher pill burden compared to the other two. And in terms of the composition of the regimen, you can see that the first regimen contains four medicines, and the other two contain 5 medicines. And you can see the 3 medicines are in common across 3 regimens, that are bedaquiline, linezolid, and pyrazinamide. The difference are quinolone. Quinolone is moxifloxacin in the first regimen and levofloxacin in the other 2. And the difference between number 2 and number 3 is clofazimine and delamanid in the second and the third. And the swapping fluocinolones, moxi and levo or vice versa, is not advisable for this regimen, because the regimen is studied with either moxie or levo, so no evidence to support swapping between the two. And about drug dosage and frequency for bedaquiline, there are two dosing strategy, and either of the strategy is acceptable. 400 milligram for the first 2 weeks, and then continue with 200 milligram 3 times a week, or 200 milligram daily for the first 8 weeks, then 100 milligram daily afterwards. And the second option, I think the feedback from the field all the time is maybe more easier for implementation in the programmatic conditions. And for linezolid, 600 milligram once daily for the first 16 weeks. Then the reduction of the dosage is allowed, either 300 milligram daily until the end of treatment, or 600 milligram 3 times a week throughout the last part of the regimen. And either dose reduction strategy for linezolid is acceptable as a standard practice. And linezolid may be reduced or discontinued earlier if toxicity occurs before 16 weeks. But ideally, the discontinuation of linezolid is not earlier than finishing 9 weeks of treatment. And the duration of the regimen is 9 months or 39 weeks. All the medicines to be used throughout the treatment duration, and no distinction between intensive or continuation phase. And for these regimens, no routine extension of treatment longer than 9 months. And all the missed doses during the treatment should be made up to complete all the doses within an 11-month framework. And some modification and conditions for discontinuation of treatment. First is lack of treatment response at month 4. If no clinical or bacteriological response or improvement, we need to investigate for possibility of drug resistance during DST for positive culture. And at month 4, if the persistent smear or culture positivity or no clinical improvement, the regimen need to be stopped and switched to another regimen. And if the drug resistance detected for fluoroquinolones or any other component drugs except pyrazinamide, the patient need to be declared a treatment failure, and change to another regimen is required. And in terms of adverse events, stopping pyrazinamide or linezolid may be possible while during the treatment. But if more than one drug need to be stopped, we need to switch to another regimen and declare as treatment failure. Some subgroup considerations for breastfeeding women, pregnant women, and children. I think all of this group, the data from the trial is very limited. However, I think the guideline development group still suggest for using of the regimen in this group, but the first regimen containing 4 medicines is a preferred option based on the history of safety use of the drugs in this group of the patient. However, the close monitoring of toxicity and treatment response is required for all the group of the patients. And for pulmonary TB, the regimen can be used for all types of pulmonary TB because of, all of them were included in the study. And patients with extensive form of pulmonary TB, for example, with cavities or high-grade sputum smear positivity had overall success rate is lower. However, it's still acceptable and higher than in the comparator group. And for extrapulmonary TB, because of no patient with severe extrapulmonary TB were included in the trial, so the efficacy of the regimen in this group of patients is not proven. That's why it's in the exclusion criteria of the using regimen. And some group of the patient with comorbidities, diabetes, the patient with diabetes can be given the regimen, but some close monitoring of toxicity, especially neuropathy, is required, especially in the patient using linezolid. And the treatment of diabetes should be provided alongside with DRTB treatment. And because of the regimen using all the regimen using pyrazinamide, and that also cause a high risk of hepatotoxicity. So the patient with moderate or advanced liver disease or ALT level 3 times or higher, the regimen should not be used, and we better select alternative regimens for these type of patients. And the regimens work well in the people living with HIV. And some considerations in relation to pyrazinamide. In case of pyrazinamide susceptibility or DST for the drugs unknown, the medicine should be used in the regimen. However, when pyrazinamide resistance detected, we can remove this drug from the regimen, and overall the regimen remain effective, but with a careful monitoring of treatment response is required. And about treatment monitoring, it's not different from other regimen for MDR or RTB that requires the monitoring of treatment response, including monthly sputum or culture, to assess the response, and DST may be required in case of poor response. And regular clinical examinations to assess clinical improvement, and radiological assessment as baseline and end of treatment. And the second purpose of the monitoring is safety for the patients and or clinical and laboratory examinations required. And in the operational handbook, there's this table to have a schedule of all the clinical and laboratory examinations for patients in all the MDR TB regimens. I don't want to go to the detail, but just show it to you, and you can refer to the operational handbook if necessary. And for treatment outcome assignment, the standardized treatment outcomes for DSTB and DRTB patients are used, so no bit different from the modified 9-month regimen compared to other regimens. And going back to the landscape or treatment regimen options that Fuad showed earlier, so we can see that the 6-month regimen, including BPAM and the BTB regimen, are preferred option for patients with MDR, RTB, or patients with pre-XDR TB. So the coverage of these two 6-month regimen would be majority of the DRTB patients. And if the patient not eligible for any of the 6-month regimens, the 9-month regimens, including 5 regimen in two classes, will be considered. And longer regimen is the last option for patients who fail shorter regimen or patient with XDR TB. And within the 9-month regimen, the 3 modified 9-month regimen should be considered for the patient if they are eligible before considering the 9-month regimen containing 7 drugs as recommended earlier. So in summary, the why 6-month regimen are preferred choice for patients with MDR or RTB without FQ resistance. The modified 9-month regimens are considered as a good alternative with some limitations. And the modified 9-month regimens are applicable for all patients, in all age group, and can be used in the pregnant and breastfeeding women. And the regimens have a less medicines and less pill burden compared to the previously recommended 9-month regimen that contain 7 medicines. So these are the 2 documents, the guidelines and handbook that we expect to release very soon by WHO in a few days. So you may expect to see the launch or release of these 2 documents next week, possibly. And we still have some pending of internal approval for the handbook, but in fact, I also provide you the link for the guidelines for your reference in case you want to assess more details of the guidelines, but maybe just for your use at the moment before the official release of WHO, because we want to launch 2 documents at the same time. And of course, after the release, all the details of the documents will be available in the WHO TB knowledge sharing platform that you can access in the computer or even in the mobile app, like other guidelines and handbook documents. And lastly, I would like to acknowledge all the national TB programs, research partners, civil society representatives, experts who contribute to the development of the guidelines and handbook for TB treatment and care, and some of our colleagues in the WHO Global TB Program. And thank you very much for your attention.
So next is the question and answer section. And I think there is a lots of new recommendations from the WHO, and new guideline is coming in 1 week, as Dr. Lin has said. So must be some questions, I think. The floor is open.
Thank you, Lynn, for your presentation. I may have missed it, but what's the dosage for the rest of the components like PZA, levofloxacin? Is it going to be weight-based or is there a standard dose? And also the dosage for bedaquiline and linezolid, which was clear in your presentation. Does this apply also to children? It's not going to be weight-based?
Yeah, I think in the previous version of the the guidelines and handbook, you might have seen the table for dosing of all the medicines, first line and the second line medicines. So for other medicines, it remains the same. We have some ongoing work to review the dosing strategy for medicine, but I think so far there's no suggestion to change that dosing strategy. So it remains the same.
Thank you. Lynn, can I have a follow-up? So even for levofloxacin and clofazimine and delamanid, it's
I think
it's standard.
remain the same as standard.
Thank you.
Thank you, Dr. Lin, for your presentation. I had a question on what you said about pyrazinamide. So you mentioned, if I got it well, you mentioned that pyrazinamide can be not given if resistance is shown. Does that yield for all regimens? So also, for instance, for the for the first regimen on the 9 months, so that's the bedaquiline, linezolid, moxifloxacin, pyrazinamide regimen. Can you just leave it out there? Is that is that what you said?
Yeah, that apply for all 3 regimens. Your question, sorry, Agnes, not sure I got your question right. You asked whether for the first regimen or all 3 regimens. The answer is for all 3 regimens. Yeah, in case we lose pyrazinamide because of resistance.
Any more questions?
Yeah. So I want to continue with the same as pyrazinamide, because you also mentioned that if it is resistant in the regimen, so we can discontinue and continue with the regimen, right? So, and now in areas which you know that we have high prevalence of resistant to pyrazinamide. So, and also there are lack of possibilities of doing DST, or there might be some delays with the DST. Is there any possibility of starting the regimen without pyrazinamide?
Sorry, Mansa, can you repeat? I'm not.
No, I mean in areas which you know that there is a high prevalence of pyrazinamide resistant. So, and the possibilities of doing DST, or there might be delay also getting the DST results. So can the regimen start without pyrazinamide?
Oh yeah, very good question, Mansa. I think the delay of the initiating the regimen is not suggested pyrazinamide in this case. So in case you don't have the information on DST results, we should start with the regimen and monitor and adjust the regimen when you get the DST result. Yeah, Dr. Thuy. I think there's the button there. You can turn it on.
On top. Yes. Thank you, Dr. Ling, for a very nice presentation. I have two questions. The first question for the new 6-month regimens to replace Delamanid for Pretomanid and adding clofazimine. So it's the same ways with Bipalem for the duration of the allowable duration of interruption of the whole regimen if adverse event happen with bedaquiline. So we need to stop full regimen like the same way as Bipalem or different. And in that way, what is the maximum of interruption allowable? For example, like for Bipal, 2 weeks continuously or 4 weeks discontinuously, something like that. And also regarding this regimen, if allowable is one month maximum discontinuation of the full regimen, then how we can identify a patient who lost 1 month? Because now the definition is lost to follow-up is defined as more than 2 months. Yes, so in this case, how we can define the patient? Of course, we need to trace patient, but if we cannot find the patient at this time, so how can, that the first question for the 6-month regimen. And the second question is for the loading dose and the option 2 of using bedaquiline. So now mentioned the second option is to use 200 milligram daily for 8 weeks and then move to 100 milligram daily. So this option can be applied to all regimen with bedaquiline or only for Bipalem 6 months. And if it can apply to all regimen, then how we can adjust the loading dose if the patient have interruption during treatment? Because now currently it is mentioned in the companion handbook for 9-month regimen with bedaquiline that for option 1, that if patient interruption more than 2 weeks but less than 8 weeks, then we can reload 1 week of bedaquiline. But how we can deal in the same way if we use option 2, because different way of using, so we doubt about how to reload in case patient have interruption. Yes, thank you.
Yeah, thank you, Dr. Thuy. I think the first 2 questions are related to the 6-month regimens. I suggest that we wait for the next presentation. I'm sure the presentation will answer maybe some or most of your questions regarding the 6-month regimens. And the second question about dosing bedaquiline, I think the 2 strategies of dosing are successes for all the regimens. Yeah. And yeah, you refer to the interruption of 2 weeks for the first strategy, loading dose, and how we deal with the second strategy. Yeah, maybe I I may need to find out from you and what exactly the implication of that. I'm not yet it quite clear now. Yeah.
I can see no more question now. So thank you, Dr. Lin, for your presentation and answer your question now. I think we a little bit late, but this is the time for coffee break, and we should be come back here again. Oh, one more, please.
Them to longer regimen during their 4 to 6 months of treatment. Thank you.
Sorry, can you repeat again the question?
Do we have to restart the patient to longer regimen? No, I mean, if we are to switch the patient during the 4 to 6 months of his treatment to longer regimen, do we have to restart the treatment, or we can just continue the counting of the dosage? Thank you.
Yeah, thank you. I think that's a good question, and we get that quite often. Yeah, but in the principle, when we change the regimen, the different regimens will be used. So you need to count from the beginning, because I'm sure the component medicines in the two regimens are different. Right? So whenever we decide to change, we may need to consider that we start the new regimen.
Any more questions? If not, I want to ask you, sir, one questions like for 9 months regimen, first one is BLMZ. So bedaquiline, linezolid, and moxi is the same from the BPAL-M regimen, and only the pretamine is replaced by the pyrazinamide. So rest all are the same. So pretamine being a core drug, I think more bactericidal and sterilizing both effect is replaced with the pyrazinamide. So what will be the treatment success difference if you use the 9 months of this BLMZ respect to BPAL-M regimen?
Yeah, good question. I don't think we have comparison between the two, but you already mentioned pretomанid in the BPAM regimen. Only the different pretomанid and pyrazinamide, right? But at least the BPAM regimen, so it's a six months. The difference 6 months compared to 9 months. And the BPAM regimen shows excellent treatment outcomes after 6 months. And for this 9-month regimen, we need like 3 months longer.
Also, the linezolid, if you extend the regimen durations, lots of adverse event of the linezolid you can see in the patients. Even in the BPAL-M regimen, we are experiencing loss of toxicity of the linezolid, and we are discontinuing also in between. So after discontinuation of BPAL-M regimen, can we go for this 9 months regimen or not? Or directly go to the 18 to 20 months regimen? What is your suggestion?
Yeah, so your question is if we fail
not fail, but discontinue because of the linezolid. Sometimes there is a toxicity and we cannot continue for longer durations. Like sometimes you have to discontinue those modifications for more than 2 weeks is not acceptable in the BPAL-M regimen. What about this BLMZ regimen or BLLFX-CZ regimen? So that if we can discontinue the BPAL-M regimen, can we move to BLLFX and CZ regimen or some other 9 months regimen as you have suggested?
Yeah, I think it's possible if the clinician, the treating doctors, see that's still eligible. Right? I think for the first one, when you stop the BPAM regimen due to the toxicity, that mainly linezolid, I guess, right? Not other drugs have a much less toxicity than linezolid. So the two regimen have the same drug with the problem, most of the problems, right? So it's maybe not the good choice to change to that regimen. But if other regimen are eligible for the patient and without the medicine that cause toxicity for the patient, I think it can be used.
But in BPAL regimen, we cannot reduce the dose even of the linezolid in the initial 9 weeks or something like that. What about this new regimen? Can we reduce the dose of linezolid within the 2 weeks or within 9 weeks like that?
Yeah, I think the modified 9-month regimens reduction standard practice reduction of linezolid after 16 weeks. However, in case the patient have a toxicity, you need to reduce the dose earlier than 16 weeks. It's also possible. However, better we have at least 9 weeks of treatment before we change the dose or stop the medication. Yeah.
Thank you.
So, okay, thank you, Dr. Lin. And we should have a coffee break now, and we'll come back again. 15 minutes, okay. Then 11:45, thank you. Then please come back in on 11:50 so that we can continue the next session. Thank you.
I think you have enjoyed a nice coffee. So the time is to start the class. Everybody be seated, please. Please take your seat. The next session is going to start, so please be seated. They have a big queue there, you can see. Please sit, please take your seat. Please take your seat. So the next session is again the online sections by Dr. Francesca, and this is about the 6 months BDL LFX C regimen. So I think this is the new for all of us, and there's lots of questions in the previous section also about the 6 months newer regimen. So I think please take your seats and see the presentations. And I think if you have questions, then at last, the question and answers will be at the last only at 12:55, I think, before lunch. So just, I think we have to start the presentations. Thank you.
Francisca, are you able to share your screen? Okay.
I'm just going to move it to, is it in presenter mode?
Yes.
So, oh, Are we ready to go?
Oh, you need to put it in presentation mode.
Okay. I can't work out how to do it.
It's on the right.
Oh, yeah, sorry, got it. There we go. Sorry about that. Sorry. That's the one with the language in it. Excuse me a second. I just need to find the one that's not recorded. Maybe if someone could share the unrecorded one from that side while I'm looking for the one on this side.
Okay.
I recorded a backup just in case. And now it seems to be the one that is presented. Okay. Now they all seem to have my voice on it. This is a bit of a problem.
Okay, I'm sharing the one. Are you seeing it?
Yes. Yeah, for some reason, the one that I've got saved has got my voice on it, but I'm sure you want my real voice. Okay, if I may start.
Yes, you can.
Okay, good day, everyone. I'm not quite sure what time of day it is. I hear you're about to go for lunch. My name is Francesca Conradi, and I'm currently a technical officer at the WHO. And what I've been asked to do, and thank you very much for inviting me. I'm sorry I couldn't be there in person. But what I'm going to do today is I'm going to talk about the 6-month bedaquiline, delamanid, linezolid, levofloxacin, and clofazimine regimen, which from now on will be referred to as the BDLLC regimen. In terms of the topics I'm going to cover today, I'm first going to cover what the sources of the evidence were, where we got this information that we can use the BDLLC regimen. I'm going to talk in detail about how we composed the regimen. I'm going to talk about who's eligible, and therefore, I guess by contrast, who's ineligible for the BDLLC regimen. And then frequently asked questions is, what's the difference and what's the same between our other current 6-month regimen, the BPALM regimen? And I'm going to cover that in quite detail. Then I'm going to go straight from that into, if we could go back a slide, please. What I'm going to do is I'm going to go into quite a lot of detail about the management of adverse events. And hopefully with all of that, I will be able to cover any of the things that we need to discuss. Then we'll have a good 15 minutes where we can have questions. Next slide, please. Okay, so where did we get this information about the BDLLC regimen? So the beet tuberculosis was a study that was conducted in South Africa alone. It was conducted at 2 sites, 2 coastal sites coincidentally. And what we looked at is we wanted to know if patients with microbiologically confirmed rifampicin-resistant or MDR-TB could be treated with a 6-month all-oral regimen with the drugs that I mentioned before. We had 2 comparators, so whenever we do a trial, we compare one to another. And the 2 comparators we had was for people who were fluoroquinolone susceptible. We gave them a 9-month regimen, the linezolid and bedaquiline regimen. So it's a 7-drug regimen with 2 months of linezolid. If in contrast they were found to be fluoroquinolone resistant, then they were given an 18 to 20-month regimen in line with the South African guidelines at the time. What was novel about this particular study is 2 things. The first thing is that pregnant women could be enrolled. So obviously, if pregnant women presented with rifampicin-resistant TB, we asked them if they would like to be part of the study, and if they agreed, if they gave us informed consent, they could be enrolled. So this is one of the first studies that gives us very valuable information on how these drugs work in women who are pregnant. Then the next thing that we did that was unusual is we enrolled children. So children from the age of 6 could be enrolled in the study. As we know, TB tends to affect households, not just a single individual. And what we wanted to do was to see if we could use a same or similar 6-month regimens for the vast majority of the people within the household. A further study that was done, in fact, prior to beat tuberculosis in South Africa was a study called Beat Tuberculosis in India. And what that study did, it was a single-arm study, and it was only for fluoroquinolone-resistant patients, and they used BDLC. And all of them have got, pardon me, a very similar efficacy. So this is where we got the information from. And how did the recommendation turn out? If we can go to the next slide, please. In the next slide, you can see these are the guidelines, and this is what they say. Sorry, the slides are just moving. I apologize. And the WHO suggests the use of a 9-month regimen composed of 5 drugs, BDLC. But what the trick with this particular regimen is that we can use either levofloxacin or clofazimine, or in some cases, we can use both, depending on whether or not we establish whether the patient has a fluoroquinolone-resistant organism. It is a conditional recommendation with very low certainty of evidence. What that means, it doesn't mean it was a poorly conducted study at all, but it just means it was a single country, essentially single population group, so that makes the evidence of low certainty. And then in addition to that, it was conducted in one country, and the sample size, although 400 patients were enrolled, it was a relatively small sample size. So that's why it's a very low certainty of evidence. If we go to the next slide. So what's the composition of this regimen, the BDLC regimen? So we have 2 options for the way that we can dose bedaquiline. The 2 options are as following. The first one is the way that bedaquiline is registered to be given. So it's a 400 milligram a day for 2 weeks. And this is followed by 200 milligrams 3 times a week. This is the way that the drug was originally registered. It has its pros and cons. I think it's quite difficult for both healthcare providers and patients to remember if today is a bedaquiline day or a non-bedaquiline day. But that's how the drug was registered. An alternative to this is bedaquiline can be given 200 milligrams for 2 months, followed by 100 milligrams for 4 months. So I heard the question that happened before is what happens if there's an interruption? I think that it's very clear what we do when we use the standard treatment. The duration of the interruption dictates how long we reload for. But at this stage, I think, to be honest, we haven't yet worked out how we would reload a patient if we give them the daily regimen, the 200 to 100. So what we'll have to do is we'll have to get back to you on that one. Delaminid is a nitramidazole. It's in the same class as pretominid, but has a couple of differences. The way that it's dosed, if we dose it as per the package insert and the way it was done on the clinical trial, is that delaminid was given at 100 milligrams twice a day. It was given for 2 months, and then we dial back down to 200 milligrams a day. There are various debates on how you can give delaminid, but those are the 2 possibilities that we've included. Then our problem drug, linezolid. I already heard someone saying we're seeing many side effects from linezolid. Welcome to the club. Linezolid is the most toxic drug in our regimen by far. And when I get to talking about adverse events, you'll see that lots of them are related to linezolid. In the BDLLC regimen, the way that we suggest that you use linezolid is we use it as 600 milligram dosage with no planned dose reductions. So in many of the other studies, Practical and even NTB, there was a planned reduction of linezolid that occurred at 16 weeks. But in this regimen, we have no planned reduction. And what we do suggest is that you give the medicine for as long as the patient can tolerate it, and then interrupt it or permanently stop it depending on which adverse event presents. Levofloxacin was the quinolone that was chosen for this particular regimen. I'm not going to go into the pediatric doses. I'll leave that to the pediatricians, and also it's within the handbook. But levofloxacin was given at either 750 milligrams or 1,000 milligrams a day. And I think this is one of the drugs with the lowest side effect profile within the regimen. Then finally, the last drug is clofazimine. Clofazimine, we know, is a drug that's previously been used to treat leprosy. Its side effect is it causes skin discoloration. And we prefer not to use it. And if we know that our patient is fluoroquinolone susceptible, we can safely drop the use of clofazimine. But in a fluoroquinolone resistant patient, what we need to do is to continue this, and the dose that we chose for this particular study was 100 milligrams. So that's a combination. We can go to the next slide. So what's the duration? The study was designed slightly differently from the others in that we chose the duration of treatment to be 24 weeks. And the reason we chose 24 weeks is that in the main, people arrive on the same day every month. So say the second Tuesday of every month. So we chose to just give the treatment for 24 weeks. You can give it for 6 months, which is really 26 weeks, but it depends on the program and how you structured it. You are not able to change the dosing of bedaquiline, delaminid, or levofloxacin. So if you get a side effect to any of these drugs, it does mean that you will probably have to stop the regimen because you actually cannot change the dose or down dose any of these drugs. Linezolid can be interrupted, and we know that the linezolid reductions that occur for myelosuppression, usually this adverse event usually occurs really early on in the treatment. So it occurs towards the beginning of treatment, and often a short interruption that's measured in days, not in weeks, can allow the bone marrow to recover, and then we can reintroduce back at the same dose. Linezolid also, sometimes we need to permanently stop it. So we need to stop it altogether. And particularly if this occurs after the first 9 weeks, then we can continue the regimen without linezolid. What happens if you miss doses? Patients miss doses for 2 reasons. The first reason is because they've got a side effect, and we as healthcare providers tell them to stop the medicines. And then they also miss doses because for some reason they couldn't get to clinic or they didn't want to take their medicines. So if there's missing doses of less than 7 days, that's okay, we just leave it. If there's dosages that are missed for between 7 and 28 days, then we make that up at the end of treatment. So if someone has, say, missed 3 weeks of treatment, we give them their 6 months of treatment, and then we add an extra 3 weeks towards the end of it. I cannot stress enough that when we use short regimens, so when we use either BPEL or BPEL-M, or we use BDLLC, that adherence is absolutely vital. And we need to do everything that we can to support our patients' adherence. So encourage them at every visit not to miss a single tablet, make sure that there are no drug stockouts, stress adherence at every time. We know that if you interrupt therapy, it is possible that you can get the development of drug resistance. And the drug that we really don't want resistance to develop to is bedaquiline. So how do we use this regimen? We've already got on to the next slide. So as soon as someone has rifampicin-resistant TB diagnosed by whatever method, we hope that most of the time it is diagnosed by a molecular method. So when it is diagnosed, you don't need to confirm it, even if they've never had TB before. If they're shown to have rifampicin-resistant TB, the test is almost always right. So you can initiate therapy as soon as possible. We do need to do some safety bloods before we initiate therapy. And the most important one is to do at least a hemoglobin. If not a full blood count, at least a hemoglobin. We know that anemia is not uncommon in patients with TB. We want to make sure that we're not dealing with somebody who's got a profound anemia before we start this regimen. We would like to get an ECG. Some of the components of the regimen can prolong the QT. And although it's a very uncommon thing, some people do have either a congenitally prolonged QT interval, or they have some cardiac problem that makes them more likely to have a prolonged QT. So we would like to see the ECG at the beginning. And then you can start BDLLC immediately. So there's no need to wait. We don't need to double check anything. You can start the treatment immediately. We do suggest in the strongest possible terms that you do a drug susceptibility testing for fluoroquinolones in all patients who have rifampicin-resistant TB. But sometimes that's not done. Sometimes it's not done because it's not done within the program. Sometimes it's not done because the specimen leaks or something goes wrong with the test itself. So even with our best intentions, and then by the time you find that information, you try and repeat it, but the patient may have culture converted and you don't get the organism again. So we do suggest in the strongest possible terms, you try and confirm fluoroquinolone susceptibility or resistance. So what happens if you find there to be resistance? We now term this as pre-XDR. Then we drop the levofloxacin and continue with only 4 drugs. So BDL and C clofazimine. What happens if we find the patient to be susceptible to the quinolone? Then we drop clofazimine. So we use BDLL. So we've got 4 drugs in the regimen. And what happens in the case of we never establish it? Say, for example, you have a child and you never found the organism itself. Then we give all 5 drugs. So we give the drugs for the duration of therapy for 24 weeks. These are the same regimens. I heard a question just recently that you asked, what happens if you change to the longer regimen, if you change regimens? But just like BPARM, it is all the same regimen. So you're not restarting. When you remove one of the drugs, the patient just continues on the same regimen. Next slide, please. So who is eligible for this new short all oral regimen? So it's for people with either MDR or rifampicin-resistant TB, and also for people with fluoroquinolone resistance. So the beauty of this is it doesn't really matter where you work and what the rate of fluoroquinolone resistance is. You don't need to wait for a further test. You can just start with all 5 drugs. So no delays at all. It's for people with pulmonary rifampicin-resistant TB. And what's really good about this particular regimen is that you can give it to anybody who lives within a household. So you can give it to children, you can give it to adolescents, you can give it to people who are living with HIV. So irrespective of what their CD4 count, if it's 5 or 500, you can give it to a patient who's living with HIV. And then also very importantly, we now have a 6-month treatment option for pregnant and breastfeeding women. In the study itself, we enrolled 10 pregnant women, one in her first trimester, the rest in the second and the third. We delivered 10 healthy babies. None of the babies had TB. And also yet to be published is we're going to be looking at the drug levels of the drugs in pregnancy, because we know pregnancy is an altered metabolic state. So now we have an option where we don't have to commit our pregnant women to longer regimens just because they're pregnant. Then the next thing when we look at the eligibility for BDLLC is we ask our patients if they've previously been exposed to any of the components of the drugs of the regimen, with the exception of levofloxacin. So we ask them if they've had more than a month of bedaquiline, linezolid, delamanid, and or protominid, because they're very similar. They have different side effect profiles and look different, but they share a resistance profile, or clofazimine. If they have had more than a month exposure, then what we need to do is to wait for the results of those tests before we initiate the BDLLC. So we want to make sure that the component drugs have susceptibility before we initiate the patients on treatment. If we could go to the next slide, please. Who else is eligible? So this is a little bit small, and I apologize for that, but we can also give BDLLC to most people who've got extrapulmonary disease. We know from working in the TB field that finding some extrapulmonary disease is not that uncommon. That includes an uncomplicated pleural effusion. You have a look at the X-ray and you can see that there's fluid in the pleural space on one side. Or alternatively, if you find peripheral lymph nodes. When you examine your patients, you'll often find some lymph nodes in the neck, and if you look carefully, you might even find some in the axilla. This is uncomplicated, non-severe extrapulmonary disease, and there is no reason to give these patients a longer regimen. However, if we've got the more severe types of extrapulmonary disease, so if there are CNS signs, either tuberculous meningitis or tuberculoma, if the TB is in the bone or in the joints, or if you have disseminated or miliary TB, then this is not the right regimen for the patients. Although the components might be correct, the duration needs to be changed. So you either need to consult or use a longer regimen in such patients. Then the next thing that you can do, and this is different from the other 6-month regimens, is that you can use it in any extent of pulmonary disease. So if you hold up your X-ray and have a look at it, or look at it on the screen, things are changing now, and you see that the patient has just a mild infiltrate, maybe a suggestion of a cavity in one of the upper lobes. That's mild to moderate disease. Go ahead, use this regimen. But what happens when you look at a chest X-ray and you can see the patient has any of the following? Bilateral cavitatory disease, so you can see that there are cavities on both sides of the lung. Or alternatively, there's really extensive parenchymal damage. This regimen can be used. So you can go ahead and use BDLLC, and in fact, you can use BPALM as well in patients with extensive disease. Sometimes you may need to extend the regimen for a slower response, but you don't need to exclude these patients from a 6-month regimen. I'm often amazed at patients who have X-rays that I think are totally uncurable. And then when I do the follow-up X-ray at 6 months, I can see some scarring, but no active disease. Then the next thing is the children. I mean, children were until recently committed to very long regimens with not that much evidence behind them. But now, because we enrolled children onto the BDLLC trial, we now know that we can use this regimen in children. Sometimes in kids, we know that they've got TB. We can see chest X-ray signs. Maybe they're failing to thrive. They have night sweats or some other problem. But we are unable to establish the diagnosis because children have paucibacillary disease and they have difficulty in expectorating sputum. If you can do ways of getting the sputum from the child, for example, if you can do a gastric aspirate, go for it. But if you can't, then you find the person usually within the household who's got drug-resistant TB, and you use their resistance pattern to guide your treatment. So you don't need to spend weeks trying to establish the diagnosis. If you're wrong, and this child actually has drug-susceptible TB, it's unlikely because they usually catch their TB at home. But if they do have it, this regimen will treat both drug-susceptible and drug-resistant TB. So if you suspect it, you can go ahead and treat it. Sometimes in adolescence, we also struggle a bit to make the diagnosis. But if we think it is drug-resistant TB, you can go ahead and start. Next slide, please. So how do we know whether the regimen is going to work, is working or not? So the technical term for that is how do we monitor for efficacy? The first thing is that we do clinical monitoring. And I think it's very satisfying to treat TB patients because what happens within 2 or 3 weeks, you know that you're on the right track because many of the patient's symptoms will resolve. They stop sweating at night, their cough settles down either completely or mostly, they gain weight, their appetite returns. And I think that one of the most important investigations you can do from a clinical monitoring point of view is get the patient to hop on a scale. If they are starting to gain weight, you're pretty much sure that you're on the right track. Then the next thing that we need to do is we want to monitor from a microbiological point of view. So we need a sputum smear and culture. We want one to start off with, so before we start treatment. And we do that to assess the burden of disease. Is this extensive? If it's 3+ on the smear, we know that the patient has a high bacillary load. And we want to culture also to confirm the test, just to confirm the resistance patterns and look for any further resistance. Please note, you don't need to wait for these. You can just start straight ahead. Then you need to do the smear and culture on the sputum every month while the patient is on treatment. So for the next 5 months, you need to do a culture to make sure that the patient is responding to treatment. On average, and of course average is average, not everyone fits into it, people will culture convert between the 1st and 2nd month of treatment. So they have a rapid culture conversion. There are times when it might be a little bit delayed for some reason, which I'll cover later, but we follow them up. There is some concern that this regimen is short. How do we know that there is not going to be any relapses? From the clinical trials, there were very few. But in addition to that, it's useful if you still have contact with your patients to repeat a smear and a culture at 6 and 12 months. Also to warn them that if they get symptoms similar to what they had before, they need to come in and we need to exclude a relapse. But it is a very uncommon situation. It is good practice to have a chest X-ray at the beginning of treatment and at the end. At the beginning of treatment, we can assess the extent of the pulmonary disease. Is there lots of TB or not too much? So how extensive is it? And then we'd like to see at the end that there is either complete or partial resolution. So sometimes we still see scarring and fibrosis on the lungs, but we'd like to see that the active disease is resolving. So it's good practice to have them both. How do we monitor for safety? I come from HIV, from South Africa, so HIV is always top of our list. But for all patients who've got TB, we need to test them for HIV. If they test positive, we need to know their CD4 counts, and then obviously initiate them on appropriate antiretroviral therapy. People with HIV do as well as people without, provided they are given suppressive antiretroviral therapy. We know that diabetes is a risk factor for acquiring TB, and that TB is worse in the face of uncontrolled diabetes. So we need to make the diagnosis if it's there. So you can either do an HbA1c. If that can't be done, you can even do a urine dipstick. If someone is a diabetic, we'll find sugar in their urine. We would like to know if they've got hepatitis B or hepatitis C. As we know in the recent guidelines, it's been suggested that you start treatment for hepatitis C during the treatment of rifampicin-resistant TB. So we'd like to know that. And of course, we want to know if any of our female patients are pregnant. If they're pregnant, then obviously they would be given the BD-LLC regimen as opposed to BPOM. Other safety things that we have to do, the first thing that we need to do is an ECG. Make sure that the QT interval is less than 500, and we're not going to go into the final details of women have slightly longer QT. If it's less than 500, it's fine. Check your patient's visual acuity, and that can be done really simply with the Snellen test. And remember, if they're wearing glasses, always do their visual acuity with glasses or without. Do choose which one you're going to do and make sure it's always the same. Then you need a full blood count. And if that can't be done or the turnaround time is too long, You can do a finger prick hemoglobin. If it's above 8, then you can go ahead and start. And then the last thing that we need to do is we need to just check that there's no liver dysfunction. The best test to do under these circumstances is an ALT, because that's really specific for the liver. If it's raised, then we know that the patient has got some liver problem. AST is also found in the blood and therefore can be confusing. So what are the things that are the same between BPAL-M and BD-LLC? The first thing is that you can start either without knowing the results of the fluoroquinolone DST. So whether you know your patient is resistant or not, you can go ahead and start it. We do suggest the use of some form of DST to the fluoroquinolones, but you don't need to wait for it. You can just start immediately. When you find that your patient is, say, fluoroquinolone susceptible, you alter the regimen, and it is considered as the same regimen. So the day you started the patient on treatment is day 1. You don't need to extend it in any other way. And you can use both of these irrespective of the severity of pulmonary disease. So if you look at the X-ray is relatively clear, start. If it's relatively severe, start. It doesn't make any difference. And you can use it in people living with HIV irrespective of the degree of immunosuppression. Next slide, please. And what are the other similarities? You can use it in uncomplicated extrapulmonary disease, couple of lymph nodes, not to worry. And you can extend both of them if there's a slow response to treatment. I just want to cover this issue of slow response to treatment. So if someone is still culture positive at month 3 or 4, there are 3 main reasons for this. The first one is that there is undiagnosed resistance. That what you have done without knowing it is that you've started someone on the regimen and they've got resistance to either bedaquiline, pretomanid or delamanid or linezolid. This is very uncommon, but when we see people not following the pattern, we need to start thinking about that and not change the treatment, but rather say, let's send off for investigation to confirm. The second reason that someone can have a slow response to treatment is that they have overwhelming pulmonary disease. That type of X-ray that you look at it and there's disease on both sides. So they're just on the outer edge of when they respond. And if you feel that they need longer treatment, the decision is made at about month 4. So at the end of the 4th month, if you think they're not responding because they've got overwhelming disease, continue them to 9 months. And the third reason why people do not culture convert, have a slow response, is they're non-adherent to their therapy. So at this stage, take a very careful history to assess whether your patient is taking their medicines. If they're not turning up on time to pick up their medicines, they're having missed doses. You can't buy these drugs anywhere else. So So what you need to do is just assess whether the patient is taking their medicines and encourage adherence. And the other thing is linezolid is the drug that causes the most amount of adverse events. And in both of these, linezolid is the driver of adverse events. Then what's different about the two? If we go to the next slide, please. The first one is BD-LLC can be used in children of all ages. It can be used in pregnant women at any stage of pregnancy, and it can be used in breastfeeding. We know that breastfeeding is the best way of feeding an infant. In a place where there is uninterruptible power supply and fresh water and all those things that you can safely bottle feed, you can consider changing to formula for feeding babies. But in a time when the baby is really dependent on the mother for breastfeeding, you can breastfeed. One of the technicalities around this is obviously breastfeeding is a very intimate thing, baby very close. And what we would suggest is that the mom wears a mask during the time that she breastfeeds. But we don't need to tell the mothers you need to choose between the best option for feeding your baby and a short treatment option. You can just go ahead and breastfeed with the use of BD-LLC. The other thing is that BPAL cannot be used in children under the age of 14. We're concerned about the safety of protominid. We don't know the doses in children. Also, we're a little bit concerned about testicular toxicity, probably not a real concern. But here we've got a regimen that we can give to the 5-year-old child, the pregnant mom, plus the dad who all live within the household. So we've got a short regimen for both. So that's one way they differ. And if we go to the next slide, the other way that these differ, and I'm sure you all know this by this stage, is that the cost of the regimen is very, very different. So if we give someone BPALM, and these are the figures that we used when we did the GDG, they've changed a little bit since then. But BPALM comes in at around $364. And it does seem like a lot of money, but in fact, it's probably the same as any of the others. So it's a relatively cheap intervention for patients with rifampicin-resistant TB. But unfortunately, delaminid is a very expensive drug. And the costs range between 1.3 and 1.4 thousand per treatment course. So obviously, if you have to use all 5 drugs, it's slightly more expensive, but of course, fluoroquinolone is the cheapest of all of them. So this means when the time comes for you to decide between the regimens, and at a national level, you need to decide what proportion of people do we think would require BDLLC? And I guess that the proportion is somewhere in the order of maybe 2 to 3% of pregnant women and 10% of children. But these are decisions that each country needs to make based on the epidemiology of TB within their own countries. So the main difference, the outcomes are the same, side effects are the same, they're both driven by linezolid. But the main difference between these two regimens is that the cost of the nitramidazole is very high. Next slide, please. So in summary, a 6-month regimen is the preferred regimen for people who have got rifampicin-resistant TB. We now have a treatment option for everybody who lives within the household. And you really have to need to think quite carefully for a reason to give a 9-month or even a longer regimen. The cost of the longer regimens obviously is higher, but the cost is also great to the patients. Patients need to come for regular checkups. They need to get transport to the clinics. And if we have an effective regimen with a low relapse rate, it makes a lot of sense to give a 6-month regimen. Yes, we know the side effects. And in my next presentation, I'm going to talk about the side effects of the drugs. So I'm going to end there and then go to my next presentation. If you could please share my next presentation, because I've only got recorded ones for some reason. While we're waiting for the next presentation, presentation to come up, just save up your questions about the indications for each, and then we'll take it from there. Let me see if I can share it with, oh no, this has got the voice on it. Okay, so now we're going to go to the management of adverse events. So what I'm going to be talking about, there are lots of ways that we can approach this. We can approach it by going through a list of what the adverse events are. But seeing as I've only got 15 minutes, my plan is to do the following, is that I'm going to go through what we expect the rates to be, and then I'm going to talk about the adverse events of special interest, the ones that we see that are related to these particular drugs. We can discuss the more unusual ones if you're interested, but really the bottom line is that these 5 adverse events of special interest are the ones that we're going to see. And there are myelosuppression, peripheral neuropathy, optic neuropathy, hepatotoxicity, and cardiotoxicity. Those are the ones that we're expecting to see. So how often do they occur? What I've done is I've had a look at the adverse event rates that we have seen in the various studies and compared, and to give us a clue of how many we're going to see. Adverse events are by definition a grade 3 or 4 event, so a moderate to severe event, an untoward event that occurs during treatment. Our patients are treated for a long time, so they're treated for 6 months or longer. And therefore, we expect many of our patients to have something going wrong, that they will get an intercurrent infection, maybe have an injury. But what we're really interested is how many of these adverse events are related to the drugs. And you can see if we have a look at the adverse event rate, they're around 17%. 17 to 25% of our patients will have a side effect that is related to the drugs. And linezolid is the culprit in almost all of these cases. So if we go to the next slide. So what I've done to make this easy is I've colored the adverse events of special interest by the causative agents. So the ones that are in bright red, and you will notice in the rest of the talk that most of them are in bright red, are adverse events that are caused by linezolid. Then yellow, I've chosen for hepatotoxicity, maybe a bit reminding us of jaundice. And then the blue one is cardiac toxicity. So let's talk about, if we can go to the next slide, myelosuppression. So myelosuppression can affect all of the cell lines, but it predominantly tends to cause anemia. And this occurs in the first 8 weeks of treatment generally. There are exceptions, but generally, if you can get your patient past the first 8 weeks, they will not become anemic. And the bone marrow is a rapidly dividing tissue. And what we need to, and because of that, usually a short interruption will give the bone marrow time to recover. If you see a patient who's anemic and has TB, this is not a case study worth writing up because this is a very common comorbidity. So we know our TB patients often suffer from undernutrition. They have an anemia of chronic disorder, and the chronic disorder is TB itself. Then HIV infection can cause it, as can sometimes our patients have massive or minor hemoptysis, so they can have blood loss. So anemia is not an uncommon comorbidity. A normal anemia, according to some of the toxicity tables, is about 14. A normal hemoglobin, rather, is about 14. But many of our TB patients, the hemoglobins are around 8, are between 8 and 10, just because of the comorbidity. If we go to the next slide, how do we manage and detect it? The only thing that you really have to do before starting any of the linezolid-containing regimens is you need to know what your patient's hemoglobin is before you start. If your patient's hemoglobin is above 8 grams per deciliter, start the regimen containing delaminid. Whichever one you're choosing, go ahead and start it. And then repeat it again in 2 weeks and keep a close eye on a change. You'll often find a change of, it'll go from, say, 10 to 9.5. That's okay. We expect it. Don't panic about it. However, if the hemoglobin is below 8 grams per deciliter, it's my opinion that these patients need to be admitted to hospital. They have severe disease with poor prognostic signs. You need to consider giving a patient a transfusion. I know that this cannot be done in many situations, but you need to consider it, particularly if there's signs of cardiac decompensation. If you do decide, so say you've got a patient who's stable with a hemoglobin of 7.5, if you do decide to start that patient on treatment, you need to keep a really close eye on them. And by that, I mean you need to repeat the hemoglobin every week thereon. So someone who's already anemic, keep a close eye on. You need to warn the patients what the signs and symptoms of TB, of anemia are. And I said TB by mistake because there's often an overlap. So anemia causes our patients to be fatigued. They have malaise. They feel short of breath. And I'm sure you're all thinking, oh, that's exactly the same. That's what TB does as well. So just say to your patients, if you have some symptoms that are getting worse, please come in and we'll check your hemoglobin. Please note, you cannot start any of the linezolid-containing regimens without linezolid because of the presence of anemia. You either have to go for a regimen without it, So without regimen, without linezolid at all, or alternatively, you need to correct the anemia and then start 3 or 4 drugs depending on, or even 5 depending on the regimen. Then if we go to the next slide, every 2 weeks for the first month, you need to continue to monitor. You need to do at least a hemoglobin. We'd like to get all of the cell lines. We'd like to know the platelets and the white cell counts, but at least the hemoglobin we have to know. If it drops below 8 grams per deciliter, I think this patient should probably be in hospital if at all possible. Then you ask the patients if they've got worsening symptoms of TB, and then you look for signs. The signs of a worsening TB is decompensation. So what you see is a tachycardia. You may hear a flow murmur. So if you see any of those, you probably need to transfuse the patient. Need to interrupt linezolid. So you stop it, but just for a short time. This is not the kind of thing that you can stop the linezolid and then say to the patient, I'll see you again in a couple of weeks' time. What you need to do is you need to restart as soon as the patient recovers. And even if you just interrupt linezolid for, say, a week, you'll often find a response in the hemoglobin. You can reintroduce. We suggest generally at the full dose, but some practitioners believe it can be at the half dose. Warn the patients about the signs and symptoms. But while linezolid is our problem drug, the one that causes the most side effects, is also one of the most important drugs early on. So we need to keep the interruptions to an absolute minimum. So as soon as the patient is stable, we need to get them back onto linezolid. If we go to the next slide, what we need to do is we need to, the next part of myelosuppression is neutropenia or thrombocytopenia. I'm sure if you've had a look at your patients' full blood counts, you've seen that many of them have a high platelet count. So they have a thrombocytosis. That's because it's an immune phase reactant and it's often high. So we very seldom see thrombocytopenia. I've seen it maybe once or twice, and then usually the cause of the thrombocytopenia has been something else. In the one case, I saw an ITP. Neutropenia and thrombocytopenia are measures that change on an almost daily basis. So if you see a neutrophil count of below 0.75 or a low platelet count below 100, then what you need to do is rather repeat the blood before you stop the linezolid. So bring the patient back in and check that it's really a real finding. If it is, again, interrupt therapy and as soon as possible, reintroduce. Bone marrow is rapidly dividing, so it gets better much quicker. And if we go to the next slide, I've talked about the bone marrow. Then the next side effect is the one that people tend to fear most. And in many ways, I'm not afraid of this because I think that it's something that the patients will tell you that they have, and you just need to keep an ear out for them. So in terms of peripheral neuropathy, you as a clinician need to be aware of it, and you need to tell your patients. And I use it quite similarly. Every time I see them, I tell them, watch out. If there's a problem with your feet, and it can be pins and needles and pain, and it can be something like what we call paresthesia, a slightly altered sensation in treatment, in the feeling in the feet. So tell the patients that this can happen, and if it does happen, don't worry, you know what to do. There are also competing risks for the development of peripheral neuropathy. Diabetes, HIV, alcohol can be quite a problem. And then other medications that your patients may have taken in the past, like INH, can also cause it. Peripheral neuropathy tends to occur late on in treatment. And again, by the time it occurs, you should have seen your patients 3 or 4 times, and they should have got used to you saying, do you have any problems with your feet, and tickling the feet and making sure that they're okay. So it should be something that you think about. If it occurs, then you interrupt therapy. And I'll talk about how to do it on the next slide. So a very simple schema, and I really like this this visual analog scale that you ask the patient, and do you have pins and needles or pain or problems in your feet? And it's very important if it interrupts their daily life, particularly sleep. If the patient is struggling with sleeping, then there's usually a moderate to severe. And ask them at every single visit, show them the picture and say, are your feet bothering you? Are you waking up with aches and pains and problems in your feet? Show them the picture and let them pick it out and then document it. And you'll see it when it's coming. But again, I'm not saying it's not a bad side effect, but the thing that's useful about it is that the patient knows it's coming. And they can tell you, and you can be warned. So what to do if we go to the next slide, if someone presents with peripheral neuropathy? If we go to the next slide. If it occurs late on, so if you can remember, I said most people culture convert at about the end of the first or second month. If it occurs late on in treatment and the patient has got an established good response to treatment, interrupt the linezolid only. So this is a side effect that's caused by linezolid. You don't need to interrupt anything else. You just interrupt the linezolid. And then you wait for resolution of symptoms. So in a patient who's doing well, they've culture converted quite a while, the truth is that a resolution of symptom takes quite a while. It usually takes 3 or 4 weeks. And sometimes by the time you get to, the patient gets peripheral neuropathy at week 20, say, by the time you get to week 24, treatment is over anyway. So you can use the balance of the drugs in that time. Now, of course, it's much more difficult if peripheral neuropathy occurs earlier on when there hasn't been an established microbiological response. Doesn't happen that often, but if it does, interrupt the linezolid only. So you don't need to interrupt everything else, just the linezolid. And then you monitor for signs and symptoms of the peripheral neuropathy. Once it's got better, then this is the one time that I would say reintroduce at perhaps a lower dose. So say you get peripheral neuropathy at week 10, you interrupt for say 2-3 weeks, patient starts to cope with the peripheral neuropathy, then you reintroduce. Linezolid is a key drug. So even though it gives us bad side effects, what we do need to do is to restart it as soon as possible. So then the last side effect, if we can go to the next slide, is optic neuritis. This is an idiosyncratic reaction. We don't really know how to predict who's going to get it and who's not. But what you need to do is you need to establish your patient's visual acuity before you start treatment. You can see I'm wearing glasses, so therefore I don't have perfect visual acuity without my glasses. But you need to establish the routine that you test one eye and then the other eye at every single visit. If there's 2-line drop, so if someone could see perfectly, so that we call that 6-6, and then suddenly they can only see to line 4, your patient has optic neuritis until proved otherwise. So interrupt the therapy. This sign and symptom does in fact resolve fully. So it will get better. But the longer you leave it, the less chance you have of full resolution. But it usually gets better. If you are skilled, and I'd like to say very clearly, I'm not, but if you are skilled and you can assess the fundoscope, you can do fundoscopy and you can decide whether your patient has got optic neuritis or not, go ahead and do it. Sometimes we find other causes for the visual disturbances. I've had patients who've developed cataracts, but in general, you assume that this is optic neuritis until proved otherwise. In this patients, you need to interrupt the treatment and probably stop it altogether. And then we use the same guidelines, as I said before. If it occurs late on in therapy, you can continue with the balance of the drugs. If it occurs early on, then you probably need to find a new longer regimen without linezolid. Next slide, please. So hepatotoxicity in the color of jaundice. So there are competing risks for hepatotoxicity in our patients. There's alcohol, there's viral hepatitis, both B, C, and even A. And then there are other toxins that the patients may ingest either on purpose or by accident. The principal causes of hepatotoxicity in our patients are INH and PZA. So PZA is in all the new modified regimens, and INH occurs in the older 9-month regimens. The other drugs that can cause it but are very uncommon are the ones that I've listed below. What I want to mention about hepatotoxicity, it is often asymptomatic. So what happens is the patient comes in, they're not jaundiced, you do their blood tests, and then the following morning you get the results and they've got an ALT of 350. So that is a grade 3. And you phone them and you're in a panic and you say, please come in, I want to check and stop your bloods and what. And the patient goes, but I feel fine. I'm not nauseous. I don't have pain. So watch out. This is often a biochemical hepatitis. If we do not stop the therapy, it's possible that your patient can proceed on to full liver failure. So we do need to keep an eye on this. In the end, tuberculosis studies, what they did is that they found that this occurred in about 11% of patients with PZA. So it is something we need to watch out for. In terms of advice for people who do consume alcohol, you're not going to get it right telling people never to drink again. Rather tell them to reduce the alcohol and perhaps, not to drink too much and definitely not to forget their pills. So if we go to the next slide, how do we manage it? So we should be doing monthly transaminases. So if you can only do one, do ALT. And then if the ALT, the normal lab value depends on your laboratory, it's somewhere between 35 and 45. If it's between 2 and 3 times the upper limit of normal, keep an eye on it. And by that I mean repeat it perhaps every 2 weeks, but don't stop the treatment. If, however, the patient has a grade 3, which is 5 times or 20 times the upper limit of normal, so that's up to 400, then you need to stop all the TB medicines, see if your patients are taking anything else that could be harming their liver, particularly alcohol, and then you can reintroduce the therapy once the hepatitis has settled down. Watch out if the patient has symptoms. This makes the stakes much worse. You need to then think about cutting back much sooner. If the patient had PZA in their regimen, you can never give PZA again, even if you find another cause for the hepatotoxicity. We don't want to add hepatic toxins in. So it doesn't matter what the cause is. If the patient gets hepatotoxicity, they can never have PZA again. If it's a grade 4, then we probably need to stop all TB drugs and to fashion a completely new regimen. Fortunately, this is very uncommon, so this doesn't happen very often that we see such severe hepatotoxicity. Next slide, please.
Sorry, Francesca, maybe you have 2 minutes more. Thank you.
Okay, cool. So prolongation of the QT. QT prolongation is a QT above 500. It doesn't happen very often. And in my experience, when it does occur, it's usually something other than the TB medicines. So it's either the things that I've listed on the slides, so a change in electrolytes, need to measure sodium, potassium, calcium, magnesium, and phosphate. Some of the drugs do cause hypothyroidism, check for that. Look for other QT prolonged drugs. For example, some of the over-counter antihistamines can prolong the QT, as can clarithromycin and amitriptyline. And if it is persistent, you need to stop the moxifloxacin. Next slide, please. So this is what the side effect that we're worried about looks like. It's called Toussaint de points. I have to say that I've treated and been involved in the treatment of thousands of patients. I've never seen this. And what we need to ask if we have a prolonged QT is if the patient has any other symptoms that's suggestive of cardiac origin. For example, syncope, or if you measure something unusual on the ECG. This is not common. We do the ECGs, we check them, but this is not a common side effect. Next slide, please. So this is just how we deal with this. If you look for signs and symptoms of a serious arrhythmia, If it's above 500 with no signs and symptoms of an arrhythmia, continue. If it's above 500 with signs and symptoms, then what you need to do is to stop and then probably avoid any cardiotoxic drugs from there on. Fortunately, doesn't happen very often. So in summary, in my last slide, so we now have 7 short regimens. We have 2 6-month regimens and 5 9-month regimens for the treatment of rifampicin-resistant TB. This is a huge breakthrough. We used to treat our patients on terrible medicines for up to 18 months. And I had patients say to me that the side effects are worse than the TB itself. Now we've got 2 6 months and a bunch of 9-month regimens. The adverse events are predictable. I've told you when they occur. So they occur early on if it's related to the bone marrow, later on if it's related to the nerves. And we can manage almost all of these at a primary healthcare level. So you can treat your patients at the clinic without having to refer them anywhere else. We've got to be a little bit cautious about what we give to children and pregnant women, and I've described which is the best regimen for that. And with that, I will end. Thank you very much for your time. I'm open to questions.
Thank you, Dr. Francesca, for nice presentations. So now floor is open for 5 minutes only for question and answer because we are running around 35 minutes late from our schedule. So only 5 minutes question and answer, please. No questions. So I have one question, Dr. Francesca. I'm Dr. Naveen from Nepal. So I'm Dr. Naveen from Nepal. I have a questions like you have seen in this 6 BD LLC regimen, there is 25% adverse event is the moderate grade 3 to 4. So what are that? And what about the QT prolongations in 6 DDLC regimen as it has 4 drugs that can cause the QT prolongations? And also for like BPAL regimen, we cannot stop or reduce the dose of linezolid in first 9 weeks of therapy. But what about in this regimen, please?
Okay, good question. So we start off with what were the adverse events? They were principally anemia. So that was our most common adverse event that occurred. And then second to that was peripheral neuropathy. We had a few patients who had hepatotoxicity. So again, these are all manageable and predictable. In terms of BD-LLC, there's only two real QT prolonging drugs, and that's bedaquiline and clofazimine. Levofloxacin doesn't really have an effect on the QT interval, and much less than, say, for example, the interval than moxifloxacin. And delaminid does not have an effect on the QT. There seemed to be a bit of a signal in the phase 2 study, but since using that, since more and more information has come out, it doesn't really cause a QT prolongation. So then the third question was, can we reduce the dose in the first 9 weeks? The answer is no. So if you've got a side effect that occurs in the first 9 weeks, you need to stop the therapy for a short period of time. Again, as I mentioned before, it's usually myelosuppression. So you can interrupt for a short period of time and then reintroduce at 600 milligrams. They respond really quickly to treatment. And I'm not sure if someone's going to ask the question about erythropoietin factor. Can you use it? The answer is, I don't know. And the reason I don't know is that the use has been anecdotal. It can be used, it has been used in some countries, but we don't really know if it works fast enough. It's certainly a drug that's used a lot. If you have access to it, it certainly can't do any harm. But no, you can't reduce the dose in the first 9 weeks.
Thank you.
I think that I've answered all your questions.
Yes. Next
Thank you.
question, please.
Yeah, Francisco, thank you for the presentation. So, and my question is regarding the other dosing mechanisms using the 200 milligrams, then 100 milligrams. Right, so okay, because for the previous dosings, we know that we have a loading dose for 2 weeks, then go to 300 or 200 milligrams 3 times per week. So, but here we have 200 and 100. So now if a patient has an interruption, for example, like about 3 to 4 weeks, so and we should restart again, should we start with 200 or we should continue with the 100? Or if the patient also is transferred to an other regimen where we also still have bedaquiline in it. So, and there was an interruption period of 3 to 4 weeks. Thank you.
Yeah. So I think it's very clear for the 400 milligrams, but I don't fully know the answer to so the 200 going to 100, it's not really a loading dose. The 400 was a true loading dose that we got the level up really high and then drop back down again. This is kind of, we just go a bit slow and we get to steady state. I think that I'll look up the references and get back to you on this. I'll search the references and speak to people about it who know a little bit more, and then get back to you by the end of, it's going to have to be pretty soon because your day is already halfway done. But I'll look it up and get back to you.
Okay, thank you.
Any more?
Hi, Francesca. Thank you very much for the presentation. I was wondering, given the cost implications of the choice for either of the regimens, and also, so I was wondering the number of people benefiting, having additional benefits from introduction of the Beat TB regimen, of course, are mostly children and up to 14 years, and pregnant women. Currently, these form very much a minority within the people diagnosed with MDR-TB. Doesn't mean they are not there, but definitely they will stay a minority. I hope so. And but what about pregnant women? What is your experience in the proportion of pregnant women among women being treated for DRTB?
Agnes, I can only take a guess at it. So first of all, when you get sick, there is reduced fertility. So women generally don't, if they're sick with TB, generally don't fall pregnant, but they can still. I think that the rate of pregnancy, so TB, drug-resistant TB occurs on average at about 35, 36 weeks. So it is a time when women can have children. My guess is it's between 2 and 3% at the very most. In the beat tuberculosis regimen, it was when we did the study, there were 10 out of 400, so that's 2.5%. But we went to antenatal clinics and we screened for TB. So we were actively seeking them out. So that's my guess. And I think each country's got to sit down and look at who's getting TB within their borders and then decide. Some really conservative people might say that women who don't want to use contraception but are sexually active should be getting the BDLLC. And I think it's got to be a decision made at a country level. And depending, some countries TB occurs at older ages, and then in that case, the risk of pregnancy is less.
Okay, thank you. I think we are very late for lunch. One of very small questions for me, like duration of regimen, like in BPAL-M, if we want to go for BPAL, we can extend the regimen to 9 months if the culture conversion is delayed. What about this BPAL, BDLC, BDLL, and BDLLC? Is there the same durations or duration is different?
The same. So if you've got a delayed culture conversion, then you can extend to 9 months, so to 36 or 39 weeks.
In all the 3 regimens, same?
In all 3, yes.
Yeah, okay, thank you.
I would just like to say, when we did the study, there were 2 out of the 200 patients who required an extension, so it's uncommon. But I think if you're worried, and the patients are tolerating the drugs well, go ahead and extend.
Thank you.
If you feel the response is slow.
Thank you, Dr. Francesca. So this is the last question. Okay,
Yes.
last small questions. Okay.
Thank you, Francesca, for the very good presentation. I'd like to ask, because I've noted in one of the monitoring that you presented is the pregnancy test from the start of the treatment and monthly while the patient is on treatment. May I know why, or is this will this be part of the programmatic when countries implement, as well as what will be the intervention or management? Because this is not really, I mean, even if they're pregnant, they are eligible for this regimen.
I think that it's good practice in all women of childbearing potential who are sexually active to do a pregnancy test. In this study, because studies are different, we did it at every month. But in fact, to do it just once is enough. I think if a woman falls pregnant while on TB treatment, the program has failed her, because what we really should be doing is offering some form of family planning advice to all women who are on TB treatment. It's just not a good scenario. If you start a woman on BPAL or BPAL-M, and then at month 3 she comes and says, my period is late, and you test it, and you find that she is pregnant, then all you need to do is to swap immediately. You have changed, you'll only be changing the pretominid and the quinolone. So you'll be changing those two. And again, the treatment starts at the first day of treatment. So you don't need to then give her another 6 months. But again, it's, you don't have to do the pregnancy test if the woman is not at risk of pregnancy. So if she's either not sexually active or alternatively is postmenopausal. I hope that answers the question. Thank you.
Okay, thank you, Dr. Francesca, for giving such a nice presentations and your effort of bringing from injectable regimen to oral regimen, and now again for pregnancy and child regimen also you have shown to us. So thank you very much for your presentations. And I think give a big round of applause for Dr. Francesca. And now we can move for the lunch. And then after lunch, again, we have another sections because we are late. So another sections will start at 1:40. So please arrive in the classroom for at 1:40.
Yeah, sorry, because they say that we have to go for lunch now. So, and we are having lunch here. So in the first hall. So it's called Iris. That's where we are having lunch. And at least if we can make it within 40 minutes so that we can continue, because we still have presentations that we need to continue. So, and the presenters online, please, we are sorry, we have to go for lunch, and we'll continue the presentations maybe in 40 minutes. Thank you.
Manza, it's Sabine here.
Yes, Sabine.
Can you hear me? The timing is becoming a little bit problematic because I have a lot of other meetings later this morning. So I'm not sure if it's possible to still continue before lunch.
To continue before lunch?
Yes, because I was scheduled to have presented at 7:30 our time, and it's 8 o'clock now. And I'm having other meetings this morning.
Okay. Okay, just give me one.
Sorry about that.
Yeah, let me find out from our team. Okay, maybe we'll have the presentation of Sabine. Then after that, we'll go for lunch. So the team will negotiate with the hotel to have the lunch a little bit later. Okay, Sabine, maybe we can continue with your presentation.
Okay, thank you. And can you just let me know if you want to share the slides from your side, or I should do that?
No, you have the access. You can try and see if you can share.
Okay.
Okay.
Thank you. Mm. I think I need to share this one. Sorry, I just need to figure out which screen I need to share. Maybe you can, it's better if you share on your side because it's a bit difficult to
Let me
get it
share
right.
it.
Yeah, thanks. Thanks so much. Okay, perfect. Thank you. Thanks so much for your flexibility and apologies for the inflexibility on my side because it's morning here and meetings are going to start soon. So my name is Sabine Verkuil. I'm working in the Global Tuberculosis Program as a medical officer, mainly focusing on TB in children and adolescents, as well as other risk populations. And I'm presenting on behalf of our team. Our colleagues, Annemieke Brands and Kerry Wijnia are also online. So, and I'll be talking really about the management of drug-resistant TB in children and adolescents and the implementation considerations of these new regimens. If you go to the next slide. So just to start with some epidemiology, it's estimated that about 1.25 million children and young adolescents under the age of 15 develop TB every year. So that works out to about 12% of all people with TB. And almost 200,000 of them die every year. So that works out to less than 3 minutes. Less than every 3 minutes, one child or young adolescent dies of TB. And if you look at the mortality, the majority of mortality is in young children, and the majority of mortality is in children and young adolescents who have not been accessing care and treatment. If you go to the next slide. This slide shows some of the data we are collecting at the global level, and countries have been reporting on initiation of second-line treatment in the age group below 15 years since 2018. And you can see that the numbers are fluctuating a bit between 3,000 and 5,500 children and young adolescents a year, which works out for last year to about 2.5% of all people with drug-resistant TB who are started on treatment. So if you then work that out in terms of the treatment coverage on the right-hand side, you see that pie chart out of an estimated 30,000 children and young adolescents who develop drug-resistant TB every year, only about 14% are actually started on treatment. So we have a big gap in TB overall, but the gap in drug-resistant TB treatment coverage is even bigger. The next slide shows some data from the two regions who are in this workshop, so the Southeast Asia region and the Western Pacific region. And you can see that for the Southeast Asia region, about 2.7% of all people who are initiated on second-line treatment are below 15 years, and the majority are in India. And in the Western Pacific, that proportion is only 0.7%. So there's very few children and adolescents actually being diagnosed. The majority from the Philippines, China, and also Papua New Guinea. If you go to the next slide. So it's always good to understand what the reasons for the treatment coverage gap are. And there's recently been a publication on a pediatric drug-resistant TB individual participant database, which was really a huge IPD with almost 24,000 records. But if you look at the data, you can see there's a high proportion of adolescents and also a high proportion of bacteriological confirmation. So these data suggest that young children with drug-resistant TB are not detected, and treatment is seldomly started in the absence of bacteriological confirmation. If you go to the next slide, we do know the risk factors for MDR or rifampicin-resistant TB in children and adolescents, which include contact with a person with confirmed drug-resistant TB or with someone with presumed drug-resistant TB. For example, if the source case did not respond to treatment or is currently being retreated for TB, or someone who recently died from TB. And therefore, contact investigation is really a critical intervention to identify children and adolescents who are exposed to drug-resistant TB who need further evaluation. And then if you click again, other risk factors are a lack of response to first-line treatment after 2 to 3 months, despite good adherence, and recurrence of disease in those who were previously treated, especially if they were treated in the past 2 months. What's also important to note is that if you use treatment decision algorithms and you have children who have a decision to start treatment, they need to be assessed for the risk of drug-resistant TB before they are started on treatment. So to avoid starting them on first-line treatment while they actually need second-line treatment. Next slide. So generally, healthcare workers need a very high index of suspicion for drug-resistant TB. And when it is suspected, it's critical to try and collect suitable specimens for bacteriological testing. And of course, I think it was on the first or second day, you've heard about the new recommendations on concurrent testing with different samples for children. So a respiratory sample and a stool sample, which really increase sensitivity, leading to fewer false negative results. So that's a very important strategy that is needed to increase bacteriological coverage. But as Francesca was also saying, if bacteriological testing is negative or it cannot be done, a clinical diagnosis can be made. And of course, detailed guidance is needed to be included in national guidelines to make that a reality. And then for the treatment, the drug susceptibility pattern of the child themselves or the most likely source case, that is then what informs the choice of treatment. You go to the next slide. So in terms of treatment, now we have a lot of new options for treatment, but of course, bearing in mind that we need to ensure that children can benefit. So we need to find them first before they can benefit of this better treatment. But basically, if you look at the latest guidance of WHO, in 2022, the age limits for the use of bedaquiline and the use of the laminate were basically removed. And those recommendations really apply to all current WHO recommendations. And that includes, of course, new recommendations that are coming out. So at the time that applied to the 9 months regimens that were available, as well as the longer regimens. But of course, now we have new options that are shorter. And those recommendations apply to those as well. If you go to the next slide, we have some resources as well, information notes on bedaquiline and laminates, which provides really very practical guidance on how to use those two drugs, how to use it when you have the child-friendly formulations, how to use those drugs when you don't have the child-friendly formulations, and the dosing as well. So those are useful resources. And you'll get these slides so that you can get the links to those documents. If you go to the next slide. So this is really the summary of the new recommendations. The first one on the beat tuberculosis regimen that you heard Francesca talking about. And as she was saying and highlighting the indications for this regimen, very important to note that this applies to children, adolescents, people with HIV, pregnant and breastfeeding women as well. Of course, it can be used in both quinolone susceptible and resistance. And then at the bottom there, you can also see that those who do not have bacteriological confirmation of TB or the drug susceptibility testing, but who have a high likelihood of MDR or rifampicin resistant TB based on a clinical diagnosis are also eligible for this regimen. And the same for the next slide, which is the slide on the 3 end TB regimens that are now being recommended only in quinolone susceptible TB. And again, the age indications are the same. The type of TB is listed there as well. And again, children and adolescents who have a clinical diagnosis are also eligible for those 3 regimens that are recommended. So if you go to the next one, you'll see sort of the mapping of options for drug-resistant TB treatment for children and adolescents. Of course, as Francesca was also highlighting, BPAL-M and BPAL is only recommended in the age group 14 years and above. So the 6-month regimen BDLLC becomes really an important option, short option, for those who are aged below 14 years. Irrespective of quinolone resistance. So that's your 6-month option. And then in addition, we have more 9-month option now. So that includes the 3 NTB trial regimens, which are slightly preferred over the 9-month regimen that we already had, mainly because of the pill burden. The other 9-month regimen includes 7 drugs in the first phase, and that can be quite a barrier, even if you're using child-friendly formulations. And then, of course, there may be children who are not eligible for those shorter regimens, who still need longer individualized regimens. And then in the next slide, I've tried to sort of depict some of the considerations for choosing pediatric drug-resistant TB regimens. It's sort of a mind map, and I'm pretty sure it's not really complete. So there may be other factors, but these are just some of the most important ones. So firstly, the age of the child, and then severity of disease in terms of whether the child has non-severe TB or severe pulmonary TB or severe extrapulmonary TB. That will determine your choice of regimen. Then also the pill burden, the formulations available, whether or not there's bacteriological confirmation, and then basing the treatment on the DST of the source case or the child himself. Of course, the cost, as Francesca also already highlighted, of the drugs. The monitoring ability, whether you can do full blood counts, ECG, and also the level of care and the supervision and mentoring that's available. Just almost lastly, to highlight the importance of child-friendly formulations. They should always be used whenever they are available and when it's possible, and also included in funding requests to the Global Fund, for example. There are now child-friendly, usually dispersible formulations of all second-line drugs, and that includes bedaquiline, delamanid, and linezolid. And these are all available through the Global Drug Facility. And you can see there the list of the medicines and also the links to the medicines catalog. So lastly, a little bit on dosing. We also have detailed dosing guidance for second-line treatment, and this is currently included in the Module 4 operational handbook with weight-based dosing of medicines used in MDR-TB regimens, covering basically all weight bands from 3 kilos all the way to over 70 kilos. And then to note is that there is a weight-based and age-based approach for bedaquiline and laminate. And then the dosing guidance that is provided using child-friendly formulations, which is of course preferred, but it also provides guidance if you have only adult formulations and how to use those. And of course, the final approach to dosing will depend on the formulations that are available in the country. And there's also, just to mention, in the knowledge sharing platform application, there is a dosing calculator as well that can be very helpful to determine the correct dosages for children and adolescents. So that's my last slide. I just want to acknowledge our colleagues, our director, unit head, as well as Annemieke, Kerry, and Tiziana. Thank you so much.
Thank you very much, Sabine. And any question from the floor?
I think we can take 2 questions.
Yes, please.
We take 2 questions even.
Please.
Hi, Sabine. Thank you for your presentation. I have a question, which actually also was a question for Francesca, maybe, but we're currently talking about the shorter regimens, and all these shorter regimens are bedaquiline and linezolid based. And of course, currently, this combination, the effectiveness of the regimen is still very high. Having said that, we know that sooner or later we will find a patient who cannot tolerate the regimen or will be irresponsive for another reason, and you have to find an alternative regimen. And then we will not be able to use bedaquiline, linezolid. Maybe clofazimine will be compromised, and the clofazimines. Sorry, the fluoroquinolones. So we will be really stuck with the old ugly ones, drugs, I mean. So is there any work being done currently at WHO to provide guidance for that situation? I'm just looking ahead for a future that hopefully will not come, but we have to be ready for it.
Yeah, thanks very much, Agnes. Yeah, so obviously the work that is done at WHO will depend on the evidence that is being generated. So we are always interested in new drugs. And of course, we are tracking very closely what is happening on the research front. There are new components in evaluation. And of course, one of the things is to really speed up the evaluation of new drugs and new regimens, and also to make sure that the delay of getting them approved and licensed for adults, between getting them approved and licensed for adults and getting them approved and licensed for children is reduced. And I think I saw Lindsay online, who is involved in the Cheetah initiative, which is an important initiative to reduce that delay in those new compounds becoming available for children. So that is one thing. And of course, the other thing is that at the moment, if a certain drug cannot be used, which means ruling out certain regimens for children, but that applies to adults as well. Of course, there's always still the longer individualized regimens that can be used. So one based on the tolerability and efficacy resistance pattern of the drugs that are currently available, it's always still possible to build a regimen with those drugs that are still tolerated or that are still effective. Of course, in the case of children with a clinical diagnosis, it's a little bit harder to know exactly what the strain that a child has is sensitive to, but that is the general principle. I'm not sure if that answers your question.
Sabine, another question, please.
Yes, please.
Thank you, Sabine, for your presentation. I have two questions. The first, sorry to be persistent about the question on dosage. So considering that we may be dealing with small children with these regimens that are now that may be used for children, do we apply the weight-based dosing for all the drugs in the components? And the second question is about concurrent testing. I understand the advice is to do both stool and sputum samples collection together or more or less at the same time. But if you already have a positive stool result, that means, am I correct that you can do away with a pulmonary sample? Because in children, we don't want to do gastric lavage if they cannot expectorate.
Thank you so much, Mamel. Those are great questions. So in terms of the dosing, the guidance that we're currently having is the weight is dosing guidance in weight bands, and they cover the full range from 3 kilos. So those are neonates up to over 70 kilos. And that the dosing for bedaquiline and laminate has been is based on an expert consultation that was held during the development of the 2022 Module 5 Guidelines and Operational Handbook. So that then used the latest PK data at the time to come up with a dosing strategy. And if you look at that dosing table, you will see that for bedaquiline and laminate, there is an age and weight based approach. So for example, for the lowest weight bands, if you have a child that is below the age of 3 months or over the age of 3 months, there's different dosing for those age categories. And the same applies for the second and third weight band in terms of whether the age is below or above 6 months. The dosing is slightly different, and that really reflects the issues around maturity of the enzyme systems, etc., in terms of drug metabolism in very young children. Now, if you have infants that are weighing less than 3 kilograms, you will need to consult with an expert in pediatric drug-resistant TB to determine the right dosages. But generally, that guidance applies from 3 kilograms of weight. And in terms of the concurrent testing, and I'm sure my colleagues from the diagnostics team can chat to you as well, but the concurrent testing strategy is really to improve the sensitivity to pick up more TB. But of course, if you have one of them that is positive, so maybe you might even start with a stool and then do a respiratory sample. Any one of them can lead to the diagnosis, bacteriological confirmation, and can inform the decision to start treatment. So if you already have a positive stool test, there's no need to go and do a gastric aspirate or try and get a sputum. So that is an important issue. It's really meant to increase bacteriological coverage and bacteriological confirmation, but any one of them that is positive should lead to a decision to treat.
Okay, thank you, Sabine, and please give Sabine a big round of applause for this insightful and informative presentation. Thank you very much.
Thank you.
So now I think it should be time for lunch, the real lunch now. So we have to come back again at 45 minutes. 40 minutes for our lunch at the first floor. So we'll be, yep, 2 p.m. and 10 past 2, we will be here. Thank you.
Alo. 1, 2, 3, 4, alo.
So shall we start? Gordon, are you ready for sharing with us? Yes. So now, so we can have a seat, and then the next session will be Gordon from Papua New Guinea will share with us about the updating pediatric TB DRTB guidelines experience from Papua New Guinea. Gordon, the floor is yours.
Requested all to be seated. Please sit.
Good afternoon, everyone. I'm Gordon Pukai, a pediatrician from Papua New Guinea. Just continuing on from Dr. Sabine's presentation previously, I'll be sharing our experiences with DRTB treatment for children back in Papua New Guinea. So for the purpose of this discussion, we wanted to see how we approach MDR treatment in children back in Papua New Guinea. This is a 5-year-old girl who has been on DSTB treatment for 5 months. And now she presents like that in the picture. The auntie brings her in. The auntie is a very poor historian. You find out that another auntie was treated for clinical DSTB in 2019. Apparently, she died 6 months into TB treatment. However, records couldn't be located at the hospital. So for this child, there was no weight gain, had severe acute malnutrition, HIV was negative, with a weight of 11 kilograms. She can't sit up, only can be held, and she appeared tired. So that's how she presented on admission. Okay, so her gene expert that was done for gastric aspirate was MTB not detected. So what to do? So we asked the lab nicely to send a sample for culture. We asked the lab nicely to send the sample for XDR cartridge. So what did we do? How did we treat this girl? So we started MDR TB treatment based on the clinical TB treatment failure. So this was an X-ray 5 months into TB treatment. So lessons learned from this case, it's always a challenge for pediatricians, when the gene expert is negative and or your ability to work up with other differential diagnosis is limited. So this can lead to overdiagnosis and treatment of TB when it's actually not TB. That's why it's very important for clinical evaluation, and contact history is critical in pediatric cases. So these children usually present with severe TB disease and are not eligible for the shorter regimen of MDR TB treatment. So some of the data from the Port Moresby General Hospital. So with the treatment success rates, you can see from the green line graph. So our treatment success rates are around 75 to 80% every year since the establishment in 2016, when the Child TB and HIV Project, which was an initiative of the Pediatric Society of Papua New Guinea funded by the Australian government to actually try and combat the problem with childhood TB in Papua New Guinea. You can see from 2024, we recorded the highest number of MDR TB cases, which was 50 from the annual 30 cases that we diagnose in children. So the number of cases that are confirmed via gene expert is usually around 40 to 50%. Our best years were in 2020, 2023. There was a drop last year because most of our cases were diagnosed clinically, and as well as lack of gene expert cartridges at times last year. So discussions about MDR TB treatment in Papua New Guinea for children. So this is the scope of the journey that PNG was using in terms of MDR TB treatment for children. We diagnosed our first case, pediatric case, in 2014. So from 2014 to 2016, PNG was using the long regimens with injections 18 to 24 months, and the list of the drugs, as you can see. Then in 2017, short course was an option for some, but still with injections. Otherwise, we stick to the longer 18 to 24 month regimens. In 2019, that was when we stopped all the injectables, but we used a longer all oral regimen for 18 months, which we adopted a 2019 Sentinel field guide, which was bedaquiline, delamanid, linezolid, levofloxacin, or clofazimide. And in 2024, we adapted the 2022 Sentinel field guide, which was the 12-month regimen with the drugs, as you can see. So how PNG updated the pediatric MDR guidelines? So there was close consultation with outside pediatric experts, including WHO, meeting with pediatricians, forming the Pediatric Society of Papua New Guinea. We actually tried to understand how the problems and the gaps that PNG has to face with the implementation of the MDR guidelines. So these were the following kind of questions that the Pediatric Society were having in terms of changing regimens during treatment, how to deal with severe and non-severe TB disease, and what if we don't have drugs to treat? And can we simplify these regimens and not have multiple options? So going back to 2019, that's when we stopped the injectables because of the toxicity and the hearing loss that these kids were faced with. It was quite depressing as pediatricians to see kids having these problems from TB treatment. So we opted for the 2019 Sentinel guide, which was the 6 months of bedaquiline, linezolid, levoflox, clofazimide, and then bedaquiline was ceased at 6 months to continue the other 3 drugs for the next 12 months. So this slide was taken from Dr. Sabine, mapping the situation, the regimens that WHO offered, and you can see the BPAL regimen on the left. For pediatrics, we were given the 9 to 11 month regimen, and or either the longer individualized regimens. Okay, so with BPAL, introduction is good, but only for adults. Now the WHO 9-month regimen was a challenge for PNG due to resistance profile in PNG, which we'll discuss that later on. High pill burden, these kids have to take 7 medicines. This regimen may not be appropriate for severely malnourished kids, which means that we might be potentially using 3 different regimens based on the regimen for non-severe TB disease, a regimen separate for severe disease, and another regimen for cases with CNS disseminated osteo TB. So this study was done with from one of our late professors, and also with Jennifer, studying a subset population in the 2 hotspots in Papua New Guinea, which was NCD and Western Province, to try and see which drugs were resistant, these patients were resistant to. So from the study, they found out that isoniazid was one of them. Ethionamide, pyrazinamide, and ethambutol. So 4 out of the 7 drugs these patients were resistant to. So we could not adapt the WHO this regimen in children. Okay, and other considerations as well. PNG, TB, and HIV co-infection rate sits at around 8%, which is quite high, which basically shows that these kids present quite sick to the hospitals. Okay, with malnutrition rates based off a study from one of our pediatricians from PNG, shows that half of the kids that are diagnosed with TB have some degree of malnutrition. So these kids cannot go onto the WHO shorter regimen. Okay, so in terms of duration of treatment, trying to determine whether it's severe or non-severe TB disease might add additional complexity to healthcare workers out in the remote areas. And as well as that, we don't have X-ray facilities to really guide us to differentiate from these 2 categories. So the question was whether 6 months or 9 months or 12 months, basically to use just one instead of multiple durations of therapy. Okay, so with linezolid, from discussions with the Pediatric Society, we opted to see if whichever regimen was going to reduce the duration of linezolid. So we know linezolid causes optic neuritis, myelosuppression, even after 2 months of exposure. So we've been using linezolid for 18 months with the 2019 Sentinel guidelines. And it's very hard to monitor linezolid toxicity in our clinics, in the main hospital as well as at the clinics. So this was one of our issues that we took on board, and in bedaquiline as well. So studies have shown that though bedaquiline, bedaquiline can be used more than 6 months, there's no sufficient studies to show the efficacy of treatment or cure rates with bedaquiline. But it's, however, safe to use beyond 6 months. So that's another aspect that we considered. Okay, so with that information, sorry, this is not. Okay, so with all those information, the society set in September 2023 to discuss all these issues and to come up with a possible regimen that was going to be applicable in our setting in Papua New Guinea. So the Sentinel 2022 field guide was adapted to Port Moresby General Hospital in 2024. And we're still currently using it, which basically shows the 5 different drugs: bedaquiline, levofloxacin, clofazimide, cycloserine, linezolid. And for fluoroquinolone resistance, delamanid can be used for 12 months. So that's what we've been using currently. So now to the rapid communications that came on board in June last year, which I think you all know, the WHO recommended 6 months treatment composed of bedaquiline, delamanid, linezolid, levoflox, clofazimide for treating MDR TB patients. Okay, so I won't go into details. Dr. Sabine already went through. So we've seen that this regimen is applicable in children, adolescents, pregnant women, and breastfeeding women, and those that have not been confirmed bacteriologically. Okay, so with the NTB regimen, we found that the second arm of the NTB trial was kind of similar to what we've been using, the 2022 Sentinel Field Guide, which is bedaquiline, linezolid, clofazimide, levoflox, paracinamide, except that we are using cycloserine instead of paracinamide. Okay, so it can be used to treat both non-severe and severe TB patients. Okay, so considerations and way forward. Back in PNG, culture is not always available to guide our therapy. We have children with severe TB disease and severe malnutrition. And with some clinicians, there's some hesitancy to shorten the treatment, especially when cultures are not available. So it's a reality that some individualized regimens will need to be made available, and which regimen has to be easiest to implement from all pediatricians across the country. Monitoring is hard, except with linezolid, and children are much less likely to contribute to drug resistance because of the paucibacillary nature than in adults. So consultation was still going on with the experts, and there was a consensus with our National TB Program, the Pediatric Society, WHO, and pediatricians at a recent PMDT meeting in October last year. And that's when we wanted to formally adopt Beat TB regimen and the NTB or the Sentinel regimen late last year. So in summary, we will include Beat TB as a treatment option, 6 months of bedaquiline, delamanid, linezolid, levoflox, and clofazimide, with the extension to 12 months in severe TB cases, which includes osteo-TB, CNS TB, miliary TB, disseminated TB. And replacing clofazimide with cycloserine for cases of nervous CNS TB. Sentinel Guide and the NTB 2-arm recommendation still remains an option for us, except that we are using cycloserine instead of paracinamide. And it's very important because at times we run out of delamanid in country, and it can treat all forms of severe TB disease. So that's how far we are with our MDR TB guidelines for children in Papua New Guinea.
So, question answered, I think. If any questions, please ask.
loud, so I didn't. I was just congratulating the team from Papua New Guinea for the excellent work that you've done in the space of pediatric drug-resistant TB. And I guess my question to you, because you show, right, how the WHO guidance is there, but you have to think about it in your context, right? And I think every country here is thinking about how to do that. What was the most important or most essential types of support that you received as a country in order to make those adaptations so that you could have regimens that were useful in your setting? Thank you.
Yeah, thank you. So with the project that I'm working for, the Child TB and HIV project, it's an initiative of the Pediatric Society that was implemented in 2016 and funded by the Australian government to actually try and reduce the rates of TB in children in Papua New Guinea. So with the project and the support and the funding that is given by the Australian government, our team is able to roll out guidelines and go for advocate for trainings in our peripheries and train the staff, assess how the pediatric cases and the treatments are going, and to actually see where, as pediatricians, we are able to give that insight into treatment. So one thing that we, as pediatricians, we don't see a patient with TB as just TB. We holistically approach our child in terms of all systems, and we try to address every problem they can have as much as possible.
Any more questions?
Thanks for sharing your experience with the use of these new regimen and how you have been adopting. Generally, we see that whenever there are modifications to the recommended regimen, they are done under an operational research condition. So in your situation, how did you ensure the data being collected and that is available for, just as we do a research, it may not be exactly a clinical research, it's just operational research, but what steps you took to make sure that, all the required data is collected and, that is analyzed for further informing, because this could also be used as a, example for broader recommendations and guidelines.
Probably to answer that, in terms of research back in Papua New Guinea, it's not as where it's supposed to be. So most of our decisions are based around clinical experts and how best we can use those clinical experience and knowledge that we have to implement the regimens in children. But that's one thing that we've tried to look into in terms of data collection and record keeping, which in terms of pediatric TB, back in Papua New Guinea, there was no proper records back in those years until in 2016 when the project came on board and we started to recruit and hire data officers on board, and they were able to get more information. So now with the Child TB project, we have a lot of data on board and we're looking into research going forward with the data.
Any question? DRTB in child. It's very difficult to diagnose TB in child. It's more difficult to diagnose DRTB in child. It's most difficult to treat the DRTB in child because of the formulation of the medicines and availability of the drugs, child doses. So, and you cannot procure. So any experience sharing from any country about the child TB treatment in DR? No question? So I think that's all for this session. Thank you, Dr. Sabine. No, Gordon, Dr. Gordon. So this session, I think, is finished, and now we'll move to another section. Thank you very much for your attention and post-lunch session also.
Okay, thank you very much to the chairs. So, and we'll move to the next session, and this will be chaired by Dr. Kabir and Dr. Sakone. So, and we'll just let you know that during this session, we'll have a panel discussion. So, and we are going to put up the projector that is in front. So please, you can use this screen. Thank you.
Thank you. I'd like to welcome everybody. The next session is there. Now it is the panel discussions, and with me, my chair, honorable chair, is also present here. The first is the presentation will be given by Mensa Mabenga. I'd like to request Mr. Mensa Mabenga to deliver his presentation about Ascent DRTB, TM, and market access. I'd like to request Mr. Mensa Mabenga. Thank you.
Okay, thank you very much. So, and this is part of my presentation, so which I'm doing after the panel session. So, and I'm just going to give brief information, and I will discuss more about that. So the technical assistance plan that we have for the countries that are participating into the Ascent DRTB project. So just a brief history of the Ascent DRTB. So the activities that we are doing in the Ascent DRTB is a self-assessment and a TA plan, so which is led by the NTP. So then we have a community demand generation activities, so which is led by TAC. So then the global coordinations activities, so which is to share experience at global, national global level as the regional workshop that we are having right now. So, and the last thing is the market access, so which is led by Chai, and also they will talk about it. So, and yeah, so and how did we come up with the technical assistance plan? So the technical assistance plan was based on the self-assessment that was conducted. As I mentioned, this was led by the NTP. So, and now you can see that in the graph that we have here, so are the, okay, I would say that we use the self-assessment and planning tool that we have been using for the past 2 days for the self-assessment. So, and this is the standards and the benchmarks that we have. So, and you can see that we use a color-graded graph, you know, to analyze, okay, the performance of each of the standards that were in the tool. So, and you can see that the ones highlighted in red are the least standards that we have, because we started from 0 to 100%. So, and you can see that for human resources, for example, like the one in green that we have, so the human resources and staffing. So for all the countries, they have the capacity for human resources and staffing. So they have the staffs are there. So, but now when it comes to the training and the monitoring plan of the staffs that are in the health facility, especially the ones at the lower level, so that capacity is lacking. So because the gaps that we have identified were that either training was delayed because there is lack of budget to conduct the training, especially at the lower level, or the staff rotation, because there are some countries which know that they have staff rotations, and this staff rotation is impacting on the staffs that are coming, into the different health facilities. So, and the other thing that we identify also among all the countries were also ADSM, that's safety monitoring. So, and what we identify in the safety monitoring was that, okay, either the safety monitoring tools are lacking or the guidelines are not updated. So, if the guidelines are updated, so they are only available at the provincial level. So, but at the district level, so we see that most of the time we identify that, okay, they have the old guideline. So, or the training also was delayed for the staff that are at that level. So, and the other thing was regarding data management, so recording and reporting. So, and what we identify also was that, okay, for most of the countries, so they don't have an electronic health reporting system. So, and they are based on manual recording. So, and for data analysis and also using this data, so will cause a lot of delay from their side. So, and these are the technical assistance plans so that we have for all of these countries. So, and you can see that a majority of the countries, so they have ADSM. So the plan is to strengthen ADSM. So, and this was to support the update of the ADSM guideline, also update training materials, also capacity building to the different project intervention areas. So because the project also was taking place into different areas, into the different countries, like for example, in Indonesia, so it's only in one province. And the project is taking place in 3 districts, including which has 45 health facilities. So in Ukraine, in 1 plus, so in 2 provinces, in Vietnam, Mozambique in 1 province, then Ethiopia also in one of the areas, and 5 treatment initiation centers. So, and in Nigeria also in 1 state. So, and among the 7 countries that we have here, so you can see that 5 of them, so the TA was based on ADSM. So, but still there are other gaps that we identify. So, and or the other gaps that we identify, so there was a stakeholder coordination meeting, so where we discuss it with the different stakeholders that are also supporting the activities in the country. So, and share those gaps with the different stakeholders to also include that into their project activities, so which is related to the gaps that we are identifying. So, and from KNCV side, so the other technical assistant that we provide also focuses on assisting countries based on their needs. So, and this includes innovations and evidence generation, policy development, strategic planning, and supportive system. So, and you can see that here I just highlighted the areas where we provide more TA to the countries. And also we have a link where you can always reach to it. Okay, that's, yeah, all about it. Thank you.
Thank you, Mr. Manasa Mabanga, for his comprehensive presentation. And I think he's a wonderful time management here. He finished his speech according to his allotted time. And I like to request our audience to ask, if you have any question, you can ask question to the Mabanga. Any question about the ADCM? Is already mentioned about that. I think no question. Thank you, everybody. I think Bamenga is his presentation is so palatable that everybody is understand everything. Now I like to request Timothy Chai. I would like to Claire Abad from Chai about the space. Thank you.
Hey everyone, so I'm going to briefly discuss the market access work under the Ascent DRTB project and discuss kind of our approach of identifying priority products and access objectives for key TB commodities. So as a bit of a background, Chai and our partner, the Orium Institute, have been tasked with identifying, designing, and executing market interventions to secure access to TB commodities. How we approached this first was through a process of a rapid gap analysis and product prioritization process. So the first step was really in articulating what are the key challenges across the TB care cascade and matching that to the commodities that can fill those gaps. And then further looking at what are the access gaps to those key commodities. And so we did this across, from TB prevention through screening, diagnosis, treatment, and post-TB care. Once we had kind of this comprehensive list of the most important products for filling these gaps, we analyzed each product to really look at the market situation and as well as what really is the access needs to identify where we could design impactful market interventions, really looking at what are the opportunities right now, given the current market situation. And so we analyzed across different dimensions, including impact and need, the suitability and buy-in for these products, as well as kind of the economic factors and the opportunities and investments that are happening right now that we could leverage for this work. And then the last and very important process was really verifying the assumptions and informing our market strategies through a process of consultation with key stakeholders. This includes civil society, global partners, as well as in-country stakeholders. And we did this across 5 countries, including India, Mozambique, Nigeria, South Africa, and Vietnam. So now I'll just give a quick snapshot of some of the kind of identified access needs and priority products. So starting off with TB screening, we saw that digital chest X-ray and CAD were of particular importance, and there were access needs around pricing and procurement and bringing more transparency and stability to the access for both CAD and for the X-ray hardware, and really ensuring that improving the procurement processes so we can have lower, more transparent pricing. For TB diagnostics, we have taken a specific view and kind of looking at the access challenges related to procurement and supply chain. What we had identified in previous work is that there is often a significant gap between what is the kind of global access pricing or reference pricing from the manufacturer and what countries are actually paying in their total landed costs. And this is due to a lot of cost drivers along the supply chain, including importation and distributor markups. And so we're looking to design targeted solutions to really address some of those cost drivers and address the kind of final total landed costs for TB diagnostics so that we can apply those, particularly for those in the pipeline that we'll hear about more tomorrow. For TB treatment, the kind of highest priority and kind of remaining access gaps were around delaminid as well as the pipeline drugs. And this is really around improving price and supply security for delaminid for both adult and pediatric formulations, as well as informing target access terms for the new regimens and drugs. And then lastly, post-TB care came up quite a bit in our consultations, including how we can really address both diagnosis and treatment of post-TB lung disease. And really the needs there are creating the enabling environment to integrate the diagnosis and treatment of post-TB lung disease into TB programs. And on the commodity side, it's focused on identifying the right product and the right price for spirometry so that we can diagnose post-TB lung disease. And cutting across all of the kind of products and market strategies that we're developing is this focus on strategies that really look at country-led procurement. As we know, donor funding is really being impacted right now, and that countries are going to have to rely more and more on domestic funding and on domestic processes for procurement. And we wanted to make sure that the access strategies that we are designing and implementing really address those issues, and that some of the gains that we've seen through pooled procurement mechanisms and global access pricing can continue and be strengthened to fill in those kind of remaining gaps for the for countries and all public sector buyers. And lastly, I just want to thank everyone who contributed to our consultation process, as well as to Unity and KNCV and our partner, ORM Institute, and the other Ascent DRTB partners. Thank you.
Okay, thank you. Thank you, Trey. So any questions to her? Yes, please.
Just maybe Smilka Drushini from United, just maybe to complement something that Claire presented on, which I think is specifically relevant to the Asia Pacific region, is that when we analyze the price accessibility, so we know that the global prices are usually the ones that we negotiate with manufacturers, and they usually are a certain level. But when we analyze across Latin America and Africa and Asia Pacific, the prices that we are seeing in Asia Pacific are the highest amongst the three regions. So basically, the countries in Asia Pacific do not access the same prices as other regions. And that's why the PSM component of the work of CHAI is really tailored to that, to understand what the drivers are behind 4 to 8-fold. I think it was very high in terms of the multiplier of how much in Asia Pacific they were paying for a TB test or for HPV test or for other tests than, for example, Africa and Latin America. Some of those drivers are with the distributors' margins, but some of them are also in the way how the countries procure. So that's a very important piece, because if we are talking also about new technologies, whatever we negotiate globally might not be automatically accessible to Asia Pacific unless we fix some of these drivers of the price increase. So I just wanted to add to that. Thanks.
Yeah, thank you for that important point. And I think a lot of what we've done in the past in terms of how we approach access is really working with manufacturers in these global access pricing. But we really need to also now focus on this kind of the last mile, the distribution, the importation, the procurement mechanisms within countries to ensure that what we are, negotiating in global access pricing actually is what countries end up paying and what countries can access. So yeah, I think this is a really important component that we'll be focusing on in this work.
Any more questions? No? Okay, thank you. Thank you so much. The next is I just like to Mike Frick, TAG, is talking about this community engagement to accelerate the uptake new TB region.
All right, hello. I'm Mike from TAG, Treatment Action Group. I don't have slides, so I'm going to give you a break from the PowerPoint for just a few minutes. In the room this week, we have community representatives from the Ascent project. Unitaid has a commitment to civil society and community engagement in all of its work. And as part of Ascent, we have been funding civil society and community to build demand for and community understanding of BPALM and other all oral, shorter drug resistant TB regimens. And maybe here at the start, I would just like to ask the community partners who are in the room, whether you're an Ascent partner or you have another community affiliation, could you stand up? Most of you are in the back. Stand up, please, so people know who you are. I just want to demonstrate our numbers. We have some people in the front too. So we have a lot of community at this regional meeting. And I really want to thank everyone who made that possible. The model, okay, you can sit down. The model that TAG has developed and used under several United projects now has been to train civil society in the science of TB, fund them, provide money for them to design and conduct locally relevant, setting-specific demand creation work for TB tools, and then to bring these trained civil society partners together as a cohort, as peers, to advocate to overcome shared barriers, high prices, outdated policies, health systems that aren't designed to reach communities in the right way. And doing this work over the past many years, I have come to think of it using this phrase. We are really trying to build infrastructures of trust, And on those infrastructures of trust, demand for tools and services is then built and generated and sustained. And this week, we brought these Ascent community partners who've been doing work in their communities together. We've been meeting on Zoom for 9 months now, and this was our first time all being together in person. We brought each other together to learn from the work that we've been doing. And I have been taking some reflections during our meeting about things that stood out to me, about the community work that I think is relevant for all of us, whether we're NTPs or global donors, to think about as we prepare to introduce new TB regimens, new diagnostics, new prevention options. The first is that it all starts with treatment literacy. This was a point made by Loon, actually, from India the other day. We have to start by teaching people with TB, at risk of TB, their families, about the interventions that we're asking them to take and to adopt. So it starts with treatment literacy, which is a kind of old-fashioned but critically important activity. And to support treatment literacy, we have been developing at TAG some materials for partners to work with. And we've been doing this with the help of Dr. Jennifer Furin, who's also in the room today. So we have an activist guide to shorter treatment for drug-resistant tuberculosis. We have a guide about the side effects that you can expect with these WHO recommendations and how to manage them. A guide for patients about at treatment initiation, at the 8-week visit, at subsequent clinical visits, what tests should you expect to receive and what are the tests for? We have a guide on the regimens because we have 6 recommended regimens now, and they're hard to keep track of. They involve the same drugs, different combinations. So how do we keep track of these regimens? We have a simplified guide for that. And we have a guide for people to talk about their diagnosis of drug-resistant TB with the people in their life, because a lot starts from disclosure. I have drug-resistant tuberculosis. We share the same air. You need to be screened for TB. You may be eligible for preventive treatment. You may have TB too, in which case you need to get diagnosed. But those conversations are hard to have. And so we have developed some supporting materials around those. So just to say, you can go to our website or find me afterward. I think these materials are useful not just for civil society. We've seen them used by programs in the past before, and we'd be very happy to share them. So it starts with treatment literacy. That was one. The second is that with these multiple recommended regimens, we are in a situation now where patient-centered drug-resistant TB care equals shared decision-making between the person with TB and their provider. That came out very strongly in the work that our partners are doing. And this shared decision-making is not just at the start of treatment, which regimen is right for me, but throughout treatment. I'm experiencing this side effect. What should we do to mitigate it? Do we need to make a regimen change? Can we just back off the drug temporarily to see if things get better? That kind of shared decision-making should be throughout. The third thing that really stood out to me was that how you enter a community matters. This was a point from a partner in Nigeria, Chinyonye, who her organization has been doing a lot of work with what she called community gatekeepers. So they can't just go into a community and do demand creation work. They have to enter the community in the right way. So that means talking to village chiefs, religious leaders, traditional healers, people who are influential in that space about tuberculosis, about the new regimens, about the science, and about the work that they want to do in the community. The fourth point is that once you enter a community, how you move through it is really important. Many of our partners are working with former DRTB patients, people who've had TB before, training them to become community health agents. This is being done in Ethiopia, in Mozambique, and in other places. And working with people who've had the experience of treatment to talk to people who are just starting treatment about what their journey is going to be like, or talking in the community to build demand for some of these new innovations. We also have partners who are moving through the community in new and innovative ways through social media. So in Nigeria, Rahama Initiative in Kano State has used influencers on TikTok to talk about drug-resistant TB. And the innovation here was that they didn't just go to any old influencer. They went to doctors, clinicians who have big social media followings, who are media savvy doctors, and asked them to talk about TB. So it's not just going to the influencer who's there to talk about fashion or sports or whatever the topic may be, but the influencers who are working on medicine and health. So working with new media. The fifth point, I would say all of our partners are working on what's called CLM, community-led monitoring. And monitoring and accountability is where communities really shine. I think what I took away from our meeting this week is that CLM is not only about getting feedback or about criticizing government, right? Sometimes I think CLM is interpreted as, here are all these people in the community complaining to you about what's going wrong. It's actually a mechanism for listening to community about what could go right if things were tweaked slightly. So when we had a similar program under the Impact for TB project, which was a Unitate-funded effort to promote 3-HP and 1-HP TB preventive treatment, community-led monitoring was critical because it allowed partners to have an early look at how communities were receiving 3-HP in terms of the acceptability of the regimens, the side effects, the myths and misinformation that were starting. So it was interesting that based on the clinical trials of 3-HP, everybody was prepared to look for a side effect called a hypersensitivity reaction, a kind of rare event. But what communities were talking about, people on 3-HP were saying to our community advocates was, I have headaches, I'm fatigued, I have this weird rash. Nobody was talking about hypersensitivity. The side effects people were complaining about were the grade 1 events in the clinical trial, the things that weren't really the focus of guidelines, but were critical for the acceptance of these regimens for people taking and finishing them. And then my last point, the sixth point, is about stigma and the importance of addressing this. Yesterday afternoon, we left you all to have our own meeting. We did a training on overcoming stigma, which was really an incredible session. And I just want to say that there is a lot of really good resource material available on measuring stigma, overcoming stigma, thinking about stigma from a healthcare provider perspective, a patient perspective that KNCV has developed. And we went through some of the exercises and found them incredibly meaningful. The KNCV approach to this is that you have to work on stigma through 3 ways. You have to work on it through your head, through your hands, and through your heart. And we also received some wisdom from one of our members, someone who has had TB before, who's an artist, about stepping outside of the science to work on stigma by tapping into creativity or art practice, the need to create an emotional bridge from experience to science, to innovation, and doing that through means that may be a little bit uncomfortable, not the things NTPs or even community groups typically do, but a willingness to embrace artistic practice and other ways of encountering this. So I'll leave you with those reflections from the community work. Treatment literacy, patient-centered care is shared decision-making, how you enter a community matters, how you move through it matters. Community-led monitoring is listening and an opportunity to get things right from the start. And stigma requires working on the head the hands and the heart. And I'm really happy that we were able to bring so many community people to this meeting. Our work will continue. It's not finished yet. And please feel free, now you know who the community people are, to talk to them and talk to them about how best to work together with programs to make all of this possible. Thank you.
Thank you, Mike. Can you stand until over the session? Can you stand there? This may be some from questions first. Any questions to ask about this community engagement? Because this is a really good model that we have good implementation from a community. So maybe from as ASEAN country or like Nepal, you have any questions? Like Cambodia, Indonesia, that I have, that's a really good community support from community engagement. It's a really big support from the communities. So no questions? It's clear? Yes, go ahead.
Hello. Not a question, but I'll supplement what Mike has said regarding the community contribution. Follow up with the previous session also regarding marketing. We talk about BPAL-M. If it's branded, our government cannot afford. You cannot afford. I cannot afford. So we need to break this pattern. And who challenge the pattern is most of the time community. Last year, in 2024, we have Win-Bedaquiline long-acting, we have Win-Bedaquiline dispersible, and in 2020, we have Win-3ASP, we break this pattern. So that's how generic company start making. When I'm not for generic company or I'm not against branded, but when there's a generic, there's a competition and it drives down the price, and that's where the public health people start receiving this. So this is a big contribution by the community. I just want to flag this.
Yeah, let me just say, thank you, Loon. So that's Loon from DNP Plus in Delhi. You said something to me at the coffee break that I wanted to mention. So thanks for reminding me. You made the point that in HIV, as things got better, as the drugs got better and diagnosis got better, things also got simpler. But that in TB, in this moment, as things are getting better, things feel like they're getting more complex. So we have 6 regimens. They all kind of involve bedaquiline, linezolid, and some other drugs, you know. And this is a challenge for the community work. So your point about, I think I heard you say branding. We have to do a better job naming these regimens, you know, like, okay, TB, that's kind of a good name, but NTB1, NTB2, NTB3, even BPAL-M, we're using drug abbreviations to name our regimens. And that's really not intuitive for people who are taking them or for communities who are trying to build demand around them. So I don't know, you know, who gets to name something. That's kind of a big existential question, but we have to come up with better names because we can't do the kind of community work that we need to do talking about the regimens this way. So maybe just something for us all to think about, not something I have an answer on, but thanks for bringing it up.
Is there any question?
Yes, and myself, I have questions too. Actually, I just like to know this how to collaborate and coordinate with the public part, its government part for the implementation.
For implementation. Well, I think the most, I mean, it's obvious, but I think you have to fund civil society to do this work. And so within the programs that you're setting up, set aside funds and space to do work with community partners. And I would also encourage programs to see community as doing more than just last mile service delivery, although that is very important, right? They can go door to door, they can take services to hard to reach places, but the skills and tools of civil society go far beyond that. So also yesterday, and in some of those small breakout groups, as we've been doing these assessments, you know, a lot of the questions are asking about the integration of civil society into like technical working groups. And it's been a mixed bag from what I've heard. Not every country seems to have a CSO representative on a technical working group for TB prevention, let's say. I would say put a civil society person in that national committee that's writing guidelines or putting together a funding request to Global Fund or other donors. Because there's nothing more powerful than having an informed advocate who's been trained in the science sitting on the technical working group. It can change the entire dynamic in the room. So those are two places I would start.
Yes, my last question is about this CRM. CRM that's it's a good model, but many countries that is not implemented yet. For example, in Laos, and again, the stigma and discrimination. How to use this opportunity to improve the health services with is coordinate how to relate it among stigma and CLM.
CLM. I'm not a CLM expert, actually. Everything I know about CLM, I've learned from people who are doing it. There are a lot of really good tools out there, and a lot of them for TB have actually been adapted from CLM frameworks that started in the HIV space. So it may be that CLM is not being done for TB where you are, but it could be being done for HIV or for other diseases. So I think the first thing I would check is it happening in the HIV response in your country? And if it is, start from there. And if it's not, there are groups that you can reach out to in civil society that will teach you basically how to do CLM and figure out that critical link between the data community collect and the data that programs need to recognize and then report onward to government or WHO. Yeah, thanks.
Thank you, Mike. We should give a big claps for our community partners as well as for the civil society and Mike also. I think civil society and community playing an important role in TB prevention and management, and your contribution should be appreciated. Now I'd like to request Dr. Eden Mendoza for the TB Alliance. No questions. She will give a some speech there.
I do have some slides. Here, link. Right. So I'm going to present what PeerLink is doing in terms of capacity building for the new TB treatment regimens. So what PeerLink does is basically we try to connect experts from the early adopter countries who implemented the PEOPLE regimen. And then what we do is basically share these best practices, experiences, and the tools and the materials that were developed, especially in the operations research that was conducted in those countries. And then we do a training, and we offer these in person or remotely. And we try to tailor the modules of the each regimen based on the country needs. And then if this was or if we are trying to conduct this in the Philippines, we try to arrange field visits so that the participants will be exposed to the central and local implementation of the new treatment regimen. We try to conduct the training in English, but for countries that are non-English speakers, we try to offer translation and interpreter services as well. And the model or the training that we conduct is based on adult learning. We want to make sure that the skills and the knowledge that are being taught can be applied immediately in your workspace or in your facilities.
We try to give as many case discussions so that all the experiences in terms of managing TB patients in the health facilities are real patients and real cases that are actually experienced in the health facility. And we also do demonstration of various tests like how to test for peripheral neuropathy, for visual acuity and color vision test. And we don't stop there. It's not a one-time technical support. If the country would require like assistance in updating their guidelines, if you want further rollout in other parts of the country, we try to offer that as well. And the coverage of the training program that PeerLink is offering covers the clinical, the programmatic, even the latest WHO recommended laboratory and diagnostic tools. We also try to integrate gender equality, disability, and social inclusion so that, as Tag has mentioned, we don't want a lot of people left behind. And if the country would like to have other interests like drug supply and cost effectiveness, we offer that as well. So the resources that we have include protocols which are of course based on WHO recommendations, the algorithms, implementation guides, case experiences, advocacy resources, and evidence publications. We have all of that. And so this is just a summary of the countries that we have assisted so far. We have Rwanda, Cambodia, Tanzania, Papua New Guinea, Brazil, Peru, Democratic Republic of Congo, and Nigeria. So as you can see, we're not limited in the Southeast Asia or even in the Western Pacific region, but worldwide. And so if you do not see your countries in the list, and for those who are present here in the room, we would like to invite and encourage you to approach us, have a chat with us so that we can discuss the training in your country. Thank you.
Yes, thank you. Any questions? Okay, yes, go ahead.
Hello. Yeah, so thank you very much for your presentation. Could you say more detail about the ZZ integration for the capacity building?
Sorry. Can you say again?
Capacity building. How?
For the ZZ integration for the capacity building.
I'm sorry, I don't understand the question.
Okay, so let me speak again. I would like to have more detail about the integration of the ZC in the capacity building you mentioned.
Oh, the JEDC.
Yes.
All right.
Yes, yes.
So sorry. So you wanted to know how we do it, right? Okay, so basically we try to discuss the different concepts. What is gender equality? What is disability? And what are the concepts behind social inclusion? And then we try to provide or help countries determine what indicators that they can use so that they can actually integrate activities related to how they can address the gaps and barriers that they have identified in their national TB response. So that's basically how we provide our capacity building for JEDC integration. Usually we just provide an overview in the beginning, but if the country is more interested in really going through the analysis of what the gender gaps are, we try to offer that as well.
Thank you so much. So I understand that you already developed some kind of assessment tool, right?
Yes.
Okay, good. Yeah, yeah. I think we can talk now in person. Thank
Right.
you so much.
Thank you.
I think no any questions, right? Okay. Thank you. Thank you so much. Thank you for Eden Medisha. Okay, I'm sorry. That's Jonathan. Just skip you. Just a moment. So You are joining live, right? You are ready?
Yes, you should be able to hear me now.
Okay, the floor is yours. Thank you.
Thank you. So, good afternoon, everyone. Thank you for the opportunity to present to you all in Hanoi. My name is John Savello, together with my colleague, Dr. Pierpaolo Di Colombani, here on behalf of the University of Milan team, working on the Unite for TB project. Together with our 30 global partners, our research consortium is working to create new drug regimens for TB. To give a quick overview of the project, we are part of the Innovative Health Initiative, funded by the European Commission and the European Federation of Pharmaceutical Industries and Associations. So we draw half of our funding from private sources and half from public sources, putting forward a total of 185 million euro towards developing new drug regimens to treat TB. Unite for TB oversees the 5 trials you see in this slide. So from the left, Paradigm for TB is our largest study, and it's testing ganfeberol, a new drug from GlaxoSmithKline, and BTZ-043 in its first wave. And then with a new drug, Cuobodepestat or Delpazolid in its second wave. We currently have 237 patients enrolled in Paradigm for TB, and the trial is expected to last until 2028, after which we hope to begin phase 3 trials. The Decision trial tested BTZ-043 by itself, which was developed by the University of Munich, to evaluate the exposure response of different dosages. This trial was completed in December last year, and our team is currently working through the trial data. Hopefully, we'll have news to share in the coming months. The Enable trial is testing the exposure response of Alpibectia, which is another drug from GlaxoSmithKline, to test how well it performs as a replacement for ethionamide. This study has not yet started, but we hope to finalize the protocol soon and then to enroll 75 people on a short-term study. Step 2C tests the efficacy and safety of BTZ-043. We'll be inheriting a study from another working group called Panacea, where we'll test the new drug with Alpibectia or ethionamide, ganfeberol, and Delpazolid. We hope to start this study in June and to enroll 120 patients over 52 weeks. And finally, there is a future trial planned with the TB Alliance to test their new drug, TBHA587. Here you can see a global map of our current trial sites. Our fully active sites, which are recruiting patients, are mainly based in South Africa, Tanzania, and Uganda, as well as one based in Moldova. But our hope is that we can open future sites in Asia for the second wave of Paradigm for TB. We are very close to regulatory approval for our site at the National Lung Hospital there in Hanoi, and another site with the National TB Program in Ho Chi Minh City. There is also ongoing site evaluation to open our trials to the Philippines, Brazil, India, and Peru. But we're not just conducting the clinical trials. Our team in the University of Milan undertook a stakeholder analysis in 2022, where we interviewed 50 stakeholders external to our consortium, mainly made up of national TB programs, international funders, policymakers, and NGOs. Year on year, we've gathered this feedback and identified these 10 recommendations from our findings. So we must ensure that clinical trial outcomes meet WHO requirements to develop policies and guidelines. We must pursue initial strategic discussions to make the costs of new treatment regimens and drug susceptibility testing affordable to low and middle income countries to guarantee equitable access in all settings. We need to encourage the development of fixed dose combinations to be presented to regulatory authorities as soon as any new regimen is approved. We must strengthen and coordinate among all clinical trial research consortia to limit duplications of effort between us. Major international stakeholders must be engaged to facilitate dialogue amongst all the research consortia and coordinate efforts in drug research and development and policy implementation. Clinical trial sites must be selected carefully so that they can include vulnerable and high-risk populations. The national TB programs in each country must be engaged to help choose the most appropriate trial sites and to facilitate local research capacity, as well as to root out and eliminate any potential bottlenecks that might prevent the quick uptake of new regimens in each country. We must advocate for stable funding so that we can fully complete these trials. And finally, we must engage in timely information sharing with our stakeholders so that they're aware of new discoveries emerging from the trials. We've continued these communications efforts with stakeholders annually and will continue to do so for the rest of the project. We are extremely grateful for opportunities like this where we can present some of our clinical trial progress and engage with NTP managers. In 2023, we attended conferences with the WHO region of the Americas and Southeast Asian region, and in 2024 held a session for external stakeholders at our Unite for TB annual meeting, as well as contributing to a UNITAID workshop on access to TB medicines. We intend to visit further events this year, and an abstract about our work has been accepted by the WHO European Regional Office for their upcoming workshop on TB innovations in May. And finally, these are some of our communications efforts related to the project. Please do add us on the platforms that you see listed here so you can receive the latest progress on our trials in Unite for TB. And with that, I'll open to questions. Thank you.
Thank you, Jonathan Sarvillo. And I think you can ask any question for him. Any question? Yes.
Thank you very much. Thank you. Thank you very much for this overview of the Unite for TB project. It's a huge project, yes. And really promising for the development of the new regimens. Based on the work you're doing now, when do you think that something really new, consisting of really brand new drugs, would be available?
So we are currently in phase 2B. At the end of 2028, we're hoping to enter phase 3 particularly for ganfebrol in the Paradigm for TB trial. So going forward from that point, it's difficult to estimate always due to the number of factors involved. But after the phase 3 trial, we hope we can introduce ganfebrol in a new regimen.
Okay, please, you can ask a question.
Hi, my name is Sharon Ann Lynch. I'm with the O'Neill Institute. My question is regarding your access policies, because it's never too early to start thinking about access policies. It's never too early to start planning. And especially because, as you say, your funding comes from, in large part, a mix of public and other sources. I know that you have been at some or some of your colleagues have been at some discussions where we wanted to learn from the past so as to not suffer the type of delays from, let's say, the conclusion of phase 3, WHO recommendations, and equitable access, especially in low and middle income countries. So can you give us just an update on what your informal thinking, if not your formal policies, are looking like?
Sure, yes. And I can remember participating in the UNITAID workshop where we also discussed this. I can actually see that my colleague, Pierpaolo, has his hand up currently. Would you like to jump in, Pierpaolo? You can unmute yourself.
Yes, thank you, John. No, I just wanted to highlight our presentation was trying to highlight the approach that we have, that is addressing access, the problem of access to innovations, already in advance, already built in the research. This project is on phase 2 clinical trial. But a part of the budget of this huge project was given, dedicated to engage stakeholders. And this is how we came out with this 10 key recommendations that if you see are all related to access. from different aspects. And this engagement that we started in 2022 with the stakeholder analysis, we continue, as John showing in the last slide, in the following years. About current policy on ensuring access, there is an internal discussion through us, facilitated by the University of Milan, that is one of the 30 members of the consortium, soliciting the discussion within the consortium about access. And so it's a key, the discussion, the dialogue with the stakeholders that John already mentioned are the national TB programs and their technical and financial partners. While another group is dealing with engagement of social community organizations. And there is a community advisory group that is advising those trialists on the different passages that are of these clinical trials.
So you do have, it sounds like, the structures in place to engage different stakeholders and to build a policy. And some of us would look forward to future engagement, which I know that you are open to. So thank you for that. But there is, so you know, an expectation that we evolve, that with every development, not only do we learn more, do more, and improve the science in terms of therapeutic options, but that we also learn from the mistakes of the past, both in terms of time and in terms of reach. So we believe that we can go further, farther, and faster. So thank you very much for being open to future conversations.
Absolutely. All inputs are very much welcome, and you can even approach John and myself, and also our team leader, that is Mario Raviglione, that was, the director of the Global TB program in Geneva, in WHO Geneva for many years, and is very much, of course, keen on and inform about the problem of accessing innovations in the past, the importance to ensure for the future.
If I have with the permission of chair,
you can ask a question.
No, it's not a question. Just to add on what the earlier colleague said, that I'm just putting up the country's perspective. Also, we look forward. I hope you have planned it. As you said that your funding comes both from public and private, and you are engaging, and the structure is there. So I'm just throwing in the country's perspective that we would like that sooner we meet with at least with the high burden countries or in the regions which are in this workshop, that is Southeast Asia and Western Pacific region. So I from India just would like to put the country's perspective that we would like to meet sooner than later, so that we also are quite interested. Thank you.
I can confirm that the colleagues in India are in our priority list of institutions to interview every year. And we already identify a number of bottlenecks for the future uptake of innovations, and we already flagged this within the consortium. About India, the first is, of course, registration of drugs that by law can be done only if there is evidence produced locally. That means that the clinical trials should be implemented in the country. Otherwise, it will be not possible the registration of those new drugs. And until now, unfortunately, India doesn't have any clinical trial site, but there is a negotiation with a consortium about including that.
Thanks.
Yes. So there are, for each of the 10 recommendations, there is a discussion going on, and this has been amplified during the follow-up and that we continue in 2023, 2024, and this year, and the feedback that we received during interviews.
Any other questions from audience? I think no questions. Thank you, Jonathan, and your colleagues. We should give a big claps for Jonathan and his colleagues. Thank you. Thank you for joining with us.
Thank you.
Thank you.
Now we are another session will be start now. That is the planning for implementation of the Noble DRTB regime. I'd like to request Jaja Mufiz of the Stop TB partner and GDF to his presentation.
Good afternoon. Firstly, thank you to the organizers for giving us this opportunity to present in this very important workshop. My name is Zaza Muñez. I am GDF Regional Technical Advisor for these two regions, for Seattle and the Western Pacific region. So right now I'm going to present GDF updates. GDF. Is that?
Sorry, that we are now looking for the presentation. Just wait for a minute.
In the interest of time, while they are looking for my presentation, I'm going to tell you about my presentation. So the outline is I'm going to introduce or present GDF's role in the implementation of WHO guidelines in the country. Also, I'm going to present updates, GDF product updates from diagnostics, medicines for the STB, TPT, and the RTP. And then I'm going to also touch on a little bit of the GDF services and challenges and solutions for countries to uptake WHO new guidelines. I think so let me just go through. So I think for Global Drug Facility, most of us knows GDF. We are part of the Stop TB partnership based in Geneva, and we are the largest procurer of TB medicines and diagnostics globally. So most of the countries, all of the countries here in this room actually procure from GDF for TB medicines or diagnostics, and countries come through GDF regardless of the funding source. So I want to highlight that most of the countries procure through us using their donors, but many of the countries also procure through GDF using government funding. And then there's no minimum. Yes. Oh. All right. So as I was saying, there's no minimum order size required because we have the leverage of pulling all the requirements by countries, since we are the largest procurer globally. So we have no minimum order size required. GDF established this TPMAT, or the TB Procurement and Market Shaping Action Team. And through this TPMAT, we gather all stakeholders from the country, even CSOs are there, and regional and global TB stakeholders. This TPMAT manages the entire TB product cycle. So from the very beginning of identifying the need of a product to working with the suppliers in the development and also production, and tracking the regulatory and quality assurance status. And when it's ready, then we also introduce to the countries and monitor and track the scale up at the country level until such time that when the product needs to be phased out, then we may need to manage that as well. The TPMAT also has this dashboard where we monitor the registration and the regulatory status and the quality assurance. So for example, here, you see that protomanid is tracked from the development until it is included in the WHO essential medicine list. And this is available in this website in the link. So, so GDF, we say that we are very proud to say that all WHO recommended TB medicines are available from GDF, including the child-friendly formulations, the dispersible tablets. They are all available in our catalog, and countries can procure through that from GDF. While for the diagnostics and medical devices, we have more than 500 products in our catalog. This is just a timeline. I'm not going to go through in detail, but this is a timeline of all the diagnostic suppliers available in our catalog. And in 2024, we've added quite some suppliers here. Looking at the digital X-ray kits and CAD AI systems that GDF delivered globally, the green bar shows the quantity that we delivered globally, mostly for FDR XR and Delft Light X-ray for digital X-ray systems, but also for the CAD AI software like CAD for TB and infrared. While the red one shows the specific deliveries to this region, Southeast Asia and Western Pacific. And as mentioned earlier, we've added, and also previously, we've added some products and suppliers under the digital X-rays and CAD AI, which are the Peak X-ray and the Cure or QXR AI software. So these are all available in the catalog from GDF. Looking at egress, we have here the country deliveries of quantiferon TB gold test, and also in the country. And as mentioned here, in addition to quantiferon TB gold test, we also have the standard ETB Ferron and one-type TB IGRA available. As mentioned, as also in the other days previously, yesterday and the other day, this skin test, the SEAL TBC is also available from GDF at the cost of $1.50 per dose. And I'd like to mention that the WHO pre-qualification, but no suppliers here, but this is an information for the suppliers that WHO pre-qualification has opened an EOI for biotherapeutic and biosimilar products. And GDF is encouraging this and other WHO recommended suppliers of TBSTs to submit under this pathway. For the TNGS, we are actively engaging with suppliers to develop procurement strategy, aim at making TNGS available and accessible to national TB programs via the GDF. And the tender process has not been launched, but we are expecting or anticipating commencement in the third quarter of 2025. So this is something to look forward. And maybe in quarter 3 to quarter 4, there may be something in our catalog for TNGS. Many of you may know about the supply issues of rifampicin-based products, the DRTB. This challenge came about when national tenders of some countries not requiring WHO PQ failed, leading to some first-line drug stockout risk at the countries. And there's also, in addition, there's also an API shortage in China and globally. So, and then also those countries who do not procure from us, even though they've been supported by Global Fund, could not do procurement, actual procurement. This procurement failed. So this came through GDF in the last minute as emergency orders. And then the WHO pre-qualified suppliers were unprepared for the sudden increase and the sudden volume. So with this crisis, we are working very closely with several stakeholders, WHO and GF, and also suppliers for API and final product suppliers to fast track and boost the production to make available to the countries. At the country level, we are also working very closely with the countries to monitor and track their stock status and ensuring that we provide our prioritization of deliveries for equitable access to all countries. At this point, we are projecting that API stabilization will be reached by mid-2025, and the backlog of supply will be cleared by November 2025. Despite of all these challenges, this shows that for last year, 2024, GDF has delivered the highest ever quantities of DSTB treatments to the countries. And here you can see that the purple one is the other countries, while the gray is for this region, Southeast Asia and Western Pacific. And from 2023 to 2024, we see an increase of 100% deliveries to this region just for this year, 2023 to 2024, and globally of 56%. So 700,000 million treatments were delivered to countries that do not typically procure from GDF. And out of this 700,000, 600,000 were delivered specifically to these regions. And not only for 2025, we're also seeing 2024, we're also seeing for this year, 2025, a lot of deliveries going through this region. These are the costs of DSTB, adult and pediatric from the GDF price. And these are the 2-HPMZ and 2-HPM, which are and also the 4-month regimen for pediatrics. So just to, for your information, that these are the costs if you go through GDF. And then also I'd like to mention that fix those combinations for the Study 31 regimen have been developed and are undergoing WHO PQ review. So that's also something to look forward. In terms of the TPT, the USAID also funded the 3HP catalytic scale-up project, which is a total of 17 million just to scale up the 3HP FDC rollout in the countries. This also led to help in the reduction, 30% reduction of price of 3HP FDC from 14 to 9.99. And under this project, we have delivered 1.3 million treatment courses to 11 countries. And 3 out of the 11 is from this region. This shows the graph for the deliveries of 3HP from 2021 to 2025. So we're seeing an increase, but we're hoping that we'll increase more with the 3HP. Yes. And 19 countries in these regions account for the 1.3 million courses, of which in 2024, 400,000 courses were granted to 3 countries through the USAID funded 3HP catalytic project. The rifapentine 150 milligram dispersible tablets for our young population is also available from GDF. This is already a WHO pre-qualified product of 100 tablets per blister pack. This is GDF continues to support the procurement under EMAV, or Early Market Access Vehicle, which was launched by the Unit 8 funded Impact for TB project to accelerate access to pediatric rifapentine tablets. So 23,000 have already reached three countries, and an additional 28.4 thousand courses are pending delivery to 3 more countries under the Impact for TB. For the 3HP FDC, GDF has worked closely with the WHO Global TB Program to revise the dosing guidance and expand the use of the fixed dose combination to population less than 50 kilograms. And this is available in the latest guideline from WHO. And as you can see, the 3HP FDC can be used from 15 kilogram and higher. But for less than 50 kilogram, monitoring for isoniazid toxicity is recommended with pyridoxine supplementation if needed. These are the costs for the TPT regimens. And you can see here on the right side, the available suppliers and also the information in terms of the shelf life of each product. For protamine-based regimens for DRTB treatment, we have 20, since 2021, we have 20 countries in this region, 2 regions, accounted for 64% of the protamine courses that GDF delivered. Out of our priority countries globally, we are at 42 who are already implementing BPAL-M, scaling up at the country level. This is globally, but if we look at the Southeast Asian, Western Pacific region, we have 9 priority countries. And as of now, in Q1 2025, all of our priority countries have already implemented and scaled up, implemented BPAL-M. And this includes Bangladesh, Indonesia, Nepal, Myanmar, India, Philippines, Vietnam, Cambodia, and Papua New Guinea. Out of the 9 priority countries, 4 have registered protamine International Drug Regulatory Authority. And for those other countries that do not have registration of protamine, they can actually access through possibility of waiver for donated medicines. These are the costing of the new DRTB, the shorter DRTB treatment regimens. And as you can see, here are the BTB regimens. And the BTB is about like ×3 of the BPAL and BPAL-M. And for the pediatric, I want to mention that all of these pediatric medicines are available in child-friendly formulations. Please have them available in your country for our very young populations. All of these are available, and want to mention also that except protamine, we don't have the child-friendly because currently it's not being recommended for less than 15. Thanks to all your work with the use of bedaquiline, you'll see the very significant reduction in price of BPAL regimen as well as the other bedaquiline-based regimen. So over 60 to 65 from 2019 to 2025. And now here in the 2025, we are at 364 and 340. And we recently also finalized the tender for Petomamid, so we are expecting even a new update of the pricing. So this is something to watch out for. And I've shown here the list of medicines that are being used for the new treatment regimens, but it doesn't mean that these are the only DRTB regimens from GDF. So all the other medicines for DRTB, even the old ones, the injectables, are still available from GDF. I'm just showing these medicines that are for the new regimens. In terms of services, we have technical advisors available in the region. I am for this region, and you know that I work very closely with the countries as well as the PSM team in the countries working on quantification and monitoring their drugs, building up early warning systems to ensure that you don't have any, we don't expect any shortages. Other than that, we also have flexible procurement funds for those countries who may be having challenges in terms of procurement of medicines. Strategic rotating stockpile we maintain so that if there are countries who may need urgent deliveries, then we can also rely on the stockpile. We also do product consolidation where all of the medicines as you order are consolidated in our warehouse so that when we deliver, they are in full. And then product prioritization is to ensure that we have equitable access, especially for those countries who are urgently needing supplies. Some of the challenges in uptake, mainly in terms of policy and regulatory. So for the policy, I think it's very important to develop implementation plans with all of the stakeholders globally and regionally and country level stakeholders. So in each country, you need to gather all the stakeholders to look at the implementation of all aspects of the transition. In terms of the regulatory, we need to coordinate. This is one aspect that is very difficult, but we need to really coordinate with our regulatory authorities and try to discuss how we can find solutions of some flexibility and waivers. In terms of procurement supply management, we need to strengthen developing scenarios for PSM transition is very important because then this transition can also feed into the funding advocacy. So if you cost the needs of the medicines that you want, and if you cost how much it will be not used, then this can be used as a discussion for funding advocacy as well as used for information for procurement. And then, of course, health system and infrastructure improvement, building on all the capacity needed. So not only in terms of PSM, guideline development, we also need to plan the training to expedite and update revision of the information system and improve health system resilience. So just quickly to mention that we work with the countries to use QuantiV tools for the quantification and forecasting. But very important here is the information and the data that we feed into the quantification. So countries, when we transition, we need to think about having the good and quality data for us to analyze the transition and the transition plan. As a take-home message, all WHO recommended TB products are available through GDF. There are no global supply issues for any products except the one that I mentioned about the rifampicin-based medicines. And for this, we need to engage with the countries closely, and countries needs to engage with us very closely in terms of tracking their stocks. We need to have collaborative implementation planning in introducing this new regimens. So we need to proactively engage in activities like guideline development, procurement, supply management, information system, diagnostics, and training to ensure alignment. And effective procurement supply planning, it's not just the introduction, but also to think about after introduction that we need to ensure that we have sufficient stocks until the scale up. And regular sharing of quantification is very important because it feeds on to our global quantification to inform the suppliers what are the needs for the countries globally, as well as this will also being used. We are also using this information to ensure that each of the countries will not have any shortages. Thank you. That's all.
Thank you. Okay, this I think many countries and many participants here, there's no GDF, right? But any questions to, huh? It's clear. No questions. Oh, yes. Please.
Yes, this is Claire Albert from the CHI. I just wanted to reiterate the point made about pediatric rifampicin, the dispersible formulation. If countries are interested in introducing pediatric 3HP, the donation is still available. And so you can reach out to GDF or come to me at CHI, and we can help with accessing the dispersible formulation for children. Thank you.
Thank you. Yes, that's very important.
No comments, no questions. Okay, I think speaker for Sasa. Thank you so much. Okay, we are sorry that the schedule is behind within 30 minutes. But anyway, maybe next is we would like to finish this and then we can have coffee break. Next is an introduction and country experience on SEAR assessment and planning tool. Mansa, please, it's your turn.
Okay, thank you very much. And I'll just give an introduction of the self-assessment and planning tool. So, and my colleague Mamel will share the country experience of it. So, and okay, so the Ascent DRTB project so is funded by Unit 8. So, and the project goals is to support the introduction of the novel social treatment regimen and differentiated people-centered care packages. And in this, we use a stage-gated approach. So starting with a self-assessment to identify the needs of the countries and also the achievements and their strengths. So, and in that case, a self-assessment and planning tool was developed on that. So, and that's the tool that we have been using for the past days. So then the other goal is to facilitate experience sharing and best practice between the global regional and the national stakeholders. So, and in that case, like the ones that we are having this week, so which is the regional workshop. So in the project, we organize 3 regional workshops. So, and one was organized last year that was in the Afro region, for the African region. So, and the workshop that we are organizing right now, so and at the end of this month, so we'll organize the workshop in the European region. So, and the other activity is the community demand generation activities, which already Mike has mentioned and is led by TAG. So, and the market access, which is led by Chai, and Claire has talked about those ones. Okay, so the consortium and the countries that are also participating in the project. So in the consortium, so we have CAC, Chai, so then PAPS. PAPS is supporting all the activities taking place in Ukraine. So the Aurum Institute is supporting 2 countries, which is Mozambique and South Africa. So, and KNCV is supporting 5 countries, Nigeria, Vietnam, Philippines, Ethiopia, and Indonesia. So, and for all the other 8 countries, so they are also supported on the community demand generation activities by TAC. So the self-assessment and planning tool. So as I mentioned, this was developed to identify these achievements and the strengths the countries have, and also the gaps for the TA plan. So, and the tool is meant for discussion and brainstorming, like what we are doing on the past days to see where do we have the strengths and where we can use the strengths that we have. So, and what are the gaps, and how we can develop a strategic plan to fulfill those gaps. So a stakeholder mapping. So, and the main aim of the stakeholder mapping is to understand the role and the contributions of the stakeholders, and establish a coordination mechanism, so which the NTP will coordinate with the respective stakeholders. So a facility and national level assessment. So, and for this was to understand the general information and the penetration of the national guidelines into the different facilities, and what are the difference between the national level and also the facilities at the lower level. So, and also understand the country readiness on that. Okay, so, and in that case also we supported a few countries that also under the introduction of the BPAL based regiment. So, and some of the countries I already mentioned here is Indonesia, Philippines, Ukraine. So, and also other countries in the Central Asian regions like Uzbekistan and Kyrgyzstan. Okay, so my colleague Mamel will take you through on the country experience. Thank you.
Yes. Okay, this is the last for the presentation before break.
Hi, good afternoon, everyone. So this is to share the country experience of the self-assessment tools and the planning tools that Mansa mentioned in his introduction. So this is actually under the Ascent DRTB Philippine project, which is funded by UNITAID. So there are 3 objectives of this Ascent DRTB project. And the first is the development of a roadmap for tailored technical assistance for TB. Actually, in the beginning, this was supposed to be a focused project for drug-resistant TB. However, the Philippine NTP requested if this can be broadened to include also drug-susceptible TB. Hence, the development of a roadmap is not just for DRTB tailored technical assistance, but for TB in general. And so in order to do this, some activities had to be done. Stakeholders mapping, which Mansa also mentioned, self-assessment for the national DOH, NTP, and also the facility-based implementation sites. And the highlight was a stakeholders workshop where the presentation of gaps was done, and partners or stakeholders were able to commit their support to some of the TAs that were expressed as priorities in that stakeholders meeting. So for purposes of this presentation, I will only focus on the development of a roadmap. But of course, after that roadmap will be the implementation of this TA plan. And this hopefully will also lead to community demand generation and patient empowerment through CSO involvement. So I don't know if you were able to capture that, but in one of Mansa's slides, he showed the countries and their priority TA needs. And for the Philippines, there were 3 TA needs, and that's capacity building in the IDOTS facilities. These are the peripheral facilities that are implementing MDR-TB services, introduction of stool expert, and introduction of DR-TPT. And I'll walk you through how this priority TA needs was met. Okay, so I'll start with the stakeholders mapping, which was conducted by the NTP. So I'm not sure if Mansa was able to show the template for stakeholders mapping, but the template was used to map the stakeholders in the Philippines. So not focusing on DRTB, but all partners that are supporting the NTP and TB were listed down on this template. Who the representative is, the services that they provide, the geographic areas of their support. And you can see here the different aspects of the cascade of care, screening, testing, treatment, prevention, advocacy, and others. So that if you see a stakeholder here and they have a project or they support the NTP, and you see here the different aspects of cascade of care, the NTP just entered what the stakeholder was actually supporting them with. So this was an extensive exercise by the NTP, such that in the end, they were able to list down 33 partners that give support to them. And you can see that it's quite a diverse group, from professional societies to technical agencies, both international and local, NGOs, CSOs, and government agencies. So another request of the NTP was to hire a professional facilitator, because this is quite a big group and very diverse. So the discussions can really become challenging. And so that was done. So we hired a facilitator for the stakeholders meeting. Okay, so that's for the stakeholders mapping. For the national and facility self-assessments, there were 2. So there were 2 tools that were introduced. One was for the national assessment, and this was intended for the national TB program. And the facility assessment tool, this was intended for the facilities. And we engaged 2 regions, 5 facilities each, who were recipients of this self-assessment tools. Okay, this is a busy slide, but this just shows you that the tool that we have actually been using in this workshop since day 1 actually came from this, but this is the summary. So that if we entered not met in one of the benchmarks for one standard, then you will get a result of partially met. But if you entered met in all of the benchmarks, then you will get a result of met. So I'm sure that's familiar to you, the met and not met. Anyway, The entire tool has 11 standards, and each standard had different benchmarks. And for the Philippines, you can see here the number of benchmarks that were not met, but I'll not go through that anymore. But among the 11, there were only 2 standards that the NTP actually met. All the rest, they had at least 1 benchmark that they did not meet, leading to a partially met result. And so that means if it's partially met, that's a gap. And so we look back at the gap, what benchmark was not met, what was the reason, and what are the possible solutions for the NTP to meet that gap. And so these are just some of the benchmarks that were not met by the Philippine NTP. So for political engagement and buy-in, so the benchmark is that less than 50% of the budget should be covering the components of DRTB management, prevention, diagnosis, and care. It should be less than 50%. But for the Philippines, it's actually more than that. It's 75% that is covered by the Global Fund. So it's majority of the activities for DRTB are covered by the Global Fund, and therefore that benchmark is not met. Another example is advocacy and community, where the CSO should be involved in planning DRTB services at the national level, and the program should be offering ongoing support or programming for TB survivors after they have successfully completed the DRTB treatment. This was also unmet, basically because funding is not sufficient for our CSOs. And one of the considerations was to look at the possibility of social contracting by the local government units. So just to let you know that the Philippines is a very decentralized form of implementation at the moment. So DRTB services used to be centralized before when it started, and for a long time it was centralized, but now it has moved down to the periphery. That's why we are involving the local government units. I'll not go through each one, but for diagnostics and laboratory, stool testing is not yet being offered, and therefore the NTP thought they should prioritize that. Some points here, human resources and staffing. So there is lack of mentors. So now that we have moved down services of MDR-TB down to the periphery, there is a lack of mentors. And therefore, they're looking at ways how to expand the manpower that can mentor the peripheral facilities. DRTPT, I was surprised when I came to this conference that many countries have actually started implementing DRTB-TPT, but for us, it's not yet being introduced. Just some pictures to show you that the self-assessment tool was simply emailed to the recipients. And therefore, we did some validation meetings with the respondents just to clarify what they meant by their entries and to verify some of their answers. So that was national assessment. For the facility assessment, it's more of the gaps in the service delivery area that we focused on. So you see here the cascade of care, and we were able to gather, a long list of gaps based on the different aspects of the standard of care, but I'll not go into them one by one because this is a very long list. I just want to show you that all the aspects of the cascade of care were covered. They were discussed, the gaps and challenges, and some recommendations were provided. Okay, so the highlight of this whole activity was the stakeholders workshop that happened in November. And in that workshop, we had 3 group works. So the first one, considering that there was a long list of challenges that we gathered in the field and also at the national level, we needed to identify priority challenges because the list was simply too long. And so the TA needs, the corresponding TA needs were also too long. So the end product of that was a TA roadmap, which was a little bit refined. So there were some challenges that were similar. We just merged them together, or some TAs that could be provided together. Another workshop was about updating the stakeholders' institutional profile. So remember, I said that the stakeholder mapping was done by the NTP based on their knowledge of their partners, but this gave them an opportunity, the stakeholders, to update the profile, whether they're still doing these services, whether they're still working in this particular geographic area. So that actually, that updated list, the NTP can use as a reference when they engage partners. And part of this workshop B was also identification of the TA needs that these stakeholders can actually contribute. So they saw the needs, they saw the TA requirements, and they signified whether their expertise fits that particular TA need. And the last workshop was to have an overview review and enhance the draft TA roadmap. Some pictures to show you the facilitated discussion, because as I said, the group was quite large and diverse. And so we had to get an experienced facilitator. And our groupings were according to the cascade of care, like those who are involved in screening and testing were grouped together, etc. This one is, I'm sorry, but this is very raw, but this is considered very helpful by the NTP. This is the TA roadmap with commitment of support. So all the partners, so if you can see, every part of the cascade had a worksheet, and this worksheet was on screening and testing. And you can see here the gap, the proposed solution, and the proposed TA, or the TA need. And so here, these are individual stakeholders who were present in the stakeholders meeting. And so if they saw that their expertise can help this gap, then they put here a P, which means they are a partner that's willing to commit and they have funds for that. But if it's a C, they have that expertise, but they don't have funds for that at that time. So this was an extensive list with different worksheets. Oh, sorry. So summary of that stakeholders meeting, you can just imagine the number of TA needs that came up in the end. It was 138 TA needs covering different parts of the cascade. Like screening and testing had 40 TA needs, treatment 15, prevention 13, health system 70, total of 38. So the NTP, I'd like to say, was very pleased with this TA roadmap, although it still needed refinement because it's very raw. But focusing now on what they can do under the unit aid project, from that long list, they looked at which among the TA needs were DRTB focused. So from that, they were able to derive only 11 that had something to do with DRTB. And so in order to prioritize from this 12 TA needs, there was a quick survey that was done in that meeting, participated by all those who attended, and this was what came out. So this was prioritization of the DRTB needs. So if we get only $300,000 US, which among the TA needs should we prioritize for funding? So you can see that the highest was for IDOTS monitoring. These IDOTS are the peripheral health centers that are now delivering DRTB services. This is something to do with clinical monitoring and mentoring, especially for ADSM. So that was the top priority. The second was TPT for DRTB. And the third one was introduction of stool by expert. So this was the process, how the NTP came up with the 3 priority needs. Just to say that why we need stool expert, because our notification in children is quite small. There was a drop during the pandemic, and it seems it
I'd like to
hasn't
request, please concise your presentation, please.
second
Time
to
is
the last
short.
slide. Okay. And then, but some things have been done, and we need, the Philippines just needs technical assistance for the drafting of implementation policy and algorithm. Okay, for the DRTB TPT, you can see that there's been an increase from 2022 to 2024 in the utilization of TPT, but this is for DSTB. And we have nothing for DRTB. That's why we need to introduce this to the country. Our fluoroquinolone resistance is only 3 to 5, so not very difficult to identify who should be eligible for that. So in summary, I'd like to say that the stakeholders mapping allowed the NTP to have an updated reference of partners, what they do, and what they can contribute. And then the National Self-Assessment Tool guided the NTP to identify strengths and gaps in terms of benchmarks in TB care. Facility Self-Assessment Tool guided the facilities to identify strengths and gaps in the cascade of care in TB service delivery. And last but not least, these identified gaps guided the NTP and stakeholders to come up with a TA roadmap that will be used in the National TB Strategic Plan 2025 to 2030. Next steps, with the recent financial cuts, budget cuts, the NTP is discussing possible changes in the priorities. And we're asking for consideration for an extended timeline for project implementation. Thank you very much.
Thank you. Thank you, Mabel, for your comprehensive presentation. Now, if any question, I'd like to request our audience to ask her. Any questions for her? I think no questions about his comprehensive presentation. So now we will go for the short break. We'll go for the coffee break. I think it will be 5 minutes enough. 10 minutes, 10 minutes for the coffee break. Then we will again come into the room and we will do our home group works. After 2 to 3 presentations, then the session will be closed. Thank you. I'd like to invite you to join the coffee in the outside, distributed in the outside. Thank you. I'd like to request all the participants, please take your coffee and come inside. Our last topics is the group work. After that, we can finish our topics today. I like to everybody, please come inside.
Hello, I'm request Dr. Mansa, just please provide more explanation about the keywords for everybody clear. Yeah. Yes, please. Patricia, she's here.
Yep.
So among the materials that we share with you, so the last one of the material was the planning for the introduction of the novel sort of treatment regimen. So, and that's the tool that we are using today. Could you please check? Yeah. So that's the tool that we are using today. So we use the one for prevention, diagnostic, and the one we are using today is focusing on treatment. So, and it's the same process like what we have done for the past 2 days. We go through it and see where do we have our achievements, strengths, and where are the gaps. So, and each of the countries will have about 3 minutes to highlight the most important areas. Okay?
Okay.
So, and we can move to the country groups like what we have done. So I think that we can share the slide for the country groups. Thank you.
Thank you. Thank you. I'd like to request Mr. Vinit Bhatia and Agnes Gabrat to conduct the group works. Please. I'd like to request Mr. Vinit Bhatia. I think the format is already supplied to you, and you know already you have done this type of group works. If it is completed, you can send to the email. Please. Yeah. Regarding group work, if any question, you can ask our Honorable Mr. Vinit Bhatia and Gabriel, Agnes.
Okay, so we have the slide for the group work. So, and you see the countries and the stakeholders supporting them. So, and the CSOs into the different group. Please, we can join to the different countries that we have. Dr. Nishal, which group is joining?
Sorry, I have to join my.
Oh, India is missing. Okay, India is joining which country? Laos. Okay, India is joining Laos. Okay, so, and yeah, we know the countries that we worked with yesterday, so, and we can go to those countries. Thank you very much.
You will get only 15 minutes for this group work. It is now 4:50. We will start our presentation from 4:15. From 4:15, we will start our presentations of group work. most significant action points. I think everybody is already completed their group works. Every country should 3 to 5 significant action points will be discussed. I think we have already completed our group works. Yeah. So from our side, I like to request Nepal 3 to 5 points you may discuss. Yeah. Okay. I like to request Nepal participants for discuss about 3 to 5 points.
Thank you for giving me time at the first. So definitely, I will start from the political commitment. And yeah, there is a political commitment in my country for the DRTB by all the levels, even including ministry, prime ministers, everyone. So 80% budget is available for management of DRTB. We have asked for 50% only. Yes, new shorter all overall DRTB regiments, BPAL is implemented throughout the country. We have DRTB National Working Group, but does not meet regularly, so partially meet, we can say. Coordination of advocacy committee engagement activities at national and sub-national level. For that, formal coordination mechanism between NTP civil society exists, mainly in TB-free local level initiations. NTP-led public awareness campaign are there. Dialogues and collaborations with communities affected by DRTB to address stigma, access to service is there. However, it is limited, not everywhere maybe. Civil society groups are involved in planning DRTB sections at national level. Yeah, of course, it's meet 100%. TB survivors or community representatives sometimes participate in DRTB treatment technical groups also as an inviting member. For structure on drug forecasting, procurement, supply management, yes, there is forecasting system for the DRTB drugs and it is well implemented also. Forecasting, procurement, supply of drugs are efficient to make no stock out. Yes, there is no stock out, but we do not have sometimes buffer stock, but stock out is not there. So procurement of new TB medicines is already initiated. Yeah, we are procuring for last 2 years. We do not have pediatric TB cases. That's why we have no stock of the pediatric TB medicines because no cases. And in the past we have procured for 1 or 2 patients, but it has expired. So that's why we are not procuring for pediatric cases. And for ancillary drugs, yes, ancillary drug is available everywhere, all the DRTB treatment centers. For package of for aeration, so not we have taken the core package for the aerations. So that was from my side, I think. Next, Cambodia. So
thank you. I will be presenting. Sure. So for Indonesia, the first benchmark on political commitment on the RTB or math, just some highlights on this. Previously, the BPAL base regimen was planned to implement it in early 2025, but due to the strong commitment of our health ministry, we implemented the BPAL base regimen in 2023 in July. Currently, the trend for BPAL usage increased significantly in 2024 in January from only 17%. By the end of the year, we have 80%, 81% patient on BPAL-based regimen, and the 9th-month regimen decreased from 63% to 17%, and ITR reduced from 21% to only 2% in Indonesia. And as February this year, we have 5,500 patients on BPL-based regimen treatment in Indonesia. And for benchmark 2, OMAT, here the highlights is the collaboration for the community on stigma reduction and access to care. Also, advocacy for the RTB efforts is mainly led by the STPI and TB survivor in Indonesia. We have 26 DRTB survivor organization that involving in this. And then on benchmark 3, OWRMET, all the drug forecasting and procurement managed by NTP and the stock level sufficient for all the RTB regimens, including pediatric formulation and ancillary drugs. For benchmark 4, partially met. This is for the capacity building. In Indonesia, we have e-learning platform called Pelataran Sehat, hosted by the MOH. It offers online training and webinars free of charge. And then the healthcare workers can access this, and they have credits, completion credits when they complete the webinars or the training. However, there's still a gap in the implementation of ADSM training because we have training for the provincial level team. However, on the district level, it's very not every district already trained for the ADSM because this is lives from the province team. And for benchmark 5, OWRMET, supportive service care. Benchmark 6, it's partially met. It's on ADSM guidelines. We have a active pharmacovigilance committee at the national level. However, challenges remain on the submission of safety report to the SITB. SITB is a Indonesian TB information system. It's electronic. However, the submission for the safety report beyond the required time frames on our guidelines. So currently, the NTP have provided local TA on ADSM recording and reporting, and also with YKI, with the United funding, we have piloted project in selected district to encourage this ADSM implementation, including incorporate MITA. MITA is a monthly interim cohort analysis to incorporate the ADSM monitoring and data validation on monthly MITA. On benchmark 6, the quality data, it's partially met because we're still on the transition for the electronic health record managed by the DTO or Digital Transformation Office. And we will be having this system called Satu Sehat. And this will be e-health report, not just for TB, but for all health related in Indonesia. The last one, benchmark 8, OWRMET. This is for the promote a person and family center approach. For Indonesia, the TB program covers the drugs and the national health insurance or global fund donors cover in examination and treatment costs. However, there is some necessary cost that will be out of pocket for patient. This is for like the administrative fees in some hospitals, but not all. I think that's all from us. Thank you.
Yes, thank you. What is next?
Thank you. This is from Bangladesh side, Group 1. And at the first benchmark, there is evidence of political commitment for management, prevention, and care of drug-resistant TB. Here, 50% budget is available for all components of drug-resistant TB management, prevention, diagnosis, and care. Here, our present situation is we have the national procurement for the tuberculosis drugs, and also we supported by Global Fund. And so this is this benchmark is made, and in case of ADSM, there is a training and monitoring plan for human resource capacity building for the management and prevention and care of DRTB. Here, the training on ADSM and AE detection and recording reporting has been conducted for the all health workers at secondary and primary level. Here, our active drug safety monitoring and management is in case of training. We have a many training program which are funded by USAID. And now USAID suspend their fund. So in here, our national NTP produce some training program for the government doctors. And in case of in this case, we need funding from the donors as well, like Global Fund, KNCB, and others. And now the current situation, our national tuberculosis program trained the government doctors, government lab technologists, and the health workers for this purpose. And we have to develop a good module training program for ADSM, and we are working on it. And there is ADSM guideline or included in National Clinical Guide with sufficient guidance on monitoring management of AS. Here, the clinician, the benchmark is clinicians are trained to conduct routine assessment for AS. Here, our NTP already working with it, and we are trying to fulfill our agreed actions with the supported by our civil society, donors, and others. Thank you all.
Okay, next volunteer, Benchi, Viet Thailand.
Thank you. For Thailand, I pick up some points for sharing. For the political commitment, in Thailand, our budget for the RTB and diagnosis, treatment, and prevention will be funded by domestic budget starting from this October forward. So I think the budget is no problem now. For the drug forecasting and procurement, in this February, all the RTB drugs are put in the national Thai, in the list of the essential drugs. So after putting in the national list, then it will be procured by the Thai government pharmaceutical organization. And so the forecasting and will be managed by them. So the forecasting and stocking, everything will be processed by the Thai GPO. They will have their own system. We launched the guideline for programmatic management for the RTB since last year, and now we do the training and monitoring by the NTP and also the DRTB expert committee together from January 1, March 1, and will be another one on June, and also we are doing like Indonesia, the online course as well. For the quality data, now all public hospitals use electronic health record already, and also it includes public primary health care center as well. So now they all linked to the TB surveillance system already. And also we use the National TB Information Program to be the central platform for reporting lab online, including the RTB. So it's in real-time reporting. And another online platform for ADSM will be reported by pharmacists from all hospitals. Thank you.
Thank you, Thailand. Next. Vietnam. Okay, PNG first.
Okay, good afternoon. I'll be quick because it's afternoon for PNGs. We are sleeping now, so. So for the, firstly, we are proud to say our government is taking full charge of our DR initiation in the country. So they are paying for our drugs and doing things for the DR. So that's a bonus for us. And where the gaps are, the Global Fund and other partners are supporting us. So for the decentralization of the DR, not yet to the local or the primary health facilities. It's just in our PMDT sites, programmatic management, that is in the provincial hospitals. So we haven't decentralized it down yet. In terms of electronic reporting, for the TB program, yes, we have electronic reporting in place. However, we need to incorporate ADSM and all the others. That's something that for the ADSM, we have a system in place, but it's still paper-based reporting. So that's something that we will work on. For the testing, initially for Papua New Guinea, I was always proud to say that we had GX alert and we had all the information. However, due to cost now, it was not connected. We need to reconnect it to at least see good data from the gene experts. And our last point is for the public-private, for the TB program. For the public, it's all free of charge, like medicine and everything, but it's just a private that we need to work together to see how best are we going to support the private sector as well. For now, they are paying for the services, TB services. Thank you.
Okay, Vietnam.
Which country?
Vietnam.
Okay. India, I think.
India.
Thank you. I'll again be quick. For benchmark number 1 for political commitment, as I said in the morning, I mean, it is evident from the fact that 91% of the total program budget is domestic funding. So that is the, and 50% of that is attributed to the DRTB services. So this benchmark is met when we tick in all the boxes. The benchmark 2, where the coordination and advocacy and community engagement, it is said that describe the mechanism. It exists because in 2017, 25 NSP, I mean, we have spelled out the national, state and district level TB forums where the civil society is at the platform of policy making. So these meetings are regularly happening, and in our expert groups also, National Technical Expert Group, the TB survivors are there, and the public awareness activities. Again, I would just like to highlight the highest political commitment. Just we have concluded on this World TB Day, where the 100-day campaign in 455 high burden districts. Active screening was done in asymptomatic vulnerables in addition to the symptomatic. And just to give you an example, that on 7th of December, this was launched. On 18th December, Honorable Minister of Health, in a running parliament session, sensitized more than 250 member parliament. One member parliament is, representing 2 to 3 million people in their constituencies, and they participated in these 100-day campaigns. So advocacy at each and every level, in addition to the elected representative across the party lines, 22 different line ministries. The third benchmark, where established structure and drug forecasting, yes, we have met this benchmark. I have written in the fourth benchmark where there is a training and monitoring mechanism, which is partially met, because we have to be honest with ourselves, because we tick all the boxes, but the last one, where community-based civil society organization received training, treatment, literacy, and DRTB diagnosis. That's the area where we have to work on. Otherwise, our training, the training cascade of the latest evidence, which is generated, latest guideline, is up to the mark. But for the last one, where the kind of training we have to give to the last worker is an area we want to work. Same goes for national treatment guideline, benchmark 5, because again, we have all the collaboratory frameworks for management of common comorbidities, clinical monitoring tests, and all the other things, except community-based or civil society organization involved in delivery or DRTB services. That's one area where that's why we have marked it partially met. For the sixth benchmark, we have met each of the subgroups which were required for quality data available and used at various levels. But for the second one, which says TB testing laboratory transmit results electronically to clinicians within 48 hours, it is differential, it is improving, but you can't say for all the states, all the districts and all the, sub-district level. That's why, again, just to be honest to ourselves, to improve the quality of services. Otherwise, we have a case-based electronic, system in which the treatment outcomes are all automatically are generated. Reports on treatment coverage can be automatically generated. Reports on AESI can be automatically generated. Just because we don't meet that more than 80% of sample received, the results reach within 48 hours. That's what we have to improve the quality. And the last one, the MTP partners, again, education material for DRTB and importers are available to use, and the national policy guidelines are all there. So we have to work on benchmark 7, 5, and 4. So that's the feedback. Thank you.
In Mongolian DRTB situation, we have 3 gaps in real situation. First, we already adopted and implemented WHO new policies and new and short regime for TB guideline and implemented, but short regimes coverage is still very low because Mongolian most DRTB cases reported relapse cases. Then TB doctors prefer to choose 9-month regimes. We suggested and explained short 6 months PIPAL regimen, but last year we planned to enroll 60% of PIPAL regimen, but last year this is just reached to 20%. Then we are planning to organize some trainings and advocacy activities for this year. And yesterday also we are discussing with TB Alliance for this topic of training courses. I hope we will be organized this year for a very active training course. Then next challenge, currently 70% of funding, DRTB drugs funding from the Global Fund, only 30% of funding from the government, because we can register only 5 drugs for government drugs list. Then we need to register more than 15 drugs. If we can register all DRTB drugs, then it's coming possible to coverage government funding. Now we started to progress for registration process. Finally, our registration of DRTB adverse event is not enough. Our country's TB program, we are using TB's electronic system. Then we reported and registered all things, but DRTB adverse events registration process is not enough. Then we contracted with IT company, and we can include this tool, include our TB system. Then we are still planning to some training course for this part. Also, DRTB cases themselves by the DRTB side effects medicines. It's very catastrophic cost for them. Then we also planning to include our health insurance for these adverse event medicines. Thank you.
No, good afternoon. From Cambodia, for the political commitment, we have a high-level meeting and also the commitment from the government to support the national program, and also for the drug, like we have that the government fully support the procurement of the first line drug, and the Global Fund support the second line drug, include the TPT, and also join the cooperate with that. So let's say from the political commitment for drug resistance, our country, we have the a good collaboration, have good plan for that. And then for the coordination advocacy, we have the CSO. We have the local NGO we call CHC. They are actively participate to do to try to provide the treatment at the community. They join, and then they have to address the problem of the patient and even the close contact with the MDR. For the drug, the structure, the forecasting, we have the QuantTB that was trained by the GDF, and then we forecast this one and make sure that the drug are the assured for the coming year. And then for the training monitoring at the community, maybe what I already said, we have the job aid for the local community when they go to community, the start of treatment, and also most of our MDR case is not hospitalized. They are able for those who have just a start enrollment assessment baseline, and then they are able to be be discharged to community, and then we have follow up. And with this regard, I just to mention to tell you that recently we have the problem with USAID. The one local NGO was get stuck because the fund from that is my concern for that. This point. And also for the guideline, we have a very latest update to what the WHO recommendation. And then for ADSM, we have the work train that, but still paper-based. I think my man go to training for last time, but a bit long, but we are doing that. But it's not electronic yet. It's still paper-based. And data quality, we use this TBMS, include actually TBMS at the beginning, we start with MDR-TB, but now become the nationwide drug accessibility. So we have the system in place to monitor and to follow up the treatment outcome there. And the last point about the partner education, we have the some material, but as you may know, for educational material is not widely available. The last 10 years, the Global Fund not allow us to to produce to develop the education, but the staff, the the community volunteer or that the trained community, they provide verbal education to the patient and the household member. So it is all from Cambodia. And also Cambodia is not so many cases. We have a year around 100, 120. It's not so many. And just last 2 years to 2022 or 22 or 23, 24, we have a bit the resistant and include the mono resistant due to we have the 10 color. So we have mono resistant INA there. Yeah. So it's all, but it's a too small number. Okay. Thank you. Vietnam. You.
Yeah. Good afternoon, everybody. Yeah. For Vietnam, almost all the standards are partially met. First, for the evidence of the political commitment for management, prevention, and care for DRTB, for the political endorsement, even now we have all the guidelines, but not sure for the budget. At the currently, 50% of budget is available and covered by Global Fund and other resources. But in this day, we are not sure about the next period. And this period will be ending in 2026 with the Global Fund. We are not sure in this day. Next, the coordination on advocacy and community engagement activities at the national and subnational levels. Yes, we have the formal coordination mechanism between the NTP and civil society. CSO exists, including the CCM subgroup, as our colleagues presented yesterday. However, the dialogue and collaboration with community affected by DRTB and civil society groups, involvement of TB survivors are not met yet, just partially met. The established structure on drug forecasting and procurement and supply management, we have the tool and the mechanism to manage this, but still we have so many difficulties for second-line drug management. Even especially for procurement for new drugs, even we already order, but sometimes delay in procurement, and we still have a encounter with stock outs and changing regimen a lot. So still a big problem to our program. There are training and monitoring plan for human resources capacity building for management prevention of DRTB care. Actually, the guidelines available, training plan available, training tool available, everything available, except budget. So now we can only provide training for a focal person of the provincial level only, and not go to the district or communal level. And in this day, we have a big change in our health system, reform health system, and all other administration system in the whole country. So there will be no more district level, and we have to merge province to province or something. So there will be very big change in this year. So we are not sure about what comes to the next year, how the function of the health facility at the peripheral level, and what the staff when we change or turn over everything. So yes, very difficult this day. National treatment guideline included latest WHO recommendation, including a supportive service. Yes, now initiation of DRTB care has been decentralized to the peripheral level. But again, training for staff is not available. And also the laboratory tests for monitoring adverse event is not well equipped at all the peripheral health facility. And for the ADSM system, tool is available. But now we still have a lack of reporting, accurate reporting and recording in timely manner. And causality assessment is not yet implemented. Quality of data available and used at various levels. Yes, now we think this is, we have the VTMS system now is quite well functioning. But again, in the next future, when the recording and reporting system of WHO changes, definition changes, health system changes in Vietnam, we need to adapt again. So yeah, there could be challenges in the next period as well. Partners deploy specific initiative to promote person and family-centered approach. We think that now this is not well organized in our country. Educational material is not available yet, and lack of the educational material, like and the campaign, TB campaign for DRTB and activity to promote people with TB and involvement of public health sector is not well functioning at this time. And also the stigmatization prevention in among DRTB patients is not so good at this time. Yes, that's all for Vietnam. So we think currently still challenges and will be more challenges in the next few years, in the next period. Thank you.
Maybe last is Laos. Okay, this as you know, this maybe Laos is a really small number of the MDR and RR cases. So in terms of political commitment, this is we have like a CDC is a fully agreed to program. It's a fully support from the government, from CDC side. But of course, this for funding, in terms of funding, this we have fully support from one fund. There's no any from government. Again, for that's maybe next grant as a Vietnam team, this we don't know next few years. We don't know this Carbon Fund still support or not. And in terms of coordinating committee, is not yet set up, but it's still program based. And again, in terms of capacity building, that's we have like annually training for all health TB manager is from central, provincial, and district level. It's all the country. And again, this is for the system that we develop via the HS2. We say is TB tracker to capture that's MDR is part of the like a normal system in the TB tracker to be a surveillance system. Anyway, for CSO, that we have not yet it's a concrete performance from CSO because it's you know that's it allows we have just 2 CSO working for TB program. That's at capacity building from CSO. We have to do more in terms of capacity building for them, and maybe in the future we have to it could be talking with them. Yes, thank you.
Thank you. From the presentations of the Laos, I think today's all the activities is finished. I think we have all day lots of presentations and group works is done. Today's activities is completed. Now I'd like to request Manasa, Mr. Manasa, anything you have to say to about the tomorrow activities? Nothing. Yeah. Thank you.
Thank you very much. I would like to request everyone to all countries to send these your filled in tool to share it with Mansa. Of course, it's for your own use, but we also would like to see what we have and maybe make a little report out of it with your permission. Yeah. And sorry. Yeah, send to Mansa, not to me, all to Mansa. And there's one more request. So yesterday we had a discussion on this morning, we had a discussion on the nutrition, but there was only the guidance, these topics presented by Annabelle, but this was not really in a tool. But can you please share with Mansa the 3 to 5 top actions which you intended to start doing? So that is the second one. And the third one I would like to remind you is on the first day, we did not put the use of TB infection tests in that part of the tool, but it was also not in the laboratory part. That was an omission from our side when we split the tool. So can you also please put an activity or a line on what you're going to do if you need to do something on TB infection tests implementation? So 3 things. Okay, Mansa, back to Mansa.
Yeah, thanks, Agnes. And just to add on that, for those of you, if you don't have my email, please send it to then Vinit or Queen, then they will forward it to me. Yes, so, and yeah, yesterday we sent a link, a Dropbox link with the materials we uploaded day 1 and day 2, but today I got some information that you cannot access the link. So we are checking what's the problem. So, and I will send another link. Yeah, and Link has sent an email also regarding the survey for the long-acting injectables. Please, if you can also complete that one. So, and the last announcement is about the appointment card for airport pickup. Please, those of you who did not reach to our team, please try and reach to them so that they can make all the arrangements on time. Okay.
Thank you. I just wanted to, if with Chair's permission, to have a little teaser for tomorrow. Is that, can I go? Okay. So I think it's been a very busy week. We realize it's day 4. You've done a lot of work. It's very clear. And so tomorrow is a little change of focus and having a look into the future. And it's going to be very interactive. So we'll have a little scenes setting in the morning, but then we will be breaking out into small groups. And for some of you who have felt like haven't left this room, some of the groups will even leave the room for the breakout room. So you get to see a new room in this hotel. But I think I hope that we can keep your enthusiasm for just a half day more. And really get sort of thinking not just on where we are, but where we could be, and be inspirational and hopeful. So we're nearly there, but please do come tomorrow with the same level of enthusiasm and engagement that you've had so far. Thank you.
Thank you for this announcement. Ended today's all activities. Tomorrow we will meet again. Until that, goodbye. Goodbye, everybody.